On behalf of Martha Howard, your CSEP president, and the executive committee, and the education committee, I present to you this course worth 7.5 continuing education credits. What I'd like to do is go right to our first speaker, and then I'll do a general introduction of this meeting after her talk. So I'd like to introduce Erin Walsh, MD. She's former co-director of the pediatric ophthalmology at the New York Eye and Ear Infirmary, and she's currently faculty at the Yale Department of Ophthalmology. She's received several awards, including the COPE Health Solutions Distinguished Alumnus Award in 2015. She's been at Yale for a short time, and we welcome her into our physician community. We hope that you find her talk useful and interesting. And I'm going to turn this over to Erin now. Welcome, Dr. Walsh.
Hi, good morning, everybody. And thank you so much for accommodating me so early in the morning. I hope to sort of enlighten you on some pediatric trauma, which is a very interesting topic. Let's see if I can get this shared for you here. Okay. And you guys, just to confirm, you guys are able to see that?
Yes.
Okay, let me make sure that I can forward. There we go. Okay, good. Excellent. So just to declare, I have no conflicts of interest or financial disclosures to report this morning. Okay, and then we'll discuss some learning objectives. Let's see here. So first, we'll talk a little bit about epidemiology of ocular injuries, some of the normal eye anatomy, and we'll go through some case series on injuries from the front part of the eye to the back part of the eye. And then discuss how this kind of can affect a childhood ocular disease process called amblyopia. And then finally, we'll wrap up and discuss some preventative measures. So moving quickly into the epidemiology of pediatric eye injury. There's an estimated 2.4 million eye injuries that occurred in the US alone. Many of those, 40,000 of those, will cause permanent vision loss. In a database in the year 2000, it even showed that there were 750 or 7,500 hospitalizations and resulted in close to $90 million worth of inpatient charges based on just pediatric eye injury. 40% of these injuries occurred in children less than 17 years old. So most of them occurred slightly over half in older children. And in most studies that we've seen, 60% of them occurred during sports injuries, which is why they probably occur in older children. And obviously it is skewed more towards boys than girls, likely because they tend to be in more aggressive sporting activities. And many of them do tend to occur more at home too. Interestingly, it's the second most leading cause of monocular vision loss in children, amblyopia being the first as an all-comer. It's the second most leading cause for eye surgery in children, and special consideration should be given to children under the age of 5, primarily due to the effects of amblyopia. So moving into the eye anatomy, just briefly, first you can see here when we start an exam or you describe an exam of any patient, whether it be an adult or a child, you basically start from the outside and move inward. So you start even describing sort of facial features, moving to the skin, moving then to eyelashes, eyelids, and then you move sort of posteriorly and you actually get into the structures of the eyeball, which would include specifically here, the cornea, which is the windshield of the eye, the iris. Moving further, you can see here, these are common areas of that can sustain ocular injury, I should say. And then here you can see here are the recti muscles of the eye, the extraocular muscles. In particular, the recti tend to be vertically or horizontally oriented, and then the oblique muscles, which involve torsional movement of the eyes, tend to be oriented under or below each of the vertical recti muscle. In particular, the superior oblique muscle in adults tends to be the most damaged muscle in ocular trauma. Additionally, we always look at orbital structures too here. As you can see, there are several bones that are involved in the orbit, and this becomes important when large projectiles hit the face and affect the eye, and sometimes need to be repaired. Additionally, the back part of the eye, just to review some of the anatomy, here you can see this is the optic nerve with the blood vessels coming out, and here is retinal structures here. You can see the macula and the fovea, which obviously, if sustained trauma and long-standing damage, can affect vision long-term. So we'll go through some cases, essentially just describing some of the common injuries in pediatric cases. Some of these are my own cases, some of these are some of my colleagues' cases, but I think, especially in a trauma center like Yale, where we see a fair amount of trauma, many of these will ring a lot of bells. So this is case one. This is a 12-month-old female. She was learning how to walk when she fell down in the kitchen. And as you can see here, she has on her right eye a laceration of her eyelid. However, if you extend this here, just as another example, this may not be this child. You can see here, this is a much more extensive eyelid laceration that may be involving other specific structures of the eyelid. So what is this? Whoops, sorry, I went too fast. What is this? Is lid laceration. So marginal eyelid lacerations here that involve the eyelid margin should be required special repair. Typically, when we see these children that come in, we'll repair them immediately in the OR setting. But if you see this and you're not in a setting of a hospital, for example, like a parent, you would place some antibiotic ointment on it and then obviously return to the ER. Additionally, if it's cannulicular, which means that it's medial here and involves the tear drainage apparatus, this does require urgent repair because you could have long-lasting tear drainage issues, which then could affect, in turn, the anterior surface of the eye and have long-standing effects from that. So this is the second case, and if anybody has questions, at the end, if we have some time, I'm happy to answer a few too. But I know we need to sort of move on. So this is the second case. This is a 13-year-old male. He was playing soccer and he was hit in the face with the ball. As you can see here, he's got some on his right side again. He's got some periorbital edema, some ecchymosis, and on a CT radiograph, he's got some fracturing here nasally of his orbital bones. Additionally, so what is this? This is an orbital floor fracture, very common in any sort of high-speed projectile that hits the face. And you would typically you would allow this fracture to heal in 1 to 2 weeks before you would consider any surgery. Why would you consider surgery? It would be secondary to this example, where you can see here, this child is actually looking up. So his left eye is moving freely up. And you can see here that he's got some restriction of elevation of his right eye. And if you move in closely here, you can see on the radiograph that he's got an orbital floor fracture and his muscle has been trapped within that fracture. And so this would require more urgent surgery for this. Sometimes, depending on case-by-case basis, you can wait for some of the swelling to go in or to go down. Essentially too, if it happens, I guess, nasally or medially, and you have to pay special attention to the vital signs of a child or an adult. And if you notice a classic sign called the ocular cardiac reflex, where the heart rate has decreased, then this is actually emergent surgery to release this muscle. On the third case, this is an 8-year-old male. We see this commonly. He was helping dad build a wooden fence, and a piece of the wood came off and whacked him in the eye. And this is very common in adults. That happens spontaneously, but in children, it typically happens with trauma. So here you can see this is the subconjunctival hemorrhage, so the skin that covers the white part of the eye, which is heavily vascularized and can bleed easily under traumatic conditions. Here you can see here superiorly that this has some nice clearing, and the anterior chamber of the eye looks nice and formed. And so our concern for any sort of more traumatic injury is a little bit lower. These will typically resolve on their own and without any sort of intervention. However, in any setting in trauma where you can see here on the right-hand side that the subconjunctival hemorrhage is involving the entire, what we call 360 degrees of the conjunctiva. Here is some clotting here. We'd be a little bit more suspicious of an open globe or trauma that actually opened the inside of the sclera. So if you are unable to reassure yourself or the patient that the globe has not been compromised, many times this would require special exploration under the OR, and you actually have to remove part of the conjunctiva piece by piece and gently explore all aspects of the eye. Of note, when you see this too, the sclera, or the white part of the eye, is the thinnest, typically right at the limbus, where the cornea and the white part of the eye meet, and behind the extraocular muscles. So it's very important to gently explore all aspects of that sort of eye anatomy. And this is a 10-year-old female who was poked in the eye this morning. She has the worst pain she's ever felt. As you can see here on the surface of the eye, there are many layers to the cornea, 5 to 6, it's debatable now, but on the surface of the eye, you can see that there's sort of this heaped up area here, which is the corneal epithelium, which is the protective layer of the cornea. Now, why is she in the worst pain ever? Because right under the epithelium is a whole bunch of nerve endings, which are there for our own protection to tell us that our eye has been injured. And as you can see here under fluorescein, that this area has stained, which does reveal that the epithelium has been compromised. Because the cornea has no vascularization to it, it's a nidus, or a nidus for infection. So we don't have any immune system immediately that can fight off any sort of pathogens, in particular here, bacteria or fungus, depending on what injured the eye. And in this case, because she was poked in the eye, say if it were a fingernail, obviously this is can be a dirty tissue, and would be concerned for infection. So when you see an abrasion, it's really important actually to be aggressive immediately and treat with antibiotic ointment as prophylaxis. In particular too, tree branches are of concern too, as fungus can also infiltrate into the cornea. So it's very somewhat emergent to make sure that we allow for this to heal. Thankfully, the corneal epithelium can heal rather quickly, usually within 72 hours. Most of these defects are closed, but it does require daily follow-up for these patients. All right. So this is a 15-year-old male. He was sawing in metal shop at a school 3 days ago. He started to feel some pain, and the pain hasn't gone away yet. In fact, it's getting a little bit worse. And as you can see here, There's a little foreign body here. We don't know of which type, but likely since he was metal shock, it's likely a piece of metal. And typically these will cause rust rings very quickly and over time cause pain. So what do we do? These are have to be removed, obviously, because A, they can cause infection, and B, they can cause scarring with these rust rings. And so these are somewhat satisfying to take out. You can try, if the epithelium has not grown back over the foreign body, to remove it with a Q-tip, or you can, there's little burrs that we have that spin at a rapid rate, and you can actually kind of flick them off. After that, because we are going to induce our own corneal abrasion, we will then again give antibiotic prophylaxis on the surface of the eye until the abrasion has been healed. Additionally, you always want to remind your patients and parents that the eye protection is the best course of prevention for this type of injury. Okay, so we haven't seen this a lot because we haven't had any snow this year, but this is a 12-year-old male, and he was hit in the eye with a snowball, and now he complains of a lot of pain and decreased vision. And this is your classic hyphema, where the blood vessels in the iris and the uvea have been sheared open and have bled into the eye. This is important too, that you obviously, if there's any sort of blood inside the eye, especially in a pediatric patient, you want to make sure it's not an open globe. And in particular, the pressure in the eye becomes a really important tool in managing patients with hyphema. You will need lots of steroids, cycloplegic eye drops, which actually stabilize the blood barrier between the vessels in the eye. And these children a lot of time actually need admission to the hospital, especially in younger children who have, who are a little bit squirmy and have difficulty sitting still, because you have to be on strict bed rest. And in fact, we even tell patients not to read due to the saccadic eye movements. And then we have to prepare for the event of an emergent glaucoma procedure. Typically, because these patients can have secondary glaucoma that can happen emergently. So they will get sickle prep to make sure that they can tolerate Tylenol, or excuse me, Diamox. Excuse me, just 1 second. I'm sorry. I happen to be at home. Additionally, these patients will require eye shields because as you want to prevent any sort of trauma back to the eye. And if these patients have glaucoma emergency, they may need an anterior chamber washout in the OR. Okay, moving on to case number 7. Let's see here. We have a few more to go. So, so case number 7, this is a 10-year-old male who was hit in the eye while playing baseball. So this is a very interesting patient, and he typically happens a little bit later while after a patient has been hit in the eye. So he was, instead of a snowball, he was hit in the eye with a baseball. And as you can see here, this is the lens of the eye. And you can see a classic stellate pattern of the lens becoming opaque, and when the trauma of the baseball hit the eye, it causes this pattern. So in any case, this was a 10-year-old male. He was hit in the eye while playing baseball. As you can see here, he's got some opacification of his lens and this beautiful stellate pattern, which indicates that it was a traumatic cataract. Sometimes too, you can see here essentially when the iris also hits the lens of the eye, you can see some very nice, beautiful pigmentation, which does indicate trauma. So importantly here, a lot of times you won't have a view to the back part of the eye. So you'll need to do what we call a B scan, which all of you know is an ultrasound, so you can see the back structures of the eye. And you'll want to make sure that because this was such a high-speed projectile, that the retina was not affected and not detached, which obviously would change your surgical management. In children who are of amblyopic age, this will need urgent removal because it can affect vision permanently, just as when we have babies who were born with cataracts, it requires surgery at a very young age. And in this case too, if we're removing this lens, then we will consider having kind of a multidisciplinary team approach to this, because as with any trauma, there's a risk that this lens was also sort of weakened by the trauma and can fall to the back of the eye. So our retina service will be hopefully handy with us when we're doing this case. Okay, and this is a common but commonly devastating injury. This is a 2-year-old female. She was found in the bathroom crying with a bottle of Clorox cleanup. So this is typical to a chemical injury of the eye and the cornea. And as you can see here, the epithelium has been essentially melted off the surface of the eye, and it's already starting to cause opacification. Important to note too that that in these types of injuries, you want to remember that it's just not the cornea that's affected. Right next to this junction here at the limbus, there are some very important stem cells who also can be affected, and in long term, if they have been damaged by the chemical, they can cause essentially almost like a death to the eye. And as you can see here, the eye just cannot heal properly, and the cornea can't re-epithelialize, and it can cause profound devastation to the ocular surface and vision of the eye. So how do you treat this? It's really important. I'll talk a little bit about this injury. So you want to immediately irrigate. Obviously saline is best, but even at home, we likely don't have saline, so water is the best thing. Important to note that it really depends on what type of chemical was injuring the surface of the eye. So typically you'll want to know if it was a base versus an acid. And basic types of chemicals, which include lye, cement, plaster, ammonia, fireworks, which is common in children. These can be rather devastating because they actually penetrate the eye and essentially can melt the surface of the eye and the stroma. Where acids can be certainly devastating, they denature proteins and they can cause a layer, almost like a protective layer, because they're precipitating proteins out. So they tend to be not as devastating as basic types of chemical injuries. Some examples of acids, which include battery acid, pool cleaners, and vinegar. It's very important also that you use a Q-tip and you try to sweep out any precipitates that have happened under the eyelids. Then once you get to the ER, because this is a severe ocular injury, the ER team will then measure what type, whether they will confirm whether it's an acid or a base, and they will want to continually check to make sure that the surface of the eye has been neutralized. And these are common in kiddos. Obviously, there have been, I think, several legal cases in terms of like Tide Pods being squirted to the eyes, and then obviously a lot of the chemical cleaners that we use that's right at kids level when they open the cabinet doors. So in case 9, this was a 4-year-old female who was poked into the eye with a pencil at school. her frantic mother rushes her to the emergency room, and mom and the patient are both screaming. And as you can see here, this is a full thickness corneal laceration. As you can see here, the iris contents have extruded out of the eye. And I apologize for the gory pictures at 8 o'clock this morning, but this is a ruptured globe. I've been alluding to this several times. As you can see, there's a defect on the front surface of the eye. And this is obviously an ocular emergency, and you want to actually manipulate the eye as little as possible, even tape a cup over the eye so the child doesn't rub the eye, and essentially stop feeding them. You'll give them antibiotics, a tetanus shot. We will even give patients antiemetics to make sure that they don't Valsalva and try to extrude contents out of the eye. And this goes to the OR emergently. This is not a picture of my patient. However, I think probably within the first week of me joining Yale, we had one of these. So it's more common than you think, and a scary situation for the parents, and can commonly happen in a school setting. A few more cases to go. We're just kind of moving to the back portion of the eye here. So this is an 18-year-old male. He went to college. He went to a college football game. A fight broke out, and he was punched in the eye by an angry person. Maybe because he lost the game, I'm not sure. But as you can see here, because of the punch, this caused a kind of an area of retinal whitening here, obviously some hemorrhaging within out of the optic nerve and the fundus. And this is common. And the reason why I wanted to bring this up, especially in teenagers and older adolescents, is that this is what we call commotio. So this is sort of what I liken to a retinal bruising. So this is whitening from shearing forces, particularly of the outer segments of the photoreceptors, and then subsequent swelling of the RPE. And so this is very common also in any sort of blunt trauma to the head, and car accidents, for example. So anytime, that there is any sort of high-speed injury to the face or facial structures, you always want to do a dilated exam, which is why we get called so often for any sort of facial trauma, because you can actually see this without any other signs of trauma, because it is thought to be a contra coup injury. And a lot of times, if it doesn't involve the fovea, it can look pretty bad and the vision can actually be normal. So we always look for this. You certainly want to rule out any sort of other retinal tearing or injury to the retina. And this typically will resolve over time on its own. So you want to reassure the patient. But this can give you an indication of how severe the injury was. And we're just finishing up here. We're getting close to being towards the end. So this is an 18-month-old here. He presented to the pediatric ophthalmologist after the parents noticed that his right eye started crossing inward. And then you see here on dilated exam that he has a large retinal hemorrhage here, a boat-shaped hemorrhage that is starting to extrude into the vitreous, which is likely affecting his vision and why he is crossing in. So what is this? This is pretty simple. It's a retinal hemorrhage in a child. It doesn't have a fancy name to it. However, I bring this up because this is a really important topic that unfortunately is a part of pediatric ophthalmology, as well as our adopted retinal specialists. So this is basically, if you see this and the parents don't even report trauma, this is trauma until proven otherwise. So in children, the vitreous is very gooey, very gummy, and any sort of hemorrhaging doesn't necessarily happen spontaneously. So this has to be worked up, and we're mandated to work this up. So the patient, if you see this, you would want to admit them to the hospital, and you'd want to run a huge workup, a head CT, skeletal survey, you'd contact the primary medical doctor, as well as the child abuse team or governmental child services, depending on what state you're in. So this, unfortunately, is child abuse until proven otherwise. And then finally, so this is actually a case of mine post-operatively. He ended up doing really well. So he's an 18-year-old male. He was playing basketball and he was hit in the face. He had history of a previous corneal transplantation from an eye infection. And when he came in, his corneal transplant was on his eyelid down here. So he had an emergent basically an emergent corneal graft that was replaced. And this is oddly a very common injury in basketball players who have corneal transplants, because if they get hit in the eye, they can redehisce their transplant. So this is basically considered a ruptured globe, obviously, because the eye is now open, and his corneal transplant was replaced. So this is treated just the same as an open globe and needs emergent repair. So to tie all of these cases together, and why this is really important in pediatrics, is because of a condition called amblyopia. So what exactly is amblyopia? It's a little bit difficult actually to define, but in strict definition, it's a decrease in visual development that happens when the brain doesn't receive normal stimulation for one or both eyes. So it can happen in both at the same time, or typically it happens just in one. If not treated, this can lead to permanent vision loss, and it's age dependent. So this is why, when I discuss with parents why it's important, for example, to either patch a child or wear glasses, the connection between the eye and the brain is kind of like drying cement. And in childhood, it's not quite dry yet. So we have to act appropriately and treat these patients before that cement dries. Because typically by the age of about 10, the effect of treatment really declines. So we're not able to really treat these patients while we're trying to balance that visual development between both eyes. So only children can develop amblyopia. So this doesn't happen in adulthood. And it is the most common cause of vision impairment, even in adults 20 to 70 years of age, is untreated amblyopia. So it's very easily missed, obviously. And common causes, as I mentioned, were untreated refractive errors, strabismus, and then as we had this long talk about trauma and cataracts. And the National Eye Institute states that it affects about 2 to 3% of children within the United States, which is about 4.5 million children. So that's a large amount of kids that can be affected by amblyopia. Now, that's not just traumatic cases, but certainly you can see how widespread this is. So prevention is key, obviously. And these are recommendations from our Pediatric Ophthalmology Society. And I think these are, always good to remind ourselves, obviously as parents, but also for our patients, to remind them what to do, even though it seems pretty obvious, to prevent a lot of these injuries. So kiddos, when they're playing sports, should wear polycarbonate lenses, especially if they have amblyopia or other visual compromise. You'll want to look up state laws in terms of what's covered medically. Most states, it's kind of a soft law to place polycarbonate lenses. There might be a small fee associated with that, so you just have to counsel your patients. Obviously, lock up all chemical sprays. Dispose of common items, paper clips, pencils, scissors, bungee cords. I think one thing that needs to be included in that is batteries, obviously. Safeguard your own sight with protective eyewear. Purchase age-appropriate toys. Avoid projectile toys. like the Nerf guns. Look for toys marked with ASTM, which means the product meets the national safety standards. I've looked for this. I've actually found this very hard to find. So, but it's always good to look for. And additionally, other preventative measures: use safety gates at the top and bottom of stairs, pad or cushion sharp corners. I have repaired a child who ran into a sharp coffee table before, who sustained a full thickness corneal laceration. Put locks on cabinets that kids can reach, and especially do not allow children anywhere near fireworks. One thing I did not mention, but very small children can be bitten by dogs. 15% of them result in eye injury, and animals are typically known to the household. And interestingly enough, the second event can result in more severe injuries. So if we're noticing a pattern, that might be something you want to discuss with the parents in terms of finding a new home for likely their loved pet. And then finally, on the road, make sure children are properly secured in car seats. And as one of my colleagues here that's hopefully here this morning, she is an expert at this. And if you ever need to ask anybody to help you with that, I'd be happy to give you her name. So thank you very much. I apologize for the interruption there in the middle, and I'm happy to answer any quick questions if you have them.
All right, so do we have any questions? You can submit them through the Q&A button at the bottom of the screen. You could also put them in the chat room, but I'm not quite as good as checking that one. What would you like, Dr. Walsh, what would you like the technicians to know about taking the history? You mentioned a lot of points in for the individual types of injury, but is there a certain way? And I have to add that I really appreciate what you pointed out, that sometimes the parents are screaming as well as the child, the patient. And so our technicians are trying to collect a history in a very maybe a very complex situation, and they actually have to deal with both the parent and the child. But as far as history taking, what are some points that they can take home, take to the office with them starting next Monday about how to evaluate people?
Yeah, that's a really good point to bring up. And I might add that the next time. Yeah, I think it's really important, honestly, is to be, number one, a support system for the parents. Everybody's going to come in very scared when you have an injury, any sort of injury with a kid. And so I find really important is to make sure, number one, that you are very supportive of what had happened, because many times they may not know, they may not have known, had witnessed the injury. Those are important documenting points to take, like, did they witness it? You really want a time course. That's really important. And just kind of let them tell the story of what they think happened, because sometimes these parents are going to feel like very overwhelmed. They're going to feel like they have really failed their children. They're going to feel guilty about this. Their kids are harmed, that sort of thing. So I think it's really important to make sure that they feel supported. You spend a lot of time with them, and try to get as much of a time course as possible in terms of what type of injury. And that can help us a lot in terms of what we think might be happening, because sometimes kids, you can't actually examine them too. They're not going to let you, because they're going to keep their eyes closed. So that can really be helpful to us in terms of determining what type of injury. And sometimes too, we won't know until we just have to take them to the OR and explore to see what had happened. But I think that's really the important take home point, is to just make it an environment that's very calming and soothing to them. And then the time course is extremely important, I think, to us. And if they know exactly, for example, like a chemical injury, we need to know what type of chemical. If it's some sort of projectile, that's important too. And then what exactly the nature of potentially the injury was. I had sometimes they won't know. This is just an anecdotal story, but one of my favorite of all time, and they're still a patient of mine after 10 years. But he was 4, and he had told his mom that he had fallen off the back of the couch and he had an open globe of corneal laceration. And based on the orientation of the couch and the orientation of the injury, the parents were obviously freaking out. We took him to the OR. I kept quizzing mom, do you really know what had happened? Because they didn't witness it. And she's like, well, this is what he told me. 4 years later, I got a phone call from him. He was an 8-year-old at this point, and his mom had made him call me alone to admit to me that he was using a knife to open yogurt, and that's how he actually injured his eye. And he had kept that from his mom for 4 years because he was so worried about being in trouble. And she had bought brand new furniture. She had bought everything because she thought it was the couch, and turns out it wasn't. So that's why, it's like you just try to do the best you can, obviously, and be really supportive of the parents. But that was basically his punishment was to call the doctor and admit that he hadn't told his parents the truth.
So that was, so good detailed history and always questioning, the suspicion was there. You kept asking mom in the background saying, hey, are you sure this is what really happened? I was very appreciative that you brought up the word bungee cord because it happens to be a personal favorite of mine. That goes right along with paintballs and then frozen paintballs. So I appreciate that. We do have some questions from the audience here. Let's see. How do you know when to head right to the emergency department versus calling your eye doctor?
Yeah, so I mean, it's that's a good question. I would never fault you in any sort of injury to go straight to the ER. Sometimes it's challenging. Obviously, now we live, in a little bit more of a technologically savvy world where you can show us pictures. That's one thing that I think is really important for parents, is to obviously photograph as much as you can, because that even can be helpful for us if we need to repair things. But if you suspect any type of injury and say a patient calls the eye clinic, I would never fault anyone, especially, technicians, front desk staff, anybody, for telling them to go to the OR to the ER, because sometimes it's actually helpful because it can get the process started if it's a really severe injury. Just in general, since we're a little bit more medically oriented, some ominous signs, obviously, if you ever see, blood dripping down the face or persistent tearing. And I always teach my residents that always be suspicious of an open globe if you're just seeing persistent tearing down the face. So even if it looks okay, just by general inspection, you really need to be suspicious of that.
Yeah, and if you do discover that in your office, put a shield on it before they touch their eye.
Yeah, exactly.
There's another question here. For a ruptured globe case from pencil injury, what was the visual acuity after surgery, or was there no recovery of sight?
Yeah, so that's a very good question. I didn't get into it just based on time, but it really depends on, so the pencil injury, I don't know about that particular case because that was a colleague of mine what their final vision was, but I've had one before. I've had a couple of them. And they can be as good as 20/20, 20/25, depending on where the corneal laceration is. So certainly in that case, you would basically want to make sure that the rest of the ocular structures are not damaged. In that case, you'd want to remove some of the iris that's been exposed to the air, and then basically close the defect. But it really depends on the nature of the laceration on the cornea. And there was a study done many years ago, basically giving prognosis tiers on visual outcome based on the eye injury. So obviously, if the more posterior the injury, the likelihood of visual prognosis being poor is higher. So Typically kiddos, if they have corneal injuries or corneal lacerations, there can be a lot done to manage this post-operatively and try to assess vision. And you'll also want to treat the amblyopia with patching, anything you can do refractively. But a lot of kids I've had that have had corneal lacerations tend to hover around 20/40, 20/60, depending on if other structures aren't involved.
All right. Are there any other questions? Apparently you have a fan here, says I remember the patient. I guess that was from your first story. Any other questions from the audience?
Yeah.
Well, again, we really appreciate you taking the time to be with us, and you gave us extra time of yours to answer the questions. So thank you so much for doing that. I know you're in a busy schedule and you're off to another meeting. So thank you again for joining us.
Thank you again, everybody. It was a pleasure to talk.
All right. So I'm going to go back to kind of the beginning and again, welcome everyone to this 2023 Virtual Technician Educational Meeting brought to you by CSEP. My name is Ed Lim. I'm a vitreoretinal surgeon here in Connecticut, and I'll be your host for today. Mark Longenheim of Photo Art Studio is going to be providing our technical production and graphic services today. And again, I couldn't do it without him. So thank you, Mark. On behalf of Dr. Martha Howard, your CSEP president, and the executive committee and the education committee, I present to you this course that's worth 7.5 continuing education credits. To get to your credits, so there was a question started right at the beginning and says, hey, where are the questions for this? So there are questions and evaluations that will need to be done and submitted in order for you to get your CE credit. So on the screen right now, you'll see the QR code that you can scan. That QR code takes you to the site. Click on current meetings, work your way over to the evaluations and the questions. So we were trying to think of a way to make this easy, better. I'm not sure, but I think that you can sign on now and answer the questions as the talks are being given. So it is important to do the test, to get the to do the questions. I just want you to know, again, we went to bat for you guys, trying to decrease the burden required on you. They had originally required 75 questions for you to answer to get your 7.5 CE credits. And we thought, wow, that's like serious test taking, anxiety producing activity. We got it down to 37 questions. This is a one-time exemption. I don't know if it will ever happen again in the future. You do need to get 60% of them correct. There are a limited number of retakes that you can do, and it has to be done within 30 days, at which time the option to take the test and therefore get CE credits will expire. So pay attention. For those of you who are getting credits, which I think is most of you, make sure you do all the steps to submit. When you complete your test and evaluations and submit them, after grading of your test, if successful, you will get your certificate through the email. And just be careful, because it's not going to come from CSEP. It's actually going to come from Photo Arts. So watch your emails after you submit for your certificate coming by way of email and from Photo Arts. I'd like to take a moment for special mention to Deb Osborne, our executive director of CSEP. All this work for one, just getting the credits, but then getting the burden of achieving those credits down really has been all of her work. It's just constant. There's also been a lot of work in trying to line up this amazing line of speakers and getting their materials in and making this both live stream, live and completely virtual encounter. So if you see Deb Osborne, drop her a line, drop her an email, let her know that she's appreciated. We on the education committee and on the executive committee really appreciate her input. Yeah, this meeting really is a recognition of you and your hard work that you need to put in on your daily efforts to bring forth the very best in eye care for each and every one of your patients. There's 9 lectures today covering topics from retina, uveitis, pediatrics, oncology, cornea, and glaucoma from our community physicians, both generalists and specialists, to our academic professorial types. The latest, greatest information has been culled from institutions and experience from all over the United States. And you go, well, how is that happening? And so it's like all these people, and we have a lot of young blood here giving these scholarly talks, and they've trained all over the place, all over the United States, and they've gotten their information from all over the world. And they're giving you this information today. And we just appreciate all this culmination of the information for you given by energetic ophthalmologists from across the state. As I look at the agenda and the speakers that CSEP curated for you, it gave me an appreciation for the depth and breadth of information that you need to utilize every day. Even my question to Aaron about, well, how do you guys now integrate this information into history taking? And this is what you guys, this is the real challenge. So when you're doing that intake interview in the office, this is how you know what questions to follow, what questions to ask, and what line of questioning to follow. And this is how you know what to say when patients ask you questions or when you're asked to do patient education. So know that we at CSEP, we appreciate that you're here today with us, investing in yourself, your patients, and your practices. Your pursuit of excellence is very inspiring. And we appreciate that you go to work every day and that you help us out in taking good care of our patients. In a time when many observe only the ways in which there's disappointment and challenge surrounding them, your presence here is a reason that people like me are hopeful and proud to be associated with you. So thank you for spending your time here today with us. I hope you find this carefully selected program useful and motivating. I'm going to go and start off for the next talk. This is with Greg Budoff. His title is An Introduction to Intravitreal Injections. I'd actually like to welcome Greg to Connecticut. He joined Retina Consultants. He did his fellowship at UCLA School of Medicine, Jules Stein Eye Institute. His medical school and residency was in New Jersey. And we're just pleased to have him as part of the Connecticut retina world and as part of CSEP and as a contributing presenter here today. So thank you for being here with us today, Greg. I'm going to turn this over to you.
Thank you so much for the introduction, Dr. Lim. You spoke about some important things regarding intravitreal injections that I wasn't necessarily going to touch on. And I think that after I'm done, we can touch on some of those things. So for some of the people who work in the retina world, this is all going to be old knowledge to you guys. You're very familiar with this, but for some of our anterior segment colleagues, I think this will be important, especially when you send patients to our practice or to our retina colleague. You'll know a little bit about what's going to happen. So let me tell you about what happens when we do an intraocular injection. So first of all, when I tell my patients this for the first time, they usually run away. They say, "No way, doc," but we usually get them back. So an intravitreal injection is what we call this. An intraocular injection really is an intravitreal injection. And let me tell you a little bit more about why. So this is the eyeball. Obviously, this is the front of the eye, the cornea, the lens. Behind the lens is this kind of black box for a lot of ophthalmologists. It's where the retina is, but really the retina lines what's called the vitreous cavity. And so when we do an injection into the eye, we're doing an injection into the vitreous cavity. And so we call it an intravitreal injection. The injection is given into a place called the pars plana, which is kind of a safe space to do the injection. You're not giving the shot through the retina, through the lens. You're not going to hit the lens. It's a really safe access point into the eye. So an intraocular injection really is an intravitreal injection. And so, the number one question from patients is, does it hurt? And the answer is no. I don't think we'd be doing this dozens of times a day if it was extremely uncomfortable. I think we would have found a different way to provide medication. So it doesn't hurt. We numb the eye in a couple different ways without needles. So one way is with drops. I think everybody is very familiar with tetracaine or proparacaine. And that's really easy. I think a lot of even cataract surgery can be done with just topical drops. So we just drop that in the eye. But then we have a lidocaine gel, something called actin gel, which you can put into the conjunctival fornix, and it will allow the eye to numb after a few minutes. Sometimes we reapply this 2 or 3 times. And then after that, patients are very numb. They don't feel any pain for the injection. Sometimes they'll feel a little bit of pressure, but it's very, very tolerable. And when I said without needles, I guess I was lying. Sometimes that we can use needles. We can do a subconjunctival injection where we inject lidocaine directly into the subconjunctival space, the area underneath the conjunctiva, between the conjunctiva and the sclera. And that provides even better numbing. But most of the time, patients do not need any needles to numb their eye. So let's talk about indications, specifically for anti-VEGF. This is the most common medication, or at least class of medications that we inject into the eye. There's a bunch of different kinds of medications that we can inject, but we're going to talk specifically about anti-VEGF injections in this talk. So VEGF stands for vascular endothelial growth factor, and it's a molecule that's created in the eye in various disease states. And when we inhibit that by injecting an anti-VEGF medications, we get a benefit that we're looking for. So we'll talk a little bit more about that in the mechanism in the future. But why would you inject a medication into a patient's eye? And there's numerous conditions that can lead to leaky blood vessels. That's obviously not a very scientific term, but that's really what's going on. Sometimes you might hear this referred to as cystoid macular edema, or CME. And let me tell you a little bit more about what cystoid macular edema means. So this is a fluorescein angiogram, and it's focused on, this is not a wide field fluorescein angiogram. This is a fluorescein angiogram which is focused on the posterior pole on the macula. So the center of the retina is called the macula. And so that's where you get the macular from. And if we draw a line through this fluorescein angiogram and kind of look at it in an OCT, you'll see that there's these black circles in the OCT. And these are fluid-filled spaces that are called cysts. And they're not exactly cysts, but we usually refer to them as cysts. So we call them cystoid, which means cyst-like. So that's where cystoid comes from. And then edema just means swelling. So if you put it all together, cystoid macular edema just means swelling of these cyst-like spaces in the center of the retina. So cystoid macular edema. And cystoid macular edema, it's not a diagnosis itself. It's more of a sign, and you can find it in various disease states, which we'll discuss in just a minute. But so if this is what cystoid macular edema looks like on fluorescein angiogram and OCT, let me show you what the normal retina looks like. It's something that we're trying to achieve by giving intravitreal injections. So this is a normal fluorescein angiography. There's no CME in the center of the retina, and there's no cystoid spaces on the OCT. And let me talk to you about some specific conditions that can cause some cystoid macular edema. And cystoid macular edema is a term you might hear in other conditions that might not require anti-VEGF, but a lot of conditions will require anti-VEGF injection. So specifically, wet age-related macular degeneration. Of course, there's different types of macular degeneration, but when it progresses to wet, you will get these fluid-filled spaces, and they come from what's called a choroidal neovascular membrane, or a macular neovascular membrane, which is when you get these abnormal blood vessels that grow underneath the retina and leak fluid into the retina, as you can see in these fluid-filled spaces, and underneath the retina as well. And so anti-VEGF medications treat this. Also diabetic macular edema, which looks a little bit different on the OCT. Typically in diabetic macular edema, you will see these, what we call hyperreflective foci, these kind of very bright white spots within the retina with fluid surrounding it. And what these correlate to on fundus photos are these hard exudates, these yellow accumulation of lipid, of fat that you see in the retina. So everything has a different appearance. This is how wet AMD can appear. This is how DME, diabetic macular edema, can appear. We'll talk about, let me take a brief aside from CME for a moment. There's other conditions that can have leaky blood vessels that don't necessarily cause CME on their own. Something like proliferative diabetic retinopathy, where you can really see on the fluorescein angiogram. This is an early phase picture on the left. This is probably about 40 seconds after the dye was injected. You see these abnormal blood vessels, which are brightening up with the fluorescein dye, and more distal to those, you see these really black areas where there's no dye. Those are ischemic areas where capillaries have died. And just to prove that these are really neovascular membranes, you can look at a later phase of the angiogram. This is probably about 2 minutes later. You see the borders, which were relatively clear here, have completely blurred. And so that's because these are abnormal blood vessels and they're leaking. So when we give anti-VEGF medications, it'll cause these we call neovascularization to regress, and they won't leak, and it'll stabilize the retina. And of course, at that point, you can do a more long-term treatment like PRP to prevent the growth of these blood vessels in the future. But back to CME, retinal vein occlusion is something else that can cause macular edema. And so this is how macular edema secondary to retinal vein occlusion might appear. It can really cause an incredible amount of swelling in the retina, as can wet AMD, as can DME. But we'll talk about response to anti-VEGF medications in just a minute. But let's first talk about how does this medication work. So as I said, VEGF is a molecule. It's created in the eye. It's increased in its amount in various disease states. So for example, in diabetic macular edema, the mechanism is diabetes causes death of blood vessels. The retina, when it doesn't get blood from those normal blood vessels, says, hey, help me, I need some more nutrients. And so it produces this molecule called vascular endothelial growth factor. And when this molecule exists in the eye, it binds to a receptor. So this is the VEGF molecule, it's binding to its VEGF receptor. And when it binds to this receptor, it turns this receptor on. And this binding of the receptor, turning on, leads to a whole bunch of cascades intracellularly, which we don't need to discuss because they're not important. But ultimately, it results in these blood vessels being leaky. It results in cystoid macular edema. It results in these neovascularization elsewhere, or neovascularization of the disc that you see in PDR. And we don't like that because it reduces vision, it destabilizes the retina. And so there's various medications, this anti-VEGF medications that we can use to treat these various disease states. And so a few of them are listed here. So aflibercept, ranibizumab, bevacizumab. You might know some of these as Eylea or Lucentis or Avastin. And then more recently, a new medication came out called faricimab, which we also refer to as Vabysmo. And so how do these medications work? So these, as I said, are anti-VEGF. So they bind to the VEGF molecule and they prevent it from binding to its receptor. Remember, when the VEGF molecule binds to its receptor, it turns the receptor on, which ultimately results in cystoid macular edema. So by these anti-VEGF molecules, they're blocking the VEGF so that it can't bind to its receptor, and it results in the receptor turning off. And when the receptor is turned off, the CME goes away, the leaky blood vessels go away, the neovascularization that we see in PDR goes away. And so that results in, the swelling going away and hopefully results in better vision. And so a lot of times patients will ask, how frequently are you going to be doing this, doc? Is this going to be an all the time thing? And so typically we begin with one injection a month until we see whatever therapeutic endpoint we're looking at. So in wet AMD, we're looking for resolution of the intraretinal fluid, the cystoid macular edema, and resolution of the subretinal fluid. In DME, we're looking for substantial improvement in the intraretinal fluid and the cystoid macular edema. Same thing with the RVO, the retinal vein occlusion. And in patients with PDR, we're looking for those neovascular membranes to not be leaking. So we typically start with one injection a month, and we can often extend slowly the time between injections to every 2 to 3 months. And every disease state's a little bit different. Some of them you can stop if the swelling doesn't come back. Some of them, like age-related macular degeneration, it's never really a great idea to stop it completely, but we can usually extend the time between injections to 6 or 8 weeks, or even 10 to 12 weeks to 14 to even 16 weeks. And sometimes we can stop it at that point. But we definitely want patients to get, we want their vision to improve, or at least to be stabilized. But we know coming in every month is rather difficult for patients. And so the more increased time between injections, I think is to their benefit. So of course, let's talk about risks. I always tell my patients that the most severe complication from an anti-VEGF injection would be an infection. Fortunately, it's extremely rare. Some studies will tell you there's a 1 in 1,000 risk of injections. Some will say there's about 1 in 5,000 risk for each individual injection. I usually tell my patients there's about a 1 in 3,000 risk of getting an infection in their eye per injection. And fortunately, we make that risk so low with the use of betadine. Betadine, as you all know, is just a drop of a medication that we put in the eye. It sterilizes the eye. It kills any bacteria on there so that you're not introducing any bacteria into the eye by sticking that needle in the eye. Of course, betadine, everything has its risks, right? And betadine, the risk of betadine, it's not really a risk, it's really a definite. When you put betadine in someone's eye, they're going to get a foreign body sensation. So it's normal for a patient who's getting a betadine injection, a betadine drop on their eye, to have a foreign body sensation that night, a grittiness or a sandiness. And that can even last until the next day. And sometimes if you use a lot of betadine, that can last even a few days later. So that's normal. What I tell my patients is if they have this grittiness or this sandiness, the night of the injection, the next day, don't worry about it. But you can usually distinguish between the foreign body sensation from the betadine and the infection from something like endophthalmitis by the degree of pain and the timing. Typically, endophthalmitis doesn't occur the day of the injection or even the next day. It's something that occurs usually a few days later. But most importantly, there is a substantial decrease in vision with endophthalmitis. Usually patients who are just having some reaction to the betadine, their vision is at baseline. Additionally, with endophthalmitis, their eye is usually very, very red, although sometimes the eye can be very red, as we'll talk about, just from the injection itself, from subconjunctival hemorrhage, which brings me to my next point. You can see this little red spot here. That's just where the needle went in. It probably hit a little capillary or a little blood vessel and caused this. And so this is not uncommon to see. Sometimes, however, patients bleed more. It might include the entire inferior subconjunctival space. It could even be 360 degrees in the subconjunctival space. More common for patients to get substantial bleeding when they're on blood thinners like aspirin or Plavix or Xarelto or Coumadin, but also a little bit more common when you do that subconjunctival injection to provide additional numbing ultimately. And that's another reason I don't typically do subconjunctival injections, is because you're more likely to look like a tomato afterwards. There's other very uncommon risks, things like retinal tears. So if a patient complains of flashing lights and floaters after their injection, it's always a good idea to do a scleral depress exam to see if there might have been a new onset retinal tear, or worse, a retinal detachment. Sometimes you can get a vitreous hemorrhage. As I said, we go through the pars plana, the part of the eye where we do the injection through, because it's a relatively avascular space and it's a very safe place to do the injection. But occasionally you can hit a blood vessel in the eye, which can lead to bleeding within the eye. So again, the risks are very uncommon. The most common risk is, I would say, grittiness, foreign body sensation, followed by bleeding, and then much more uncommon things like infection, retinal tear, retinal detachment, vitreous hemorrhage. The more uncommon risks are the more serious ones. And unfortunately, the more common risks are not as serious. So of course, the biggest question is, does it work? So let's bring us back to the patient that I mentioned earlier with a retinal vein occlusion. So this patient came in, they had 20/100 vision. I told them they needed an injection in their eye. We gave them one single anti-VEGF injection. 1 month later, they came back and their retina was completely dry. And their vision, which is what we're all concerned about, went from, sometimes the injections improve the vision. Like this patient went from 20/100 to 20/50 after 1 month. That's a substantial improvement, a couple of lines of improvement after one single injection. And what I would do at this point is I would inject the patient a month after this first injection, and then I'd see them back. Instead of seeing them back at 4 weeks, I'd see them back at 6 weeks. And the goal is to keep this retina dry, because when the retina is dry, it functions best and the vision is usually a lot better than if the swelling is there. And we know that if we stop injecting these patients completely, the swelling is going to come back. So that's why we do something called treat and extend. We slowly extend the interval between the injections to maintain the retina looking like this and to maintain the vision like this, as opposed to the swollen retina with decreased vision. Sometimes, however, the injections just stabilize the vision or reduce the chance of the vision getting worse. Sometimes these disease states take a toll on the retina, and even once we cause the swelling to go away, we can't bring the vision back completely, and we just want to prevent it from getting worse. So that's all I have for my talk. I'm Greg Budoff. I recently joined Retina Consultants up in Hartford. So I look forward to seeing any patients that you send to us. Anybody have questions?
Oh, come on, guys. This is retina. We love retina here at CSEP. All right, I have a couple questions. When I think about our technicians, and maybe they're in a comprehensive practice that's beginning to integrate this service into their protocols, when I think about what our ophthalmic technicians are being asked to do, if in the workup phase of this, is there any patient characteristic that they can identify in which you do not want to do an injection? And what should they be looking for that might actually lead to cancellation of the injection on that day?
That's a great question, Ed. I think patients who have, of course, the biggest risk we want to avoid is an infection. And some patients have really significant blepharitis. And of course, we can sterilize the eye, the conjunctival fornices, by putting a drop of betadine in the eye. But unless you're scrubbing the lashes with Q-tips and really getting all that crusting, that blepharitis away, sometimes it's not a great idea to do the injection when somebody has extreme blepharitis. So if that's the case, sometimes I will recommend we pause the injection, have them do some lid scrubs at home, get the blepharitis under control, and then come back a few weeks later to do the injection. But I think typically it's not too common to pause the injection for. I think most patients, if you look hard enough, will have a little bit of blepharitis, and that's not something that concerns me, especially if you can use a speculum or your fingers to kind of move the eyelids out of the way and really do the injection into a sterilized conjunctival space.
Yeah, and that super important. So when we're doing injections, we think about the pathway of that needle through space. And if we hit their hair on the way in, or if we hit their lashes on the way in, we are greatly increasing the risk of intraocular infection. We do have some other questions here, but I have so many questions. I'm gonna take the lead here again for just a moment. Somebody's there, a patient's there for their first injection, and you go in, give the injection, and you turn and you look to the technician and say, okay, tell them what they need to know. What patient education elements are important for the ophthalmic technician to discuss with the patient after their first injection?
I think it's really important. As I said, I tell every patient to expect to have a little bit of discomfort that first night. It's usually a grittiness or a sandiness or a foreign body sensation in the eye. And that usually comes not from the injection itself, but from the betadine. The betadine, while sterilizing the eye surface and killing any bacteria, the conjunctiva and the cornea aren't really big fans of the betadine, and so it can be a little bit irritating. And we try to rinse the eye out after the injection with some BSS to just remove any excess betadine and to reduce the chance that a patient is going to feel a significant grittiness or sandiness. But I think happiness usually is related to your level of expectation, and I think that patients who are expecting to have a little bit of discomfort the night of the injection and the next day are the ones that are happier, the ones that aren't calling in the middle of the night because they have that foreign body sensation. And so I think if they're aware of what to expect, they're going to be happy.
All right. We have some questions from the audience. How do you decide which drug to use?
I think that's a great question. And I think if you look at various studies, tons of them have been done over the 20 years or so since we've been using anti-VEGF. And I think for the most part, they're all relatively equal. We don't have great evidence on which patients are going to respond better to a certain medication. And I think a lot of times we should just start with one and see what happens. In an ideal world, I think all of us might have individual preferences on which medication to use, whether it's Avastin or Lucentis or Eylea or Vabysmo. But a lot of times in this day and age, the insurance company is going to make that decision for us. They're going to say, you have to start with a particular medication, usually Avastin, because it's the cheapest and it works, wonders on some patients. And if it doesn't work, if you can show that it doesn't work with the vision not improving, with the subretinal fluid not improving, with the cystoid macular edema not improving, then we can go on to try these other medications like Lucentis or Eylea or Vabysmo. But a lot of times we start with Avastin because of the recommendation by the requirement by the insurance company.
A sad but true fact. And it's even more there's more emphasis on that starting January 1 this year. Another question from the audience, why does the vein occlusion cause edema?
So a vein occlusion is basically when there's a blockage in one of the retinal veins. And I always explain to my patients like this, your eye's kind of like plumbing. So you have arteries that bring blood to the retina, and then you have the veins that drain the blood from the retina. And so when you have a blockage in that draining system from the eye, the fluid has to go somewhere. And so in patients with vein occlusions, you'll see when you look at their retina and you look at their fundus photo, you'll see all this blood. But when you look at when you examine them, you can see macular edema on exam, but on OCT, you'll see fluid. And that's really because it just can't drain. It builds up in the eye. And when it builds up in the eye, the retina can't function as well.
And another question from the audience, how long would you see a patient and inject at the 16-week mark before deciding to discontinue injections if the retina remains dry?
I think that's a great question. And To be honest, I haven't necessarily found my groove with that yet. I finished my fellowship, I guess about 16 weeks ago. I started here about 16 weeks ago, and so I haven't had any patients that I've extended to 16 weeks yet. But I think it's really a conversation you have with the patient, and you say, listen, you know, you've made it 4 months since your last injection, and you know, we could continue to inject you every 4 months if you'd like, knowing the risks of the injection, knowing the benefits of the injection, and seeing what they think. If the patient's like, no, doc, I don't want to get any injections that I don't absolutely need, I would say, okay, well then let me follow you closely. Let me see you back, you know, in another 4 weeks or another 8 weeks and see how you're doing. But Ed, how do you handle that situation?
Yeah. So again, great question. And it really is kind of working and listening to the patient, looking at their history of response to the drug that you've chosen to use on them. And they'll tell you, you know, like what they want to do. And it really becomes, in a nice way, a partnership with the patient. You know, you can show them the OCTs, and if you're doing FAs, you can show them that and say, look, this is what we accomplished. Geez, now it's dry. It all, you know, you obviously have to make a recommendation. You, the physician, have to make a recommendation for when you want to see them. Like, what do the studies show? What's a good time to follow them up? But also, if the patient is very kind of involved and aware and articulate and communicative with you, you can use them as kind of the sentry for notification. You know, a lot of my patients will call me and they'll say, you know, I'm getting a little blurred again, like a vein occlusion, and they've been responding well, but we're kind of trying to figure out what interval would be optimal for them. They'll say, you know, I think I need to come in. You know, we had set a certain interval, but I think I'm getting a little blurred right now. So these people, you know, they'll get a grid, or they'll, you know, we'll talk about what best way to kind of monitor their vision in standardized, somewhat standardized conditions, and kind of really make them a partner in this. You know, in the future, they're talking about home OCT use, and it's just like, we're not there yet, but, you know, that might be an even different way to throw some technology and cost into monitoring the patients at home. Because one of the things that everybody's working on is trying to decrease the treatment burden on patients. And so if you tell them, oh, you know, you only have to come in every 12 weeks or every 16 weeks, they'll be so happy just not to keep coming in. Sometimes people understand they don't really have a choice. They know that they respond to drug, but they're really on a fixed interval. And if they miss that interval, they have a recurrence. So it's really working with the patient. It's very individualized care, is not cookbook medicine. And it's really assessing the patient and their ability to be involved. Another question from the audience. I like this one. What do you do if someone's allergic to betadine?
That's a great question. You know, there's a difference between an allergy and an intolerance, let's say, or betadine. Nobody likes betadine, and betadine can cause real discomfort on some patients. And I think it really depends on, I think for those patients, I don't think anybody has a true, you know, anaphylactic allergy to betadine. Ed, correct me if I'm wrong, but I think some patients can have more intolerance to betadine. And for those patients, I might try to minimize the use of betadine. I already try to minimize the use of betadine. I usually give them a drop before they start getting numbed, and then a drop before the injection. I know some people like to use a significant amount of betadine that can definitely sterilize the surface, but can also lead to a rather symptomatic patient from this foreign body sensation. So I think for the patients who really do have a severe intolerance to it, there's really two options. One, you can use less betadine. Some people like to just take a Q-tip and put betadine right on the spot that they're going to inject. I don't really like to do that because I think, you know, the rest of the conjunctiva hasn't been sterilized. And so, you know, I do like to give a drop into the fornix and let it sterilize everything, but not an excessive number of drops. I also think it's really important to wash the eye out, so there's not excess betadine causing a reaction, you know, hours after the injection when it's not necessary. There is some talk recently about using another chemical that's like betadine, but not betadine, that might be just as good, if not better, at sterilizing the eye surface, but maybe a little bit less caustic, a little bit less irritating to the conjunctival surface. And I think as a field, that's something that we are looking into to see if this other sterilizing medication can sterilize the eye as well as betadine. But I think that's something that we haven't answered fully yet.
Very fair answer. Another question here, can PDR, I presume proliferative diabetic retinopathy patients get CME?
Yes, I mean, patients with PDR can get CME, or more appropriately termed in this case, diabetic macular edema. But diabetes, I always tell my patients, can cause two different things. It always causes problems to blood vessels. And one of those things, those blood vessels can leak in the center of the retina from microaneurysms. But another thing that it does is it causes death of normal blood vessels. And when the normal blood vessels die, you can get these abnormal blood vessels that grow, this neovascularization of the disc or neovascularization elsewhere on the retina. And so when you get this neovascularization, that is what PDR is. That's what those neovascular complexes are, proliferation. So that's what PDR is. So those patients who have PDR can also get diabetic macular edema from leaking microaneurysms in the macula. But you don't need to have PDR to get diabetic macular edema, if that makes sense.
We have another question from the audience. Do you have any tips on prepping the patients for injection? So I think you probably mean, and you correct me if I'm wrong, you mean the physical preparation of the patient.
I mean, I think this question can be answered in a million different ways, but let me take two different stances on it, and if there's any questions, I'm happy to go down any other rabbit holes with it. But first of all, to me, the most important thing is getting a drop of betadine quickly. Before you start, a lot of times we'll use this actin gel, this lidocaine gel, to numb the patient's eye. And I think there's good evidence that if you get betadine in before you give them that lidocaine gel, there's going to be a greater effect, a greater sterilizing effect. And so I always tell my scribes and my technicians and whoever's going to prep the patient for me, or if I'm doing it myself, to put a drop of tetracaine in, then give a drop of betadine, and then put the actin or the lidocaine gel in. So that's one thing. The other thing I would say is you always want the patient to be numb. So give them time to numb. So put the drop of tetracaine in. Tetracaine works pretty quickly, but this actin gel, this lidocaine gel, can take some time. So usually from the time my patients get their lidocaine gel, their actin gel, I'm waiting usually at least 10 minutes before giving them their injection. And that's just so the eye has sufficient time to get numb, but also repeated application of the actin gel. So you give the gel, you wait a few minutes, you give another application of the gel into the conjunctival fornix, wait a few minutes, sometimes even apply a third dose of that actin gel to the conjunctival fornix, and give even more time, up to 15 minutes or 20 minutes for the patient to get numb. So that's the other thing I would say is just time following the numbing.
I have a somewhat related question. During the procedure of the injection, how can the ophthalmic technician be the most helpful to you?
You mean during the injection itself?
Yeah, so we talked about the prepping and how we do that, but during the actual procedure, what would you like your ophthalmic technician to do? They're standing there. What would you like them to be doing?
I think when we do the injection, we need to access a certain part of the eye. So everybody does their injections in a different location, usually either supratemporally or infratemporally. But in order to access that area, the patient needs to be looking in the right area. So if I'm doing a right eye injection, my patient needs to be looking up and to the left so that I can access that inferotemporal area. So it's really helpful if my my scribes and my technicians are standing on the left side of the patient, giving that patient a target to look to so that I can access the right area. What about you, Ed?
Yeah, and there's this concept I call room management. So I do it. I actually just do it in the exam room. I don't have a separate room to do it in. And there's usually other people in the room, and I just want the focus to be on the patient. I don't want the adult child of the patient who's getting the AMD injection to all of a sudden I'm going to get up and make a phone call. For that 3 seconds that it takes to do the injection, where I need the patient's concentration on me. I just need some control of the room. So anything that my technician could do to control the room, keep the patient focused, like for instance on that up and in gaze, is really important. So just be aware of your surroundings. You're really, even if you're standing there, you're participating to create that environment that's going to minimize risk. When I have another question, actually, we have a comment from Sarah, who, going back to the betadine sensitive patients, they said experience has taught her that using artificial tears before coming to their appointment may help the people who are betadine sensitive. I'll add one thing to that also, that I've had over the years patients say, well, I'm allergic to betadine. One, it's very difficult to be allergic to betadine, but that in mind, oftentimes what I'll do is I'll take one of my 10% swabs and put it on their skin and just sit there and say, well, if you are, we'll figure it out in just a few minutes. And then I'll leave the room, go do something else, come back. And when they're okay with it, I say, okay, now I'm going to use half the strength, and I give them a drop in their eye, and I go leave the room again. And for the 1 or 2 times over the decades that I've done this, I've never had somebody who actually was allergic, like true anaphylaxis to it. And I guess if I did, it would be a bad thing. So I guess you always have to keep that in mind, but we have to make sure that they truly have a sensitivity to it. When an ophthalmic technician is doing a phone triage, right? So their assignment for the day, for the afternoon or something, is take phone calls. And they get a call from a post-injection patient, which you don't always know unless you're actually in their chart, which is easier with EHR, of course. But you get a call from a post-injection patient. What questions would you like the technician to be asking in a post-injection patient?
First of all, I want to know when the injection was. As I said, typically it's normal to have, as I've stressed multiple times throughout this talk, it's normal to have and expected to have some discomfort or foreign body sensation or grittiness or scratchiness the day of the injection, even the next morning. It's also extremely uncommon to have an infection in the eye the day of the injection or even the next day. Now, I don't want anybody to think that it's impossible, because of course it's not. But having an idea in terms of when the injection was given can give you an idea in terms of what complications are expected to occur at that time frame. As I said, also there's differences in terms of the symptoms of an infection versus the symptoms of a reaction to the betadine. So endophthalmitis, an infection in the eye, is going to cause the eye to be extremely red and extremely painful, and have the vision be a lot worse. So I always want to know, how's the vision? If the vision is at baseline, I'm a little bit less concerned. If the eye is not red, I'm a little bit less concerned. And if it's not painful and more of just a grittiness, I'm a little bit less concerned. But a lot of times for these patients, I will want to talk to them myself. So I'll get the number and give the patient a call myself and see how they're doing, so I can, make sure that I'm asking the correct questions. Also, I always offer these patients to come in. I don't want them to be concerned. I know that, you know, this is their eye and they're very concerned. And sometimes just having them come in and have you take a look at them and just reassure them that everything is okay can further strengthen that relationship. It takes 2 minutes to take a look to see if the patient does have anything serious going on. It's certainly something you don't want to miss. So, you know, those are the important things to think about, I would say. Anything to add, Ed?
Could you make a comment on TAS, so toxic anterior segment response, and what are those patients going to tell you on the phone and when?
So you mean like post cataract surgery tests?
Well, or you know, post injection,
Injection.
yeah, where they get some big inflammatory reaction.
To be honest, I have not seen TAS following an intravitreal injection, but you know, usually their vision, at least for post cataract, their vision is going to be reduced, and they're going to have an inflammatory reaction in their eye, but they're not going to, correct me if I'm wrong, they're not going to be in pain or as much pain. And so, you know, pain to me is a really sensitive, really important thing to know about when I'm determining if a patient has endophthalmitis or not. And if they have inflammation in their eye, but it's not painful, my concern that they have endophthalmitis is just a little bit lower.
Yeah, and I think that that's a really important point. So when you're on the phone with these patients, or you know, talking to them, you need to get a degree of pain, and then the trend of the pain. Is this pain increasing? Did it hurt before, but oh, now it's better? You know, if they have an infectious endophthalmitis or a big inflammatory response in their eye, you know, a non-infectious endophthalmitis, their pain is not going to all of a sudden start getting better all by itself. So, you know, asking those questions about pain, redness, discharge, light sensitivity, you know, the clarity of their vision, and then the progression of those symptoms is really, really important. We have another question from the audience that must be from one of our more experienced technicians. What do you do if the patient has a superior and inferior bleb? Do you move your injection site?
That's a great question. Yeah, you definitely would move your injection site. I would not inject through a bleb. The last thing I want to do as a retina specialist is cause a leaking bleb and have to, you know, deal with surgical management of the conjunctiva post-operatively. But you can really inject anywhere. I mean, you can inject for 360 degrees around the eye. So if a patient has a supratemporal and an infratemporal bleb, well, then I would just move my injection site to infranasal. It's a little bit more difficult, or supranasal. It's a little bit more difficult depending on you know, the nose and getting to that area. But it's not impossible, and it's, I would say, extremely uncommon for a patient to have a bleb or a tube or something for 360 degrees around the conjunctiva. So yeah, you would just move it. But that's a great question.
Obviously, from someone who's seen a lot of eyeballs. What other questions do we have from the audience? All great questions. Okay, well, thank you, Dr. Budov. Appreciate you being here and spending time with us today. Okay, so we're going to move on to the next talk. The next talk is a pre-recorded video by Michelle Meng. Dr. Meng is assistant professor at the Yale School of Medicine. She's board certified in ophthalmology with subspecialty training in oculofacial plastic, reconstructive, and orbital surgery. She completed her medical degree from the Illinois College of Medicine. University of Illinois College of Medicine, and she did a general surgery internship at Cornell Medicine. She completed her ophthalmology residency at Columbia University Medical Center, and she did a 2-year fellowship at Bascom Palmer under the program sponsored by the American Society of Ophthalmic Plastic and Reconstructive Surgery, or affectionately known as ASOPers. For those of you who don't know, that it's a real mark of prestige to be an ASOPers sponsored fellowship program. They are a very special group of people, so it's a real feather in her cap. So if you get an opportunity to meet, see, or interact with Dr. Meng, tell her that you've seen her talk, and hopefully you'll enjoy her talk that's titled Orbital Neoplasms and Malformations.
Hello, my name is Michelle Mang. I'm the oculoplastics faculty at the Yale School of Medicine. I just joined the team in October, and I'm just so happy to be here virtually to talk to all of you about orbital neoplasms and malformations. I have no financial disclosures. So orbital neoplasms and malformations can arise from a long list of causes, ranging from vascular to mesenchymal, lymphoproliferative, lacrimal, metastatic tumors, and so much more. So we unfortunately don't have the time today to cover the full breadth of this field, but I'd like to take this time to give you just a little taste of some of the more common orbit pathologies that you may encounter. I'm going to take you through 5 cases that I saw in the past 2 years that exemplify the key history and clinical features that everyone should be aware of to provide the best care for our patients. So let's start with the first case. This was a 28-year-old female who was referred for bulging of the left eye. She said she noticed some left-sided headaches, maybe a pressure-like sensation around her left eye, but no frank pain. She said she really noticed these symptoms worsen during her most recent pregnancy, and her baby was now 3 months old, but she otherwise had no other past medical or ocular history. On exam, her vision was 20/20 in both eyes. Her pupils were round and reactive, but there was a small left RAPD on the left side. Her IOP was 18 and 20. Color plates were full on the right and 4 out of 6 a little bit diminished on the left side. There was also 6 millimeters of relative proptosis on the left side. EOMs were otherwise completely full. And on dilated fundus exam, there was a mild blurring of disc edges on the left side. You can see in this picture, this is what's called the worm's eye view. The proptosis can be grossly visualized on the left side. I'd like to hone in on some key exam findings for this case. So in the setting of an orbit workup, I'd like to think of vision, pupils, and color plates as the optic nerve package. And that's because the information that's gleaned from these values gives me an idea of whether or not the optic nerve is being compromised in any way. An accurate assessment of these 3 can really change the direction of how I manage patients with an orbital mass. In addition, the Hertel measurement and EOMs are really important to give a full picture of what's going on in the orbit. So going back to our case, we sent this patient for additional testing. I apologize for the low quality of these images, but as you can see on the Humphrey visual field here, on the right, it was essentially full. On the left, there was some generalized depression, but a pattern deviation showed this definite nasal step right here. We also sent this patient for OCT RNFL, which showed RNFL thickening on the left side. That was well outside the normal range. That's why it's white there. So where do we go from here? And if you said to the MRI, then you are correct. That's exactly what happened. So here's the patient scan. You can see there's this large, round, oval lesion. It enhances with contrast over time. You can see on the right here, this lesion is pushing up against the globe medially, creating this flattening effect against the globe. The shape of this lesion on imaging was very consistent with what's called a cavernous hemangioma. And because of the effect it was having on her vision, if you remember, she had an APD, color vision deficit, some disc edema, we decided we were going to take her to the operating room for total excision of the mass. I wish all of you could have been there in the OR with me because this was such a fun case. But here are some intraoperative photos to show you what we saw. Here you can see we made an incision transconjunctivally along the lower eyelid. We used malleable retractors to help us visualize as we carefully dissected around the entire perimeter of the lesion until we were able to free it up and deliver this baby out from the orbit. Pathology revealed that this lesion was indeed a cavernous hemangioma. This is typified by the many blood-filled channels throughout the tissue, as you can see in this low-powered and high-powered images. So what is a cavernous hemangioma? It's benign. It's the most common orbital lesion in adults, usually presenting in the 40th to 50th decade. And patients will usually come with the slowly progressive, painless proptosis. On exam, they may be hyperopic, particularly because the lesion can push on the posterior aspect of the globe, effectively shortening the eye, leading to a hyperopic shift. The mechanical push of the lesion can also lead to retinal striae, which you can visualize on dilated fundus exam, optic nerve compression, increased IOP, and rarely strabismus. Additional imaging is critical for the diagnosis and management of this lesion. So without visualizing the location of the lesion, it's impossible really to formulate the surgical approach and the plan. And not only that, but there are very characteristic kind of appearances of the lesion on imaging. So while looking at the image under the microscope is truly the most definitive and specific way to give the diagnosis, imaging can still give a relatively high level of confidence, and that helps us to determine whether or not we want to take the whole thing out in surgery or just take a little sample for biopsy. Management is typically observation, as these lesions tend to just grow extremely slowly or not at all. However, when there's evidence that this mass is causing vision loss, like there was in our case, or if the proptosis is very disfiguring, then surgical resection can be warranted. So new studies have shown some treatment effect also in patients where when they have a lesion way back in the orbit, that's in the apex, and it's difficult to resect, then radiotherapy may be used in those cases. So back to our patient here, the images on the top are to remind you of what this patient looked like on presentation. And on the bottom, these two images are the same patient 1 week after surgery. You can see that already she has great symmetry between the two eyes. The projection of her left globe is sinking back into a better position. And this continued to improve over time. Moving on to our next case, here is a 7-year-old boy who presented with this rapidly enlarging mass in the right lower eyelid for the past 2 weeks. Mom says that there was no trauma or pain. He just kind of woke up one morning and something started to grow pretty quickly. The boy otherwise had normal gestational and developmental history, pretty healthy kid. And now sometimes getting the history for children is tricky, but when it comes to parental observation of a child's face, I tend to put a lot of weight on that. You know, parents can spend a lot of time staring at their kid's face, and they can pick up on subtle changes in a kid's physical appearance or activity level even that may not be obvious to a physician on their first time meeting them. And so the majority of patients, I feel like, you know, the parents just tend to know, and I trust them when it comes to their concerns. So on a patient's exam, the vision was 20/20 in both eyes. There was no APD, her tells were equal, color plates were full, EOMs were full. So otherwise the exam was fairly unremarkable. Seems, you know, not that frightening on that exam. However, we were curious to see how deep the lesion extended into the orbit. Unfortunately, I don't have these images with me, I'm sorry, but the lesion seemed localized on the eyelid. The posterior edge of it was fairly anterior, meaning just mainly on the orbit. It didn't grow deep into the orbit. So next steps, the operating room. You know, even though the exam was reassuring, our level of suspicion was very high for something that could be bad. So we took a tissue biopsy of this growth to find that the pathology was indeed consistent with a rhabdomyosarcoma. Rhabdomyosarcoma is the most common primary orbital malignancy of childhood. The average onset is between 5 and 7 years. And the classic clinical picture is that of a child with sudden onset and rapid progression of unilateral proptosis. It's almost always fast. It just kind of seems to come out of nowhere. And the mass can involve any quadrant of the orbit, and even in rare cases involve the conjunctiva, as we saw in our case. There's often this marked adnexal response with edema and discoloration of the eyelids. Ptosis and strabismus may also be present. The mass can be palpable on exam, particularly in the superior nasal quadrant of the eyelid. And I have to admit, rhabdo is not a common diagnosis, but it should always be in the back of our minds. And that's because sometimes the history for children, as I said, it's not always straightforward. So sometimes they present with this unrelated history of trauma. And for those of you with kids, kids are always bumping their heads on things, but unfortunately that history can convolute the picture and lead to a delay in diagnosis and treatment. For any rapidly enlarging mass in a child, the workup is always urgent. Again, imaging is critical to evaluate the location and extent of the mass. And then a biopsy should be performed, usually through an anterior orbitotomy approach. There are various subtypes of rhabdomyosarcoma, each with different prognostication and treatment regimen, so getting an adequate tissue volume for pathology is very important. When the diagnosis is confirmed, the patient needs to be referred to oncology as soon as possible for a full metastatic workup, and that includes evaluation of the lymph nodes, additional imaging of the body, bone marrow biopsy, lumbar puncture, and that all helps to dictate treatment. Before 1965, the standard treatment for orbital rhabdomyosarcoma was exenteration, which is not only disfiguring, but the survival rate was also very poor. More recently, exenteration has been reserved just primarily for recurrent cases. Radiation therapy and systemic chemotherapy have become the mainstay of primary treatment. And that's all based on the guidelines set forth by the Rhabdomyosarcoma Study Group. The goal of the systemic chemotherapy is to eliminate any microscopic, any very, very small cellular metastases. And the good news is that with radiation and chemotherapy, survival rates can be better than 90%. But that's if the orbital tumor has not invaded into the bone that surrounds the orbit or to other sites. And so with the rapid nature of this tumor's growth, that's why prompt diagnosis can make all the difference in a patient's outcome. Moving on to case number 3. So I saw this 58-year-old female who had been treated for months with various antibiotic eye drops for conjunctivitis. She came to me saying that she had this long-standing red eye that did not improve with anything that she did. She denied any other pain or trauma. Her past medical history was significant for hypertension, but she otherwise had no other ocular history. On exam, her vision was 20/20, 20/25. Pupils were round and reactive. There was no APD. IOP was 17 and 19. Her TELs showed 2 millimeters of proptosis on the left side. Color plates were full on the right, but a bit diminished on the left. On external exam, you can see there was this diffuse periorbital fullness on the left side, and there was chemosis, there was injection. Chemosis can sometimes be an orbital sign. That's something we look out for. So as demonstrated by this 9th grade, her extraocular motility was limited, particularly in down gaze, as well as in adduction. I unfortunately don't have access to this patient's imaging, but I found this representative MRI online, and it's very similar to what we saw at the time. There was this diffuse, ill-defined, infiltrative mass that took up nearly the entire space of the orbit. There was some proptosis, you can see here, and the optic nerve, which is usually wiggly, was on stretch. It was more like a straight line, as you can see in this image. So for our next steps, we took the patient to the operating room. The lesion was so diffusely infiltrative that there would have been no way that we could take the whole thing out. We performed a biopsy because we wanted to know what it was in order to treat it. Pathology revealed a B-cell lymphoma, and you can see the representative images here on low and high-powered magnification. There's just this hypercellular response. Lymphoproliferative lesions in general constitute a heterogeneous group of neoplasms that are defined by clinical, histologic, immunologic, molecular, and genetic characteristics, just so many different things. And they account for more than 20% of all orbital tumors. The vast majority of orbital lymphoproliferative lesions are of the non-Hodgkin's lymphoma type. And in the United States, the incidence of non-Hodgkin's lymphoma in all anatomic sites has been increasing. And it's one of the most common malignancies affecting the orbit. Approximately 20 to 30% of periocular lymphoproliferative lesions have a history of previous or concomitant systemic disease. An additional 30% will develop something else in the body over the course of 5 years. The risk of systemic disease remains elevated for decades after the original lesion is diagnosed, so the long-term follow-up is very important for all patients. The risk of having or developing systemic non-Hodgkin's lymphoma is lowest for conjunctival lesions, next greater for orbital lesions, and highest for lesions arising around the eyelid. Conjunctival lesions are often called salmon patch lesions here due to just the way that it looks in the coloring, and so that's why I have this here. The typical lymphoproliferative lesion presents as a gradually progressive painless mass, and it results in proptosis, a visible periocular mass that can be palpated, or ptosis. Lymphoproliferative lesions, whether benign or malignant, usually mold to surrounding orbital structures. It's usually described to be like putty. And rather than invading the tissue, it just kind of pushes up against the surrounding tissue. And consequently, the disturbances in extraocular motility or visual function are usually unusual. For all lymphoproliferative lesions, an open biopsy is preferred to obtain an adequate tissue specimen. The molecular diagnostic testing that occurs after the biopsy helps to guide specific treatment regimens. Radiation is a treatment of choice for the most common subtypes, and prognosis is usually favorable. Treatment for less common subtypes often involves chemotherapy and immunomodulation in addition to radiation. So back to our patient, she received chemotherapy, and within several months, she was looking more like her regular self. She was very happy. Moving on to case number 4, this was a 54-year-old female who noted a 6-year history of left-sided painless proptosis that was observed for many, many years as thyroid eye disease. The patient had never had a scan, but was told by multiple providers that there was no further management needed. She denied a history of trauma, but reported this acute worsening of her symptoms that prompted her to seek care. As noted, this patient had a history of Graves' disease that was controlled on medication as well as hypertension. Her only ocular history was this presumed thyroid eye disease. On exam, her vision was 20/20 on the right, 20/25 on the left. IOPs were 18 and 21. Pupils were round and reactive, there was no APD, color plates were full, and there was 7 millimeters of relative proptosis on the left side. You can see here this video of her extraocular motility showed that there was restriction on upgaze, on abduction, on bringing the eye out, but was otherwise preserved on downgaze and on adduction, bringing the eye in. So here are images from her MRI orbits. You can see there was this large circumscribed oval-shaped mass situated in the superior lateral left extracorneal space where the lacrimal gland usually sits. We did additional CT imaging of the orbits and found that there was no surrounding bony erosion, and that's helpful for us to lean away from a malignant process. You may be noticing a theme here, but the next stop was the operating room. We did a left lateral orbital, left bone window orbitotomy, and that's where we remove a chunk of bone from the lateral wall of the orbit to provide more space to visualize this lesion. It gives us room so that we can dissect completely around the lesion. take out this big old hunker of a mass. After the mass is out, though, we do replace the bone. Pathology came back for pleomorphic adenoma. Pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland. It usually affects adults during the 4th or 5th decade of life. Patients present with a progressive, painless, inferior and medial displacement of the globe with axial proptosis. Symptoms usually persist for more than 12 months as this mass grows relatively slowly. A firm lobular mass can be palpated near the superlateral orbital rim, kind of near where the lacrimal gland should be. And again, while the path diagnosis is always the most specific, we know that the imaging for pleomorphic adenoma can still be relatively characteristic, and it helps us guide the surgical planning. This lesion is always where the lacrimal gland sits, and it's usually well demarcated and has some slight nodularity to its borders. Treatment is complete removal of the pleomorphic adenoma with its pseudocapsule and surrounding margin of orbital tissue intact. Patients do not need any additional treatment after the mass is out unless the lesion recurs, and that can happen in the minority of cases after 15 plus years. Turns out, prior to meeting me, this patient had been praying that her proptosis would be resolved prior to her 55th birthday. We ended up taking out this lesion a week before her birthday, and she was very happy. And for our last case, we met this 83-year-old otherwise healthy female. She was referred for a ptosis workup. For the patient, she was having this slowly progressive droopy left eyelid for the past 6 months. She denied any pain or trauma. There was no significant medical or ocular history. On exam, what struck me was her extraocular motility. You know, we have the pictures for that, but before that, let me get to her vision. It was 20/30 on the right side, 20/60 on the left. Pressure was 15 and 17. Pupils were random reactive. There was no APD, but here, this extraocular motility, you know, with her left eye, other than being able to adduct, looking in okay, she really couldn't look up. It was hard for her to abduct and also to fully look down. On her tail, she had this 6 millimeters of relative enophthalmos of the left eye. So in contrast to some of the previous cases, I was more worried about the fact that the left globe appeared to be sinking down into her socket. And that resulted in a relatively deep superior sulcus here compared to the other side. You can see this hollowing. And it also resulted in her eyelid to appear ptotic. MRI of the orbits demonstrated this enophthalmos of the left globe with this diffuse, ill-defined lesion surrounding her globe, extraocular muscles, and optic nerve sheath complex. Patient was taken to the operating room for a biopsy where the pathology revealed metastasis of breast cancer. If you recall, this patient had no prior diagnosis of breast cancer. And that can be the case in many of our patients. So 75% of patients have a history of a known primary tumor, but orbital metastases can often be the presenting sign of cancer in 25% of patients. Although virtually any cancer of the internal organs, hematopoietic system, or skin can metastasize to the orbit, the most common orbital metastases are derived from the breast, the lungs, and the prostate. The presence of pain, proptosis, inflammation, bone destruction on imaging, and early ophthalmoplegia, so deficits in the extraocular motility, suggests the possibility of a metastatic carcinoma. Breast metastases to the orbit can elicit a fibrous response that causes the classic picture of enophthalmos and restriction of extraocular motility. So any older female with a sunken globe should raise a red flag for possible breast cancer. It can also think that the underlying etiology is ipsilateral ptosis, as we saw in our patient, or they may think that the patient just has some double vision, and that's secondary to the EOM deficits, but that's not what's focused on. So in fact, up to 50% of these cases are often referred for other causes. The treatment of metastatic tumors of the orbit is usually palliative, consists of local radiation therapy. Consultation with the patient's oncologist is key in determining the best treatment plan. We covered a lot of ground today in a short amount of time. And out of the 7 subtypes of orbital neoplasms and malformations, we talked about the presentation, timing, and treatment for 5 types of tumors. The most common vascular lesion is the slow-growing cavernous hemangioma. We learned about how it can cause proptosis, generally without motility deficits. We learned that on exam, the vision, pupils, and color plates are important as the optic nerve package, while the Hertel and extraocular motility give us a better understanding of what's going on in the orbit. We also learned about the most common mesenchymal tumor in children. The rhabdomyosarcoma is a serious diagnosis, and we should always keep that on our differential when a child presents with a rapidly growing mass on the eyelid or in the orbit. Our third case is about lymphoproliferative lesions, of which the most common is a non-Hodgkin B-cell lymphoma in the orbit. We learned that this disease has systemic implications, so it's important to get a biopsy to direct the right course of treatment. We also learned about a lacrimal mass, the benign mixed tumor. This case illustrated that imaging is extremely important to make the correct diagnosis. And lastly, we learned about metastatic malignancies to the orbit. We learned that we have to have this discerning eye when it comes to evaluating the patient. Sometimes the most important clinical features, such as ophthalmos, can be disguised as something entirely different, like ptosis. And so here are 4 key takeaways I'd like to leave with you today. Number 1, careful history provides diagnostic clues, as certain lesions present more commonly in different age groups, and the time course of symptomatology, as well as the presence or absence of pain, are also important pieces of information. There are key exam elements, so vision, pupils, color plates, that are part of the optic nerve package. And EOMs and Hertels complete the orbital exam. Third, and I cannot stress this enough, but imaging is critical. The paper radiology read alone is never sufficient. Scrolling through the actual images themselves is tantamount in the diagnosis and the surgical planning. Whenever members of the care team can help obtain the physical CD or help to push the virtual images into the system for viewing, this saves so much time, and it's a game changer in providing the best care for our patients. Lastly, getting the patient to the operating room to either take a small biopsy or remove the mass entirely determines the treatment plan for our patient. Sometimes getting the patient to the OR isn't easy. So whether it's getting the consent documentation ready while the conversation is happening, or answering some patient questions when they call in, there are so many little ways to jump in and help facilitate this often daunting process for patients to get them on the right track. If you keep these 4 key takeaways in mind, you'll be an even more valuable member of the team, and many patients will benefit from your care. Thank you so much for your attention today. I'm so sorry that I'm not there to answer any questions in person, but please feel free to email me at this email, and I'd be happy to chat. Hope you all have a great conference day.
Well, that's quite a bit to take in. I think that what's really important is her point of, what to notice on the exam. Every single one of you have worked up patients, and that evaluation starts kind of at the door. You know, if you didn't walk the patient back, but as you're entering that exam room, you're listening to their voices and the rhythm of their voices, and you're looking at them. And when you look at them, you know, that observational part of your encounter is so important to kind of get the big picture. And then you get to your examination where you're doing the motility exam, the pupil exam, and all those little parts are important. They're additive when you're trying to make that assessment of the patient. So, you know, if you can think about the pictures that she presented and think about, well, what questions do I have to ask? You know, in an adult, yet their cancer history is really important. So all of a sudden that past medical history, making sure that you're thorough. You know, I think every single one of you have probably heard the patient say, well, it doesn't have to do with my eye, so I didn't tell you because I didn't think it was important. So knowing that when you're trying to cull through the information, everything's important. So if somebody presents with diplopia, you want to know about their cancer history. If somebody says, geez, the red lights, the traffic lights, they're not as red as they used to be in this one eye, but if I close that eye, it's normal. All those things are important. And doing the motility exam, not just copy forward those parts of the exam on the EHR, which I know you would never do, but all those things are important. So hopefully, you know, as you learn about the wide breadth of information like these orbital tumors, you can then say, well, how would I make that part of my physical exam, the observational part of my exam, the vision testing? You know, the pupil exam is important. You know, everyone knows a normal pupil exam. If you're not quite sure what a non-normal pupil exam means, just get somebody, get another technician, get a senior tech, get your physician and say, you know, I don't know what the problem is, but I know that it's not normal. And it's just such an important role that you play as part of the team. I'm going to move on to our next talk. Our next talk is also a pre-recorded presentation. This is given by Dr. Nanani Kambo. Dr. Kambo, I've depended on her so many times. She's just a wonderful person. In addition to being the uveitis specialist and comprehensive ophthalmologist at Yale, she's Yale faculty, but she's also a graduate of Yale School of Medicine and the Yale residency in ophthalmology. She went up to Massachusetts to do her uveitis fellowship with Dr. Stephen Foster. So for those of you in the business, you'll recognize that name. He's truly one of the leaders in uveitis. And her training was done at his facility, the Massachusetts Eye Research and Surgery Institution. My understanding is, in addition to being Yale faculty, she, I think, became chief of VA ophthalmology. So she's really accomplished quite a bit in a short period of time. Her talk is titled "The Masqueraders of Uveitis."
So much, Dr. Lim, for that kind introduction. And you all know Dr. Lim is awesome. So he's my go-to person for some complicated cases, and we share a lot of lovely patients together. And let me see, Emma, good to see everybody, and thank you for spending your lunch hour with us. I hope this is really a productive meeting for you. And during my talk, I'll encourage you to chime in the chat session. You know, if you have any questions, any comments, feel free to just type away. And of course, if you want to raise your hand, I don't know if I'll be able to simultaneously talk and monitor the hand raising. So if you have a question or anything, I'll pause throughout the talk so that you can have an opportunity to ask questions and we can have a little bit of a dialogue. So we'll get right to it. Still no financial disclosures. I don't know, Ed Lim, how long this will take, but hopefully one day. I'm kidding. So our talk my talk today will focus on, okay, so Marilyn, you have your hand raised. Sorry, do you have a question? Or not yet? Okay. So we'll talk about definitions in uveitis, common causes, as Dr. Lim mentioned, and then I'll outline neoplastic, which means cancerous causes of masquerade uveitis, as well as non-cancerous or non-neoplastic. And then I'll give you some examples. So just a little bit about why I'm so excited about uveitis and why I continue to do it. And everyone who works with me knows how complicated it can get. But even though it's such a rare condition, it turns out it contributes to about 20% of blindness in the US. So we've got a lot of work to do to make sure we treat these patients and treat them well and give them the best opportunity at maintaining good vision. And I thank all my techs who work with me, who help me in that on a daily basis. So once in a while, we have a patient walk into clinic who comes in complaining of a red, painful eye and with light sensitivity that is very significant. So red, painful eye with photophobia. And, I say anyone who tells you that my eye's red, it's light sensitive, it's painful, one of the things that should go through your mind is this uveitis? The first thing is probably a corneal abrasion. We see those a lot and they cause a red, painful, light sensitive eye. But once you rule that out with history, you can think about uveitis. The other important thing is if a patient does complain of a red, painful eye, ask them when their last eye intraocular surgery or intraocular injection was, because we definitely want to make sure we're not missing endophthalmitis in our red, painful eye patients. Anyone want to type in the chat? What do we see down here? I can't even see the chat. Perfect. So thank you, Sarah. So that's a hypopion. And there are different types of uveitis that give us hypopions. The most common one is HLA-B27. So you might see that in the notes of the patients that you're talking about, or they might tell you, yes, I have something called ankylosing spondylitis, or you might actually be the first one to diagnose that they may have HLA-B27. So the questions I do ask my uveitis patients are, do you have morning stiffness? That's usually concentrated on the neck and their lower back. And then the key about this type of stiffness is it actually gets better the more they move. So they'll say, yeah, my mornings are tough. I'm stiff. I try and get out of bed. And then by the time I've been walking around after an hour or so, I feel great and much better. And so that's the key about HLA-B27 or ankylosing spondylitis type arthritis or arthropathies. Another condition that's a little bit more rare than HLA-B27 is called Behçet's, and we see hypopions in that. And then the herpes infections in the eye can give us hypopions, and of course endophthalmitis, which I mentioned briefly. So what's going on on this cornea? Again, we all can put a quick note in the chat. And awesome. So Kelly, thank you. So these are KPs, and these are large KPs that we see on this endothelium. And I didn't give you a whole picture of the cornea, but you can kind of appreciate that they may form almost like a triangle if you could imagine the whole cornea in view. And this we call Arth's triangle. And the reason we tend to have a concentration of KPs or keratic precipitates in this area is because of the way the aqueous is moving in the eye. It moves with a little bit of convection currents based on the temperature between the outside and the inside of our eye. And they tend to settle there, but you can definitely see them spread out through the entire cornea. When we see large KPs like this, we think of conditions like sarcoidosis, associated uveitis, so the granulomatous diseases. And of course, we can definitely see it in severe herpetic uveitis as well, also toxoplasmosis. So some of the infections will give you these large, what we call mutton fat keratic precipitates or KPs. Other conditions, syphilis is still alive and well, even after many decades after its discovery. TB, VKH or Vogt-Koyanagi-Harada syndrome, and then sympathetic ophthalmia, which we may be seeing a little more than we used to because of how much surgery we do in the eye, and specifically vitrectomies. We've seen that back in the day when sympathetic ophthalmia was first described, it was actually more common in patients who'd had trauma to their eyes. So a penetrating injury, maybe a nail in through the eye or a projectile through the eye. But now it turns out most cases of sympathetic ophthalmia actually occur in our patients that have had vitrectomies, even just one or multiple vitrectomies. So in contrast, I wanted to show you guys another type of KP that we see, and we call this stellate KPs. The other KPs I showed you were the bigger, thicker, rounder KPs. And these KPs are very fine, and these are scattered throughout the entire cornea. And we see these in several entities. So most commonly are viral. So herpes simplex, varicella zoster, or chickenpox virus. And then in Fuchs, we see this, and then toxoplasmosis infection as well. So let's see. I just want to make sure, am I missing your hand up, Ms. Rosado? It's okay. All right. So the other findings we can see in the eye in uveitis patients are nodules. So these are also granulomatous inflammation in the iris. So you see these fine nodules on this iris, and some actually go all the way out into the angle. And then this picture here gives you a much closer view of these nodules around the pupil. When you treat the uveitis, they actually go away. So it's pretty satisfying sometimes to see when the patient comes in and they have these nodules, and then you treat them and they disappear. The conditions where I usually see them are sarcoid-associated uveitis, but you can get them in lots of different types of uveitis. All right. Anyone want to text in the chat what they're seeing here? Perfect. So thank you. So it's a hyphema. So sometimes in uveitis, we see hemorrhagic hypopion. So they have blood in them. And the conditions in which we see this is herpetic types of uveitis. So if I have a patient who's coming in with the symptoms of red, painful, light sensitive eye, and I look in, I see this hypopion with blood, the first thing that goes through my mind is, okay, is this herpes related uveitis? And I usually take, a sample of the aqueous if I need to, and send it for a PCR testing to check for the herpes viruses. So when you see a hemorrhagic hypopion, if the patient has not had surgery, has not had trauma, think about a herpetic related uveitis. And another thing that herpetic disease can do is actually sort of eat away at the iris. So if you see all these transillumination defects in the eye, you definitely should think about either the herpetic HSV or herpetic varicella type viruses. So for some reason, they damage the iris stroma. And then when you retroilluminate, you can see all these defects in our iris. And sometimes we'll call it a moth-eaten iris. And early on in the disease, it can be very, very subtle. So doing retroillumination is very important. So that was a lot of anterior stuff. As we look into the back of the eye, and when you work in a uveitis clinic, or when you suspect any uveitis, even if you see a patient who's telling you 100% the uveitis is in the front of the eye, it's always worthwhile dilating, because oftentimes you'll be surprised by what you see in the retina or in the vitreous, and then that changes your testing, that changes your diagnostic your diagnosis or your differential diagnosis actually. And then of course it changes your treatment. So in this case, we see these little condensations of inflammatory material, and these are in the vitreous, and we call them snowballs. And then when they're all the way on the pars plana, this is called a snowbank. And we see this in classic intermediate uveitis. And some of the patients you may have seen in clinic that we diagnose with pars planitis, this is what we're talking about. So intermediate uveitis and pars planitis. Intermediate uveitis is caused by several conditions. So most commonly we don't know. So idiopathic is what the fancy word we label it as. But in the cases that it's associated with illness, so 8% of the time the patients may have multiple sclerosis. So you might hear your doctors asking them about tingling, numbness, urinary incontinence. So that's very important to get that in your history. The other conditions that can be associated with intermediate uveitis include syphilis, tuberculosis, and sarcoidosis. So we always ask about those symptoms for those type of diseases. Sarcoidosis, you want to ask the patients whether they have any like nodules on their skin or skin rashes. You want to ask them about any difficulty breathing or new cough that has developed, because sarcoidosis can sometimes affect the skin, it can affect the lungs, and actually can affect every part of the body, to be honest. Alrighty. So most of what I've talked about is the autoimmune or uveitis, and then I mentioned the herpetic, but toxoplasmosis is actually the most common infectious posterior retinitis. And the history that goes along with this in patients is usually that they do have cats, handle cats, or they eat undercooked meat. And then there are other parts of the world. So for example, South America and specifically Brazil, they've published a ton of literature about toxo. It turns out that it's pretty much endemic there, and a lot of their population is exposed to toxo. Now, we don't quite know why some people will get the retinitis while others don't. That probably has to do with their own immune status and the way their immune system is working. But toxoretinitis, so anything in the back of the eye or our vitreous and retina, the symptoms that patients complain about the most are floaters, blurry vision, flashes. And so when we look in, you see that it's really hazy. And then you see this bright white lesion. So actually we call it a headlight in the fog in the uveitis and retina world. And that's exactly what you're seeing, is that bright white lesion, that's inflamed retina from the toxoplasmosis. And then the haze is because the vitreous, it has a lot of inflammation or cells in it. Another type of infectious uveitis is CMV, which was more common during the height of the AIDS epidemic. And now we mainly see it in our patients who are immunosuppressed because they're on chemotherapy. So this is a lot of retinal necrosis around with hemorrhage. And sometimes it'll be dubbed the pizza pie retina from CMV retinitis. And the treatment is either injecting ganciclovir into the eye and giving them systemic, and then if they're immunosuppressed, trying to get their immune system back working. All right, any questions about the first part of non-infectious uveitis? Or comments? All right, so the next part I'll transition to is our uveitis masquerade syndromes. So, and Dr. Lim, let me know if I'm running over time. I think I have till 1 o'clock, right?
You're fine.
All right. So masquerade syndromes is actually a term that was defined in the 60s. To describe a very specific entity. It was a conjunctival carcinoma that had presented as conjunctivitis. And since then, we've had other experts chime in, and Nussenblatt was a giant in uveitis, and he described it as conditions that present as apparent inflammation, but are actually not inflammatory whatsoever. And they may have infiltrating cells, but they're not due to an immune-mediated uveitis condition. So those are the conditions that we talked about earlier. Those are definitely uveitis because they are inflammation and inflammatory driven. So we divide these into neoplastic and non-neoplastic masquerade syndromes. And it turns out that 2.5% of patients can actually have neoplastic masquerade syndromes, and they tend to be a little bit older. So average age of about 57, but we've seen younger patients as well. And this is important because in your clinics, if you're seeing a patient come in who's in their 60s, 70s, talking about, I just developed uveitis, make sure you're always thinking in the back of your mind, could this be neoplastic? And you have to make sure you're not missing. And the most common neoplastic condition, of course, being lymphoma, if you have a patient with vitreous inflammation. So other conditions in the young children, retinoblastoma can give us this sort of pseudo uveitis, if you will, or uveitis masquerade. The hypopyon that we saw, sometimes patients with retinoblastoma can come in looking like they have a hypopyon. Patients with leukemia as well, the cells can collect and look like a hypopyon. And then multiple myeloma, lymphoma, as I mentioned. The choroidal melanomas, especially the amelanotic ones, can look like a uveitis. And then metastatic tumors can also. So we know in women, breast cancer can metastasize to the eye and give us a pseudo uveitis. And then in men, the most common one would be lung cancer. And then prostate and as well can sometimes metastasize to the eye. So in terms of non-neoplastic masquerade symptoms, I divided them into anterior versus posterior. So in anterior uveitis, actually, we just saw a patient with what's called juvenile xanthogranuloma last week. And it's a benign condition, which usually presents in the first year of life. However, the patient we just saw is in her 60s, so it can really present at any time in the patient's life, but most commonly young patients. And the ocular signs will be blurry vision and redness. And then when you look on exam, you might actually see an iris nodule. It's sort of an orangish nodule, and I'll show you some pictures of that. But what can also happen is the patients can develop spontaneous hyphemas. They can also have glaucoma eventually, and sometimes they have these characteristic skin lesions. This condition will resolve spontaneously, thankfully, but for the painful eye, we do treat with steroids, our best friend. So this is a lesion that you can see in the eye. You can see it's a little bit injected and red, but that's the lesion that we're talking about from JXG is the abbreviation for that. This patient actually presented with a hyphema, and then when you look closely, you see the JXG nodule appearing. And then here's one of the skin lesions that can appear in this condition. So you see this little one with that nodule on their chin. And then here's the same kid, you see the little JXG nodule right there. And this is one of our patients that we saw. He was 12 years old, and you see the little tannish orangish lesion here on the iris. And he was coming in because of intermittent redness and then some cells in the anterior chamber. And then we saw this lesion. And after several weeks of steroid drops, this lesion completely disappeared. And he's doing great. So the next syndrome that you all who work in the glaucoma clinics a lot might have come across is pigment dispersion syndrome. So these patients usually will complain of intermittent blurry vision. The classic is sort of the young myope who notices blurry vision when they participate in activities, sports activities, so jogging, basketball, anything that's pretty vigorous. And when you look into their eyes, you will see some sort of cells, but the important thing is they're pigmented. They're not white uveitis inflammatory cells. The patients are usually in their 20s to the 30s, and sometimes they actually do have light sensitivity when their pigment dispersion syndrome is acting up. And the treatment that you actually, the exam findings, which are important to first look at, is you can see pigment on the endothelium. So you see these little endothelial pigment deposits, which you call the Krukenberg spindle. And you can also, when you do gonioscopy, see a very heavily pigmented TM. And that gives you a clue that there's a lot of pigment being liberated. When we dilate the pupil and look at the anterior hyaloid, we can also see some pigment deposits there. So all these findings will help you move away from a diagnosis of anterior uveitis, because you'll see all these clues that, it's actually pigment liberation. And the arrow sign, just to point out all the findings we're talking about here. And then also, this is courtesy of our own Dr. Liu here. When you look, or when you do your retroillumination, you can actually see these little fine, and here too as well, you can see these iris defects. So transillumination defects, you have to take your time to really look for them. And they're classically in this area in pigment dispersion syndrome, so in the mid periphery. And then here is, when you've had pigment dispersion syndrome for a long time, or it's been pretty active, the transillumination defects are really much bigger than the ones you see in this picture, where they're really tiny. So anyone want to put in the chat why we get the TIDs, or the transillumination defects in PDS? We'll do the glaucoma techs. Any glaucoma techs in the house here who can answer that? Yeah, so Lorena said zonules rubbing against the iris, and that's exactly it. That's what's happening, is every time the iris is moving, it's rubbing the zonules, and then the pigment is being released. So thank you for that. If we don't have those signs that I just showed you, which can take some time to appear, you might be clued into the fact that in addition to the patient being myopic, this does not respond to corticosteroids, of course. And then all of you who've worked in the glaucoma clinic have seen that the treatment really will be laser. And then, I don't know what else they do if laser doesn't work, if an LPI doesn't work. We can ask the glaucoma crew later. So another thing that can masquerade as uveitis is a retinal detachment. There's a chronic RD, there's the eponym Schwartz-Matsua syndrome, where it turns out that the photoreceptors can be floating around and actually blocking our trabecular meshwork, then causing subsequent IOP elevation. So as I mentioned earlier, even if you see cells in the anterior chamber, you've got to dilate the patients, because we got to see what's happening in the back of the eye and make sure we're not dealing with this syndrome. So as always, for inflammatory or elevated IOP conditions, you have blurry vision, eye pain, and then the history in these patients, of course, you can ask them about previous trauma, or whether they're post-op patients. We know RDs can happen in our patients. And then it turns out that atopic dermatitis might be a risk factor for having this RD. And when you do your exam findings, in addition to your elevated IOP, you'll see AC cells, and then the open angles will be open on gonioscopy. And then if there is a history of trauma, you may see angle recession. And then of course, the definitive diagnosis will be made when you find your break in the retina. So, and of course, we treat the RD and then we're all good, or the patient does well. So another syndrome, ocular ischemic syndrome, which tends to give us some, which is a uveitis masquerade, and patients present with pain, redness, and blurry vision, and then they might describe intermittent loss of vision or blacking out of the vision, which is called amaurosis fugax, and then also acute decreases in vision. These patients with OIS tend to be older because the risk factors are, cardiovascular. So if they've had atherosclerosis, uncontrolled hypertension, diabetes, these all contribute to OIS. And these are findings in a patient with OIS. So the red eye, like we talked about, and then they might have neovascularization of the iris. And you can see this is an FA imaging the iris. So you can see all the new vessels or neovascularization in this iris. And then here's a picture of it. And also they tend to develop a unilateral cataract as well. In the anterior chamber, what might make it look like a uveitis is you see some cells and some flare, and that's probably just from the compromised vasculature and the neovascularization. When you look in the retina of patients with OIS, you see all these hemorrhages in the retina, so all these dot blot hemorrhages from the ischemia. And then you can see on FA really delayed filling of the vessels here, as well as in the choroid. So when we see patients like this, what we do, the most important thing is actually to send them for carotid imaging. So you want to investigate whether there's stenosis in the carotid on that side where you're seeing the ocular ischemic syndrome, so the patient can be treated appropriately with endarterectomy if that's needed, or if the occlusion is less than 100%. So we have a condition called ocular amyloid, which really we see in younger patients, and the systemic issues that these patients will have are sensory motor neuropathy and paresthesias. And also the thing to go first is thermal and pain sensitivity. And then also the cornea. So they'll lose corneal sensitivity as well. And because they have no corneal sensitivity, as you've seen with other conditions with neurotrophic corneas, they tend to get ulcers. But on exam, we'll see amyloid deposits and tortural retinal vessels, and they can also develop glaucoma. So here's some deposits of amyloid in the vitreous here that we can see. And so you might think when you look at this, that the patient has vitreous cells, but if you put everything together, you can see here, the history of the neuropathies, corneal hyposthesia, and these, you can sort of put that all together. Here's a picture just to demonstrate what the amyloid looks like. And you'll see here, it just gives you that deposits within the vitreous. And sometimes they are in just sort of clumps versus the little dots that I showed you, or the spots that I showed you here. And then RP, or retinitis pigmentosa, is usually we see some sort of pigment changes in the retina, but there is an RP that does present with no pigment. And so in this case, this patients can also have some vitreous cells, some depigmentation, some PSC, and then some cystic macular lesions as well. And of course, in uveitis patients, they may have vitreous deposits, they may develop PSC from inflammation, and they may have CME from inflammation. So the RP without pigment might masquerade as a uveitis because of those findings. And of course, we know that in retinitis pigmentosa, these patients may have a lot of trouble with night vision. You'll do a field, you'll see defects, and then you can do your ERGs, and of course, see defects in the photoreceptor function as well. And here's an FA of that. And then one last entity I'll touch on is hypertensive retinopathy that can masquerade as a retinopathy. These patients will have blurry vision, painless loss of their vision, and on exam you might see vit-heme, choroidal ischemia, retinal edema, all of which you can see in uveitis as well. And so this is just to demonstrate several different types or levels of manifestation of hypertensive retinopathy. So remember that CMV picture I showed you earlier. Sometimes you might look at this picture and think about that. When we see pictures like this, lupus vasculopathy, which I didn't show you, can also give us these types of scenarios. So you might think it's a uveitis. And this is a milder, so around the nerve, we see damage, we see vascular attenuation. And then in this patient, we see a little bit of the vessel changes. And then of course, the cotton wool spots as well. So hypertensive retinopathy can, really damage the choroid. And then in this case, we see some choroidal infarction that can occur as well with acute hypertensive changes. So of course, taking the blood pressure will answer our question here. And then when we see retinopathy of these grades, we definitely, of course, the blood pressure, these are all hypertensive emergencies. So these patients must be taken to the ED right away for blood pressure control. And then here's the choroidal infarction. So sometimes if you see that, you might think that maybe it's some sort of retinitis or choroiditis. And so in summary, when you want to consider masquerade symptom or syndrome, when symptoms don't match up or when there's no response to standard therapy, and as you know, most uveitis, it's steroids. So if the steroids are not helping, you have to go back to the drawing board. Of course, if the steroids are making it worse, then it's a whole nother issue. They can mimic anterior uveitis, but the most common type of uveitis that masquerades mimic are posterior uveitic entities. So as I mentioned earlier, think about the age group that we're dealing with. New uveitis in the 5th, 6th, 7th decade should always raise the question of whether this is a masquerade, and specifically a neoplastic masquerade. And of course, in uveitis, it's all about the history taking and the thorough eye exam, and then all the testing that we have available to us is very helpful too. So I thank you for your attention today. All right. Good morning, everyone. I'm just checking in to see if anybody has any questions they want to ask based on the talk, or I can just leave you with a couple more pearls before you get to hear the awesome talk about diabetic retinopathy from Dr. Kaplan. All right. Thank you for the question in the chat. I will answer that. So the question is, going back to JXG, if you have only one skin lesion, what are the odds that it will never show up in the eyes? It's actually not common for a JXG to show up in the eyes. And also when it's in the eyes, it doesn't necessarily mean you'd have a skin lesion. And it turns out you can get it at all ages. My most recent JXG patient was in her 60s that I saw last winter. So really it's looking at the characteristics and, the classic sort of orangish, tannish lesion on the iris, and sometimes presents with some hemorrhage. Very rare for it to appear in the eye. And then question about immunosuppressive therapy. I did not go into therapies. I was just sort of doing an overview of how to identify uveitis, but I'll just talk about that for a couple seconds. Most of the immunosuppressive therapy that we use for uveitis is off-label, but fortunately we have adalimumab or Humira. That's the one FDA-approved medication that we have. And but you know, the most important thing to know is immunosuppressive therapy is definitely needed for most of our non-infectious uveitis, especially if it's not responding to an initial round of either topical drops or systemic steroids. And the most common identifiable cause of anti-uveitis in adults versus children, great question, Nicole. So in children, it's JIA, so juvenile idiopathic arthritis. So those children will get uveitis, especially the ones that are diagnosed under the age of 6, especially the ones who are ANA positive, rheumatoid factor negative. And we actually have to screen those patients every 3 months, even if they have no ocular symptoms. In adults, it turns out it's HLA-B27. So any adult who presents with an anterior uveitis, I recommend including HLA-B27 testing in your panel. And let's see. How common is it to be HLA-B27 positive with the presentation of uveitis? So the HLA-B27 positive individuals have about a 30% risk of developing uveitis. And then if you're testing everybody who comes in with anterior uveitis for HLA-B27, let's see, I actually don't remember that exact percentage. So I'll get back to you guys on that. I'll have Debbie send you that message because I don't know if there is such a statistic, but if I find it, I will get to you. And then what is the most important info you would like from your workup technician? All right, great question. So the very important things that techs could help us with in the beginning is really getting the symptoms. So uveitis is redness, pain, and light sensitivity for anterior uveitis. And then for posterior uveitis is your floaters, scotomas. So that's really important in history. And then, as I said, it's really a head to toe history, any fevers, chills, joint pain, joint swelling. So you can do an initial screen like that. And lots of people will create little documents to have in the office just to help with the screening. But also what's important from the technician is not to dilate the pupil or put any fluorescein in before a doctor looks at the anterior chamber. And one question was, I'm confused on the answer for immunosuppressive. So maybe you can elaborate on that a little more. And I'll take one last question so that Dr. Kaplan can come on time. It says, on our test, it asks about chronic immunosuppressive therapy should be considered in which of the following? Okay, very good. So chronic immunosuppressive therapy should always be considered in entities that we know will only respond with long-term treatment. So the systemic causes of uveitis, for example, Vodka and Naegeli-Harada's disease, Behçet's, those patients need immunosuppressive therapy right away. You have that discussion right off the bat. The other group is patients, like I said, if they're not responding to steroids, then you will transition them to immunosuppression. And thank you very much. I will hand off to Dr. Kaplan. Thank you.
So our next speaker is Dr. Richard Kaplan, board certified ophthalmologist and vitreoretinal surgeon. Got his medical degree from Columbia University College of Physicians and Surgeons, and completed his ophthalmology residency and vitreoretinal surgery fellowship at the renowned New York Eye and Ear Infirmary of Mount Sinai in New York City. He's currently with Connecticut Retina Consultants, working out of the Fairfield and Hamden offices, But as most of us know, Connecticut Retina Consultants really has a wide spread. They go from Madison, New Haven, and Norwalk, Trumbull, and down to Fairfield. So his talk is titled Diabetic Retinopathy. It's a broad topic. I don't know how he's going to do it in just an hour, but we wish him luck to do that. So Dr. Kaplan and I are going to trade seats here. We'll fire up his talk.
All right. Good morning, everybody. Thank you, Dr. Lim. So yes, my name is Rich Kaplan. I'm a retina surgeon. And I'm going to talk to you guys about diabetic retinopathy. And I'm going to try to hit on some things that hopefully will be helpful for you in the clinic in terms of, working up patients, advising the doctors that you work with. So this is a very, very broad topic, and there's a tremendous amount of things we could talk about. So I'm just going to tell you, we're not certainly going to cover everything, and there's even going to be certain treatment modalities that we're not necessarily even going to get into much detail about, but just because it's so broad. I don't have any relevant disclosures for you. So some of the questions I'd like to help answer are, what are some of the findings and complications of diabetic retinopathy? What are some of the imaging findings? What are some things that you can look for, either, when you're scribing, taking imaging? What patients need to see a retina surgeon, retina specialist, medical retina? What can be managed in the office, and how do we treat them? And how should you counsel them? And that's really an important thing. So I really want to make sure we hit on that. So very basic, what is the retina? Just got to figure out how to use this mouse. Here we go. So we got the front of the eye, we got the back of the eye. And the retina, the way I describe it to patients, it's the orange wallpaper on the inside of the back of the eyeball. And it functions as the film in the camera. And, we can think of the eye as a camera. That could be helpful for patients. You got the lens in the front, the film in the back, and the information goes to your brain through the optic nerve. And that's kind of like the cable connecting the camera to your TV, or I guess nowadays your computer. And so OCT is a very important thing we use to look at the retina. And I just wanted to touch on what a normal OCT looks like. And so I like to think of an OCT image like this as sort of like a piece of cake, where you're looking at the layers of the cake from the side. And that's something I definitely use to describe it to patients. And it's helpful to understand. We have the inside of the eye, the retina are these sort of gray stripes. And then the white line is where the retina will meet the wall of the eye, or the choroid. And so, you can look at this, there's a lot of images online, but all the different layers that are useful for us when we get more advanced interpretation of OCT. But I'm going to show you some not normal OCTs. So I at least wanted to show you a normal one. Okay, again, normal. This is an Optos photo of the retina, and this is a fluorescein angiogram of the retina. And these are both pretty normal. We have the optic nerve in the back, the macula is here. And then over here, we get to the anterior retina. Okay, so if we remember, the eye is round, and the optic nerve and the macula are in the back, and then the anterior retina is towards the front of the eye. Okay, and then with a fluorescein angiogram, we're injecting a yellow dye into a patient's vein, and we're looking at the circulation. So you see all these red blood vessels here appear white, and that's due to the fluorescence of the dye. And this is how it should look. Okay, we have mostly this frosted gray. Okay, we have our white lines, and we don't see anything else particularly that stands out. So you're going to see some pretty significant differences from that. Okay, so I'm going to go through some cases just to illustrate some points about diabetes. So this first patient is 67 years old. She was referred for evaluation. She has no complaints. And so one of the things that we can kind of hit on, and I wish we could be a little bit more interactive. I don't even know how to see questions here. Dr. Lim, is there any way that I can monitor for that? Or I don't know. We'll have to do them at the end.
Yeah.
Okay. All right. Sorry, guys. We'll definitely hit some questions at the end, but I would love to ask you, what questions should you ask? So one of the important questions for a diabetic patient is, what's your hemoglobin A1C, which is the measure of their sugar over a period of months. And that can really give you an idea of how they're doing with their diabetic control. You can also ask them other medical issues, certainly important. We'll talk about that, like high blood pressure, very important. Are they taking insulin? How long have they had diabetes? So these are all very important questions, certainly for the doctor when they start to evaluate the patient's risk factors. She's 20/20. She has some cataracts, but she is otherwise pretty happy with her vision. And here we're going to look at her OCT. Okay, so on the top, we have the right eye, okay, which you could tell because the arcade vessels go out towards the ear, and that would be the right ear over here. And this is the left eye. And the left eye looks pretty good. It looks pretty similar to the one that we looked at before in terms of normal. And the right eye, we're starting to see some things. We see this white spot here. We see these gray blobs over here. So at least we could say this is not perfectly normal. And another clue that you can look at, whether you're, helping to scribe OCTs or you're taking them, is this red-free image. So this image is very, very useful as a very quick early way to screen. So when we look at that, we see multiple dark spots here. Okay, we're going to see in a second what those are, but they're helpful. This is her picture. So as compared to the picture that we saw before, which was really orange, essentially we're seeing a lot of red intraretinal hemorrhages, okay, which we call dot plot hemorrhages. And we see that white thing that we saw in the OCT is this material here, which we call lipid. So these are important things and very common to see in patients with diabetes, particularly when they have issues like macular edema. So these are things to look for, very important. And you see very, very small white dots as well. This is on the same camera on the Optos. And this is just a picture that's done without red. It's a red-free picture. And that's pretty easy to do. And I actually was meaning to remember how to do it. But it's basically like, I think you hold control and you scroll, but it's easy to look up in the Optos manual how to do it. But as you could see, the hemorrhages are really much easier to see. Okay, so if you have any role in screening or entering images, this is a very useful tool for diabetic retinopathy. And here's the fluorescein. So this is obviously much different than the one I showed you before. You have all this whitish change out on the sides. And if you look closely, you see all these little white dots. Okay, so the little white dots represent microaneurysms. They're little tiny outpouchings of the blood vessel. And this is called leakage. This is diffuse leakage in the retina because the blood vessels have been affected by the diabetic retinopathy. So diabetes is super duper common. I'm not going to belabor the statistics, but a ton of people have it. Okay. A lot of them don't know that they have it, which is not good because they don't get treatment. And every year there's a lot of new diagnosis. And this data is old. Okay. Now it's just getting worse constantly. It's the leading cause of blindness for working age Americans. And it's the leading cause of blindness for people of that age in the entire world. So a lot of people have retinopathy who have diabetes, and enough 4.4% have vision-threatening retinopathy, and it's only getting worse. High blood pressure is bad for diabetes. It's very important, and so when you're counseling patients about their diabetes, if they have high blood pressure, it's very important that they control it. It makes a major impact on the retinopathy. You could think about it as like a 1-2 punch. The diabetes is one hand and the hypertension is another, and it really makes things worse. And this lady has both, so that's not helpful for her. The fluorescein that I showed you, we don't have to go into too much detail about this, but one of the really helpful ways that we use it is to look for neovascularization of the retina, which I will show you shortly. If a patient has unexplained vision loss, which I will also show you. And this guiding the laser, I'm not going to go into that as much, but that used to be a very, very important use of fluorescein, much less so now. There's a lot less laser done for that, and we'll talk about that too. Okay, now this is very important. So why do patients go blind from diabetes? Okay, one of the big things is macular edema. Okay, we're gonna look at that some more, but this patient that we're looking at has a little bit of macular edema that's not affecting her yet. And it's important that she's monitored so that if it starts to affect her vision, we can treat her. Proliferative diabetic retinopathy, which we will go into, okay, involves the growth of abnormal blood vessels on the surface of the retina, and that's really bad. Okay, it can cause bleeding inside the eye, it can cause the retina to detach, and it can cause neovascular glaucoma, which is a terrible, terrible thing. It can also cause macular ischemia, which means you lose blood flow to your central vision, and then you can't see at all. So for all of these, we can treat them, and we have very good treatments. And essentially, we can prevent blindness in the vast, vast, vast majority of these patients if they have follow-up. So a key point to make to patients, and I tell every single patient that comes to see me with diabetic retinopathy, particularly more advanced, is that the patients who typically lose vision, they don't have follow-up. Okay. And I think for counseling, and a lot of technicians have a lot of very important role in counseling patients. That's super important that they know that, because a lot of these patients are sick. A lot of these patients have a lot of other things going on, and they feel good. They see well, they don't notice a change, and they say, okay, something's got to go. I'm not going to go to the eye doctor. And then they can come in and it's too late for them to be fixed. So I think they need to know you can go blind from this, but if you come and you see us, you really won't. Okay. This we're not going to go into a lot of detail about, but this is sort of grading the stages. If you ever wanted to read about it a little bit more, we talked about microaneurysms. Okay, that dictates mild, okay, NPDR, non-proliferative diabetic retinopathy. They have more than that, so some hemorrhages, then it's moderate. And severe is this 4-2-1 rule. So a lot of hemorrhages in all four quadrants. Venous beating, again, a kind of a higher level concept, or this intraretinal microvascular anomalies. And so that's just kind of how we use to grade these things. PDR, we're going to go into shortly. Okay. This is a very busy slide. This is a very complicated slide. I'm really putting this up here to say that there's a lot of thought that needs to go into the patient's follow-up, and there's a lot of consideration. So if we just focus on these three columns here on the left, all right, based on the grade and whether or not they have swelling in the macula, it gives you some guidance as to how soon they need to come up. But it's pretty frequent if you look here, okay, particularly at more advanced stages. These patients should not be seen every 6 months or a year, because if there's a problem, you want to be able to fix it. Okay, so for our lady, she's 20/20. She has a little bit of swelling, which we'll show you a little bit more. And she does not have any proliferative disease. So we're going to see her pretty shortly, a couple months. All right. And this is dictated by this study, where it tells us that if somebody has some swelling, but their vision's good, we can safely watch them, and they won't do worse as long as we treat them if their vision starts to drop. So she comes back, uh-oh, this looks a lot worse here. Okay, so now the OCT, we still have that white stuff, but now we see these black pockets of fluid inside the retina. Okay, now that is what we call macular edema. All right, this fluid should just be inside the eye. It should not be within the retina. When you see black blobs in the retina, something is wrong and it's swelling. Okay, so now, good thing we saw her, because she's getting worse. All right, she has a little bit of a drop in vision. So what are we going to do? We're going to treat her with anti-VEGF therapy. All right. Now, many of you, I'm sure, have heard of anti-VEGF therapy. We have all of these drugs over here. We don't use this one anymore. This one's new. But to suffice it to say, they block the chemical VEGF. All right. So the way I describe it to patients is the retina is sick. It doesn't have good blood flow. So it makes this chemical. It's trying to help itself. But that chemical causes problems. Causes abnormal blood vessel growth, and it can cause some swelling. So these drugs, they block that chemical, they intercept it. All right, so that's what we're going to do for this lady. She looks better, looks much, much better. Her vision's better. Okay, so we'll just watch her. We'll have her come back in 6 weeks. Uh-oh, now the right eye's worse again, and now she has new swelling in the left eye, which looked just fine. So we're going to treat her some more with injections. I know you had a talk on injections earlier today, and she's better. All right. So these types of patients, we can treat them, we can make them better. They need close follow-up. Okay. So a patient with macular edema, this is a good patient, that needs very good close follow-up with, a comprehensive ophthalmologist, or referral to a retina specialist for potential treatment. Okay. Case 2, 30-year-old lady. She's had diabetes for 10 years, and she reports some floaters for about 6 months. Here's her photo. So as compared to our earlier photo, we see a lot going on here. There's this white tissue, and we have all these squiggly abnormal blood vessels. All right, this is all abnormal. And we could see really well on this red-free photo, it looks like there's almost like little spider webs growing. Okay, and this is the neovascularization, the abnormal blood vessels that we have been talking about, and these are a problem. Really very, very striking in her left eye. You see we have almost all these little branching networks, okay, that really have no business being there, and they're really obvious here, okay? So she had some treatment with another specialist. She had some injections, and she had a little bit of laser. And the laser works in a little bit of a different way on the same pathway. We laser the peripheral retina, and that's going to keep that retina that's sick from making the VEGF chemical. Okay, we can also give the patient injections, but laser works in that regard, a little bit further up the chain. So she comes in as emergency, and she has all this blood in her right eye. And that's when I first saw her, and I said, uh-oh, she's going to need surgery. But we gave her an injection, and she did really well. And then we added more laser, and this is about a year and a half later, and she's doing well because the laser shuts down the production of that chemical, which drives that blood vessel growth. Now, if she had not had treatment, she would have done really, really badly. Okay. Kind of going to skip over this. This is just basically saying instead of laser, people can come for periodic injections, and there's an algorithm for the way that we approach that. So this is a case of we're kind of getting worse and worse. Okay, if patient doesn't have follow-up, how bad can it get? So we're getting pretty bad here. This 38-year-old woman, very unfortunate, very sick lady, and she comes in with blurry vision in her right eye. All right, now we see that whitish tissue the last patient had, which didn't get too bad, is a lot more here, and she's got some bleeding. Okay, now those blood vessels that we see are fragile, and they're connected to the vitreous gel, and they can break and bleed. And so now we're starting to get some trouble. So she had some treatment with another doctor. She had a little bit of treatment. She had an injection, and she had some laser. But here's her FA before we get to that. Now, remember that frosted kind of glass that we were looking at, that sort of gray with the first fluorescein? This is black. Black means there's no blood flow. So this is a really ugly looking picture for her. So despite her treatment, her good eye, the left eye, now has all this sort of white material and now has bleeding. So this is not good. Her vision after more treatment was 2200 in her right eye with retinal detachment and 2140 in her left eye. So she's really struggling. So we decided to do some surgery for her. And fortunately, her left eye did very well. Her vision improved to 2050. We removed some of those membranes and blood, but her right eye is still not doing well. That eye actually got worse and worse, got to hand motion because she couldn't have surgery. She was too ill. But eventually, and this is a lot down the road, we were able to do surgery for her. You see all the laser, and that eye's improved to 2060. So she eventually did well. But sometimes you can't help somebody. It's too late. And this is this case. So this is a relatively young gentleman. He's in his probably about 50 years old. And he comes in with this kind of picture. And this is a bad picture. So what is really bad here? The blood vessels, instead of being red, they are white, okay, because there's no blood flow at all. And that's due to years and years and years of bad sugar. Now, this is one thing where we really, this is something we can't change. We can't reverse. When somebody doesn't have blood flow, we cannot restore it. All right. So this patient had some treatment. You could see some laser. But he had unexplained vision loss in this right eye. His vision loss was count fingers. He had been like 2200 and he was count fingers. So we did a fluorescein. And this is a really one of the worst fluoresceins you could ever find. So his left eye is bad, but not as bad. In the left eye, you see that there is at least a little island here of that gray color. And that's blood flow. So he has a tiny little area where he still has blood flow in his left eye. But in his right eye over here, there's nothing. This is all that dark gray. And you see that there's absolutely no blood flow in his macula, which is very sad. Now, what's even more sad is that he was lost to follow-up. He didn't come back in. And he ended up in the hospital in an emergency room with severe pain in his right eye because he developed neovascular glaucoma, which is where you develop abnormal blood vessels in the front of the eye, and the pressure can go up to 80, 70, 80. It's terrible. It's very painful. And he ended up, despite having surgery for that, he ended up losing all vision in that right eye and has no light perception. So at the end of the day, the follow-up is so important because even when somebody's in bad shape, it can always be worse. And unfortunately for him, it ended up worse. Fortunately, though, his follow-up has been very good and he's been able to maintain, I think he's 20/80 or 2100 vision in his left eye. And so hopefully he's able to continue following up with us to treat the swelling in his left eye. And that's my talk. So thank you guys for your attention. I'm going to try to see if I can open up any questions. And I'm seeing a question here. So can a patient with NPDR present with rubeosis and not have NVE in the retina? Could it be a precursor to PDR, or does it have correlation to diabetic retinopathy itself? So that's a great question. So if somebody has rubeosis, okay, so just for context here, the case we just discussed references that, the last patient who had neovascular glaucoma. So rubeosis is blood vessels on the iris, okay? So the iris is just not supposed to have any blood vessels on it at all. And when there are, we call that rubeosis, and that can lead to an outflow blockage of fluid that the eye is constantly making. So it's like you're pumping up a basketball constantly and you're not letting any air out. And so the pressure in the eye goes up tremendously. So that is a really, really, really bad thing. And the patient needs urgent treatment to prevent that kind of complication. So it's extremely, extremely rare that someone would have so much ischemia in the retina to have rubeosis with just from diabetes and not have neovascularization elsewhere. So NVE means neovascularization elsewhere. We looked at a lot of neovascularization elsewhere, okay? But that's a great term, especially if you're scribing. And so all of this is neovascularization elsewhere, but this last patient, I think, really shows us nicely what that is. And although what I was describing as those kind of, extra branches or so, this is neovascularization elsewhere. So it's highly, highly unlikely that a patient with just NPDR would skip all the way to rubeosis without having proliferative diabetic retinopathy. Now, you can have other situations where you can get rubeosis without having neovascularization, but typically there's an overlay of a vascular occlusion, like a central retinal vein occlusion. Even an artery occlusion can rarely cause that, or something like ocular ischemic syndrome, where there's poor blood flow to the eye itself due to bad blood flow in the carotid arteries in the neck. So to answer your question, very, 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 very unlikely to have that scenario where you just have non-proliferative diabetic retinopathy with rubeosis. Do you recommend an iris FA routinely when ordering an FA on a patient with diabetic retinopathy? Great question. So I do not typically do that. I think it's very, very rare that that somebody would have iris vessels that are invisible to a clinical exam. Generally speaking, rubeosis is pretty obvious in that regard, particularly when it's clinically relevant. So if I'm getting an FA, I'm typically looking for, neovascularization in the retina that's hard to see, or there's an area that's a little suspicious, but I'm not sure. Or I want to use it to assess how bad the perfusion is in the periphery, how much black we're seeing, and also to help me kind of monitor them going forward, to guide me to see after treatment if that neovascularization recurs. So in those cases, Let's say there were some tiny vessels that could show up with iris FA. I'm really probably going to get them anyway because I'm going to be treating the retina. So, I try to order tests based on how it's going to help me manage the patient. And I'm not sure in those cases how it would. If there are vessels that I see, done. Desperately needs treatment, and I'm going to take care of those. If I don't see anything, it's unlikely that I'm not going to be treating the retina if there was a suspicion that there could be. What is one of the lowest A1Cs you've seen with progressive PDR or NPR? So that's a very, very good question. That's an excellent question. So I think A1C is important to, I think is really important to help guide treatment, but it can be, a little tricky. So let's say somebody's had an A1C. So just for everybody's context, an A1C should be, for a normal person, should be essentially below 6 or something like that. I think 6.5 is the cutoff for diabetes. 8 is bad. Okay. 12 is horrible. And then I've seen patients with A1Cs of 14, 15, and that's horrendous. All right. So let's say somebody's A1C is 15 for 10 years. Okay. And then they control it. They get their life together and their A1C 7. That patient has damage. There's probably going to be significant amount of ischemic damage from when that patient had that high A1C. So I kind of describe it sometimes to patients as like credit card debt, because they say, well, why do I need treatment? And why do I need to do any of this? My A1C is good now. Well, when your A1C was bad, okay, you caused damage to the retina, to the blood flow. And that's like you're swiping your credit card, okay? And you're getting a balance. You got a balance. Now, when you get your sugar under control, that's fantastic. And it's going to keep you from being our last guy, right? That we went through our last case. But the damage that's been done is done. So you put your credit card away and that's good, but your balance still exists and we still need to monitor and treat you. So I have patients with terrible disease and their A1C, they're on dialysis that can lower their A1C, and their A1C is, 6, let's just say. I've even had some patients where after something like dialysis, their A1C is below 6 and they can have progressive disease just from the ischemia. And the other thing that we need to consider is things like blood pressure and other stuff. So as we talked about earlier, I kind of blew through it, but if somebody's blood pressure is really high, even if their A1C is good, they can still accumulate further blood loss in the retina because those blood vessels continue to get damaged. Okay. I'm not seeing any more questions. So I'm going to turn it over to
I'm not going to let you get away that easy.
Okay.
So
I want to thank everybody for their attention. I know that you watched a lot of talks today, so I appreciate you listening to mine.
all right. So I think, there were some really good points that Dr. Kaplan brought up. This is one of those diseases where you can really get the patient involved in their own success. And so, talking about their A1C, talking about their blood pressure, and I'll just put a reminder that you can ask a patient, say, how's your blood pressure? And they'll say, fine. And if you ask a simple little follow-up question that says, well, what was it last time you had it taken? Oh, it was 160/94. You go like, okay, that's not okay. So remember to always ask that other question. It's like asking people, do you have allergies? They say no, and say, have you ever had a bad reaction to a medicine? Yeah, I almost died taking, penicillin. So you always have to ask that kind of follow-up question, but getting them involved in knowing their numbers, knowing what the target numbers should be and how to get back to those numbers is a really important point. I also, in getting them involved with their own care, oftentimes I'll just, out of the blue, I'll just say, what'd you have for dinner last night? And they'll say, well, my A1C was good, but last night I had, French fries on a baked potato that was twice baked, and I had it over pasta with a sugary soda. And you go, okay, so those people, I'll actually sometimes have them do a dietary log for me. I say, I'm not going to manage your diabetes, but I'm really interested in what you eat. Could you just write down everything that passes your lips, and we'll talk about it at your next appointment. And it's more so that they can begin to learn how their food intake, their activity level really impacts what their blood sugar is. So I think, you know, the history taking, the review of systems that are kind of targeted towards a diabetic is really important. You know, I oftentimes feel like if we do our job of lasers and surgery, the patient can still end up losing if they're totally out of control with blood pressure, cholesterol, and A1C. So again, you guys play a super important part in this in helping us push that that concept. I'll also say that when you're taking that history and you're trying to find out, you say, well, how well controlled is your diabetes? And say, oh, it's really good. Okay, what's a typical A1C for you? Oh, it's like 8.2. One time I was 9, but I'm way better now. I'm like 8.1, I think was my last one. So that's important to know what their definition is, but then also their duration of diabetes. Like if somebody says, well, I'm a diabetic for 5 years, Dr. Kaplan and I expect to see a certain thing on their exam, certain level of disease on their exam. But if we see way advanced disease for a reported short period of duration of diabetes, we know something's wrong then. It's either they don't know the duration or they're really not in the control that they thought they were in. So again, I think that Dr. Kaplan has brought up some really good points. You really have to take this big bucket of knowledge that he just gave you and say, well, how am I going to translate that into my everyday, you know, starting Monday, how am I going to ask my diabetics in ways that are helpful to taking care of this patient? I will also say that I have found it helpful if you guys have already asked, hey, do you have any numbness or tingling in your hands or feet? Or have you, when was your last EKG? Have you ever had any heart problems? Because again, if we get a diabetic that says, well, yeah, I have numbness and tingling, or they say, well, I lost my toes already, or, well, I can't make my appointment then because I'm on dialysis, or, right, all those little peripheral pieces of information. So what is that? Your review of systems. All of a sudden gets really important to taking care of the patient. And if you'll kind of notice, if you compare Dr. Combo's talk about the review of systems, when somebody asked a question about that, and this review of systems is different, right? And the answers are different, and what you're probing for is different. And I also agree with Dr. Kaplan that is the delayed impact of diabetes on body systems is really something to explain. Because I've had patients in the past say, geez, I did everything you said, or that my endocrinologist said, and I'm in good control, but yeah, we're going back to the operating room, or, you know, my kidneys are failing, and they want to know why. And I always say, well, remember that first day that we met and we said, oh, it might take a while for, you know, your good control to catch up with the disease manifestation. So really, you know, that's the patient education part that you guys are involved in, to let them know kind of what to expect.
I totally agree. I mean, I think, you know, it's amazing that it's so common. I'll have a patient come in, I'll say, what's your A1C? And they'll say, I don't know. Or you say to them, how are your sugars? It was 100 this morning. And you say, okay, great, but what's your A1C? And they say, I have no idea. And how many times a day you check your sugar? Once a day. So they could be 100 in the morning and 500 all day. And despite the fact that this number, this A1C number, and it's something good to look up, we've known about this for so many years, and it's so important for managing, because there's no escaping that. If you eat, you know, a pizza, okay, your sugar was 100 and they eat a pizza and you're 500 for the rest of the day, the A1C is going to find it. But it's kind of like some diabetics kind of have the attitude, if you don't look, you know, it won't hurt you. If you don't know what your sugars are, then they're going to be okay. So we actually have the opportunity to educate them. Well, hey, listen, there's this really important number. You know, you never should say, well, what do you mean you don't know your number? You know, it's always like, well, you know, oh, well, here, let me tell you a little bit about this number. If you come back next time, you could find out. It's a really good way for you to know how you're doing. Because if you don't know that number, you really don't know how you're doing. And we really do have an opportunity. I think it's a great point to help them kind of get on board, even though they're seeing internal medicine, they're seeing endocrinology. There's so many patients who, despite all that, they just don't get it, or they haven't been explained properly, or something, and so on and so forth. And I'm just seeing a couple other messages in the chat where, you know, somebody said living with diabetes is like living with a terrorist inside their body. It's defeating. It's very, very, very hard. It's one of the hardest diseases that you could possibly have, because, you know, everything you do, you eat, you do affects it. And, you know, especially during the pandemic, I mean, people were locked in their house, you know, stressed, horrible, losing people. And, you know, you expect them that they shouldn't eat anything or have any sort of, you know, missteps. It all affects them. It's a terrible disease to live with. So I think compassion is, like this comment said, is key. It really is. It's a very difficult disease. And even though sometimes people are having complications, they're doing very badly, it's hard for them to control. It's hard. Eating is a hard thing for people to modify.
So I'll add to that. I like Gina's comment that the encouragement and compassion is key. And I think the point that Dr. Kaplan's also getting at is that all the patients are different. You know, there's different levels of understanding, different levels of being able to control things that they do. I will say that over the years, I have found that when you empower the patients to alter their outcomes, that it's a very powerful tool, because so many times in healthcare, they're just told what to do. They take this pill and come back and they feel like, I don't have any control over this. I'm only just trying to stop myself from just getting worse. But in diabetes, you can actually help empower them, actually give them some control. Say, look, when you do this, this is what your blood sugar is. When you do that, your blood sugar is something differently. And then all of a sudden, you'll watch over the time that the light goes on in their head. I was wondering, Dr. Kaplan, could you comment on these continuous glucose monitors that we're seeing more and more patients get?
I think that they're terrific. I mean, I think, you know, I've seen patients go from really terrible control to, you know, much better, especially when there's a pump that can really help them, because, you know, people are living their lives, especially people who are going to work. Okay, they're working all day, you know, having to prick your blood sugar and administer medication and so on and so forth. It's tough. I mean, it really is disrupting. So when patients can get these monitors, assuming they work properly, I mean, it still takes some work. They're not exact. Okay, it kind of gives them an idea, but depending on the monitor, sometimes the sugar is higher or lower than what the monitor says. Patient still needs to be very vigilant and very involved, but it can definitely help patients, I think, control their diabetes. I've had patients do better with them.
Yeah, very true. And I think I'm finding the same thing, that when the patients finally get that data and can understand, oh, I was under a lot of stress today. Look what my blood sugar did. And look how it compares to yesterday or last week, or look at this entire week, how I stayed in or out of range. Super important. Again, I put it under that empowerment thing with the patients, that they can see how their actions impact their blood sugar. And then from there, they can see how it's going to help them in the long run. So, you know, as ophthalmic technicians, you know, inquiring about CGM use, and are they comfortable using it? Are they successful in using it? Is an important part of the history. That's something that's more recent. For those that are not using CGMs, which there are tons of people not using continuous glucose monitors, you know, then you have to go back to your old style of questioning and see if they understand. You know, I have a lot of people, they'll come in with significant diabetic retinal disease, and you say, do you check your blood sugar? This is pre-CGMs. Do you check your blood sugar? Yep, I do. Great. How are your numbers? They're fantastic. They go, great. How many times a day do you, or no, give me an example of your numbers. Oh, like 110. I'm always 110. I say, great. And I say, when do you check it? Well, first thing in the morning, right before I eat, before I take my meds, and after I've been asleep all night.
or sometimes twice a week.
Yeah, or
They check it like once or twice a week.
even worse, right?
Yeah.
Once or twice a week,
It's
and you
like,
go, wow, okay, so we're missing a lot of data points. So again, I give that example because it's a great contrast to CGMs where it's continuous. They can know anytime what their blood sugar is doing. And I love taking the time and letting them be proud of their CGM results, where they want to show me. They'll take out their phone and glide through all the screens and tell me. And I just go, well, this is fantastic, because it's an indicator to me that they're getting more and more involved in their care. It actually makes our job a lot easier because we have to do less to them, hopefully.
Have you had any patients where you noticed that, like the first patient where I was talking about, there's patients where we don't need to treat their macular edema. They'll have some cysts on OCT. Their vision's excellent. All those patients, I tell them, listen, if this gets worse, you're gonna need an injection. Okay. But if your sugar's better, it might get better on its own. And all the time I have patients where they come back, and I tell them, I'd say, listen, the injection is not going to hurt you. It's nothing to be worried about. But no matter what I tell people, every patient is always worried about getting a shot, no matter what, until they get one, and then it doesn't hurt them at all. And then they say, fine. But so many times I've seen patients, they leave, they come back in 2 to 3 months, their sugars are better. And I show them on that picture, I show them the pictures that I show you. Look, this is better. And the technology on the OCT is so incredible that you can really show them even a subtle improvement very easily. You don't have to be experienced looking at these pictures. If you explain it to the patient, they can see. And if they see that they improved, okay, their anatomy, their body got better because they did better with their sugar, some of those patients become incredibly motivated and they never need an injection.
Yeah.
Okay. Now some people will need a treatment even if they do a good job with their sugar. That's a whole complicated topic. If somebody has very strict, sudden change in their sugars, they can actually have worsening of their retinopathy. But a lot of times, and I think to your point of empowering patients, what could be more empowering for them to look at their pictures and say, I actually made myself better.
Yeah.
And patients are really happy, when that happens. They feel
Happy,
good.
motivated, and you help place them on a road to success. And I think that, your role in this is, I don't know, I'm sure it happens quite a bit, but, we'll walk out of the room and the patient will be like, what did he just say?
Right.
And you guys are the ones left in the room to do this education coaching thing. Maybe you can say, no, see, this OCT, he said it was better. See, look, this was today, and this was last time you were here, and your blood sugar control, right? So you guys can take this information home and start using it right away and helping that patient, kind of get that security that they are doing the right thing by participating in their care.
Yeah, absolutely. You have such a huge role in helping the docs, kind of, see what they need to see on photos. Sometimes if somebody's going fast, I mean, it depends on your doctor, but if somebody points out to me something that I might not have seen, I always appreciate that. But also with the patient, I mean, let's say you work for a comprehensive ophthalmologist and a patient is getting referred to retina for diabetic retinopathy evaluation. If that patient never comes to see me, okay, I can't help them. And that patient can do really badly. If that patient leaves, I'm not saying to be terrified but if they leave knowing that they have a problem can be treated, and without treatment, that's really the only way. I mean, obviously we showed some examples, but that if they get treatment, they show up for the appointments, they're going to do well. They shouldn't be so scared in that regard. But if they don't come, things might not go well for them. I think that that's a huge opportunity. And like Dr. Lim's saying, patient in the office, there's questions, they call, so on and so forth, or they miss an appointment. I mean, these are just as important as the treatments. We have great treatments, but if a patient doesn't receive the treatments because they don't come to the appointments, or they don't know, or they don't think it's important, or whatever, they don't do well. So, we need your help for sure to make sure that these people do okay.
The other thing I'd like to emphasize too, and this may or may not be as much a part of your involvement with the patient, but the communications between, the ophthalmology office and primary care, the ophthalmology office and endocrinology is super important, and it's making sure that letters were received, letters that are incoming, or communications or labs that are incoming. We all use the EHR, and it supposedly is going to catch things for us, but it's important, when you're working out the patient, if there's a recent set of labs that came in since the last exam, it's good to pop it up and have it ready on the screen to be reviewed. And same with communications. Oh, they went to see the podiatrist, or they went to see the endocrinologist. And there's a whole other part of this talk on the systemic manifestations of diabetes. And you guys are exposed to all that, because when you're sitting there asking about review systems, you might see a cast on their foot, and you kind of should have an idea of what foot problems diabetics get, right? Again, it helps us in the overall assessment of the patient, but that's a little bit outside the scope of this talk. What else do you think is good for our technicians to be aware of? I think you did a really great job covering really the highlights of it. Hopefully all of you have something that you can take back to your offices in a helpful and useful way. Do we have any additional questions here?
Oh, yeah. Can uncontrolled hypertension, uncontrolled diabetes cause a hemorrhagic stroke? Absolutely. Yes, certainly. Certainly. So both of them affect the blood vessels, the arteries in our body, which lead to stroke. Hemorrhagic stroke, kind of is a little bit more complicated, but hypertension is a little bit more associated, but absolutely they both can, yes. Why are sugars higher in the morning after sleeping all night and lower in the afternoon sometimes? Well, so that can be a little bit complicated depending on whether the patient's on insulin and all these other kinds of things. So, if somebody's on a basal dose of insulin, depending on how that is, sugar could be higher or lower different points in the day, and how they're dosing their insulin. Typically, that has a lot to do with sort of the basal insulin dose and then the short-acting insulin that's given throughout the day to cover meals. So that's a little bit complicated. I can't say I'm going to be able to answer that so perfectly, but that's the best I would say that. How come is TR development with PDR? Does surgical intervention restore vision? That's a good question. So, I think it depends on a lot of things. So, in terms of the gross statistic for how often people get tractional retinal detachments, I think generally speaking, it's rather low, but with poor follow-up and bad diabetes, it's common enough. Now, does surgical intervention restore vision? Great question. So a lot of times, yes. And I would say the most of the time, yes. But there are certain situations where, things can get really, really complicated in the point where the patient can have retinal breaks and combined tractional rhegmatogenous retinal detachments. They're a higher risk of vision loss. And then depending on how long it's been there, that can dictate to how long, to what extent the vision comes back. That case that I presented of that sick young woman, she had tractional retinal detachments in both eyes. She didn't start that way. And I didn't really show you all the OCTs. I thought I had less time than I had, but in any event, she ended up developing tractional retinal detachments in both eyes. She had fluid under her retina in both eyes. The right eye was much worse than the left, but she ended up 20/60 and 20/25. So, that's a great outcome. It's not always quite as good, but generally speaking, we certainly hope that we will get, an improvement in vision, for patients with tractional detachments. I will tell you though, there's a significant risk of complications with tractional retinal detachment surgery. Depending on the severity, the more severe, the higher the risk. But there are rare cases where they could even be inoperable, or I'll look at a patient, I'll see no blood flow, I'll see very, very severe traction. The patient probably doesn't have visual potential, and then the risk of surgery is just so high that it doesn't make sense. That's rare. But it's a spectrum of disease, and the surgery. I could give an entire very long presentation about the surgery itself and how we do that and how we think about that and sort of key points to it. But really needs to be done kind of perfectly the first time, you don't really get a lot of second chances about that.
Okay. Okay, so we'll get ready for our next talk here. Dr. Rotruck. She's fellowship trained pediatric ophthalmology and adult strabismus at Yale Eye Center. She got her medical degree from West Virginia University School of Medicine. She did her ophthalmology residency at the California Pacific Medical Center in San Francisco, California, followed by her fellowship in pediatric ophthalmology and strabismus at the Duke Eye Center. So we're very happy, one, to have her here in Connecticut as part of the Yale Eye Center, two, to be another pediatric ophthalmologist in town because we need them. And third, to have agreed to join us today. This is the first time she's been speaking at the Connecticut Society of Eye Physicians, and we hope that she'll join us for many talks again in the future. So we're going to take just a moment to transition here and get set up, and then we'll get you guys tuned in. So stand by for just a moment.
Hello, I'm Jill Rotruck. Thank you guys so much for joining us today for this conference. I apologize, we've transferred my slides over to a different computer, and it looks like the font sizing has changed on here, but I think it's probably just going to be this one slide. So as you can sort of see on here, it says that we're going to talk about red eye mysteries today. So this is focused on pediatric eyes, but a lot of this translates to adult eyes certainly as well. And so red eyes are a very common thing that we see in clinic in both adults and kids. And it's really helpful to be able to try to kind of dig into what it is that might be causing that in our history and think a lot about what questions we can ask to try to draw out the cause before we even start really doing an exam of the patient. So there are a number of different causes of red eyes, and we want to think through our differential. Infectious is something that always comes to mind. Allergies are another very common cause. Blepharokeratoconjunctivitis or blepharoconjunctivitis. Traumatic causes, inflammatory, toxic chemical, neoplastic, and vascular are the main things that we're going to think about today. So our first case is of a 7-year-old boy who has got a history of redness and mild irritation of his eyes. And so the first thing we want to do is just try to take a thorough history to see what might be going on. So we want to find out, how long has he had these red eyes for? Has it been going on for a couple of days, a couple of weeks, years? Is it something that is always there, or is it coming and going, only there in the mornings, only there in the afternoons? Are there any precipitating factors? Is there anything that seems to bring on the red eyes? Every time he goes outside, for example, or every time he goes in the swimming pool, there could be any number of things that might bring them on. And then we want to ask about any types of associated signs or symptoms. So does he have pain in his eyes? Is there any itching, watering or discharge, any sensitivity to light, any vision changes? And we also want to know about any history of past medical problems. That could include acute things, acute other symptoms that he has, or any chronic conditions. And we specifically want to ask in the setting of red eyes about allergies and systemic symptoms. So I want to ask about any history recently of sneezing, runny nose. Do they have asthma or eczema, which tend to be associated with allergies? And do they have any symptoms of body-wide issues as well? Fever, headache, fatigue, sore throat, or a cough. It's also helpful to know if they have a recent history of contact with somebody else who has a red eye. Is there a giant breakout of epidemic keratoconjunctivitis at daycare or at school? And have they had any recent exposures to toxins or chemicals? Which most people will be pretty forthcoming about, but some people may not mention until you actually tell them about it. If I can get this out of the view here. Go. So, let's see. All right, so we've got a 3-day history of redness, watery mucoid discharge, gritty, itchy sensation. And we find on his exam, because we're doing a very thorough exam here at the office, that he also has redness. He's got a sore throat. We can also see on here, he's got bumps or swellings in front of his ears, in addition to his red eyes. And on talking to him, we also learned that he has been having a fever and just feeling really pretty fatigued for the last couple of days as well. And so this is most consistent with pharyngoconjunctival fever. So this is a viral cause of red eyes, and it is generally caused by one of the serotypes of adenovirus. Adenovirus has a number of different serotypes that can cause a variety of different types of conjunctivitis, including hemorrhagic conjunctivitis, this pharyngoconjunctival fever, and then, of course, the dreaded epidemic keratoconjunctivitis as well, which I'm sure you guys are all familiar with. So epidemic keratoconjunctivitis, or EKC, can lead to a very severe presentation, including hemorrhages of the conjunctiva. You can get these pseudomembranes that occur under and behind the eyelids. And those can actually be associated with inflammation on the lids that can lead to symblepharon, which is we see down here in the bottom right. And that's where the eyelid actually becomes adherent to the conjunctiva and foreshortens the fornices. And the other finding that we see with this is subepithelial infiltrates, which are these little infiltrates just in the anterior part of the cornea. They can actually impact vision though. And so while for most types of viral conjunctivitis, we're really just looking to do supportive care with tears, cold tears, especially cool compresses. Sometimes they'll respond to antihistamine for itching. In EKC, sometimes we do actually need to give them steroid treatment to help prevent things such as the symblepharon formation, or if they're having visually significant subepithelial infiltrates, sometimes we'll also need to treat with steroids for that. And so we do also need to watch the EKC patients a little bit closer. Generally for just run-of-the-mill viral conjunctivitis, we don't really need to monitor that closely. So our unlucky friend comes back. This time he's a little bit older because some time has passed, and now we've made it into the spring, and he's got some itchy, watery discharge of his eyes. On further questioning, you find out that he also has had some sneezing and a lot of runny nose recently as well. And on exam, when we flip over his eyelids, we find these fine little bumps on the backside of the eyelid. And we refer to that as cobblestoning. And this is a papillary reaction. So basically there's little vascular cores that have little edematous, kind of round edematous areas surrounding them, as well as inflammatory cells. And that's what causes these papillae. And so he has allergic conjunctivitis. This is very common. About 20% of people in the US are affected by allergies. And of people who have allergies, about 50% of them actually have eye problems associated with them. So this is a very common cause of red eyes in both adults and kids. Allergic conjunctivitis has kind of a couple different subgroups to it. Oftentimes we see perennial conjunctivitis occurs most commonly in the spring and fall. There are some people though who actually have worsening allergies in the winter, even especially if they're allergic to dust mites. Sometimes they'll actually worsen when they're spending more time indoors and the heater kicking on. And one of our more concerning types of allergy subtypes that we really see mostly just in children would be vernal conjunctivitis. So vernal conjunctivitis usually occurs most commonly in males in the second decade of life. And it is a pretty severe presentation of allergies in the eyes, in which we see these very large papillae. You can see, as compared to these very fine papillae here, how large the papillae are in that middle picture there. That's just an everted upper lid that you're seeing there. And you can see in between those papillae that kind of thicker mucus there as well. On the left side, you can see these fine little gelatinous circles just around the limbus, and they occur most commonly superiorly, but you can see them in other areas of the limbus. And those are called Horner-Trontus dots. They're just little gelatinous collections that have eosinophils in them. And they do actually sometimes have epi-defects on them as well. So there's some risk of secondary infection there. And they can be pretty uncomfortable, as can be the giant papillae that you see in the middle picture. And they do actually sometimes lead to corneal scarring. So you may actually see, after somebody's had vernal conjunctivitis, this kind of area of pannus up along the superior cornea that will be long lasting. And then over on the right side, what you can see is something called a shield ulcer. This is basically a large epithelial defect. It's typically sterile, but of course they can become secondarily infected with bacteria. And the thought is that those giant papillae underneath of the upper lid are actually just kind of scraping over the cornea so much with blinking that they may actually pull off the epithelium in that area. And so whereas our regular kind of run-of-the-mill perennial conjunctivitis can usually be treated just with, over-the-counter, or you can send in prescription antihistamine mast cell stabilizer combo, something such as Pataday or ketotifen. We usually need to use some level of steroid, oftentimes in vernal conjunctivitis. And some of these kids may even need some steroid sparing agents if it's severe, such as Restasis, in addition to also giving them an antihistamine and mast cell stabilizer. All right, so now our friend comes back again in August. He's got these red eyes again. He is just an unlucky gentleman here. And we're going through our history again, thinking, well, does he have a virus? He came in with red eyes for virus before, but no, he doesn't have any systemic symptoms of a virus. And then we want to ask him about, could this potentially be related to his allergies? Because we know he has this recent history of allergies. He doesn't really have any sneezing or runny nose anymore. And he's not really having itching at this point. On further questioning, we want to find a little bit more about the timing of it. So when do the eyes get red? Are they red all the time? And he says, really, it's worse in the morning, but can have it really kind of chronically red somewhat throughout the day, but it's just worse when he first wakes up in the morning. And we ask about any other associated symptoms. He does note that he does have a little bit of crusting on his lashes, especially when he wakes up in the morning. And so we take a closer look at his eyes here, and we find that he has pretty significant anterior blepharitis there with scurf along his lash line. And so he's diagnosed with blepharitis and just recommended as a starting point to start with No Tears baby shampoo, warm water lid scrubs twice a day, since it is pretty severe blepharitis. And then he's sent away and told to come back in about 6 weeks just to check in and make sure that he's actually looking better. So when he comes back, he really isn't feeling better. He's actually feeling a good bit worse, and his eye actually looks even redder than it did before. So the first thing we want to know is, how is he doing with our treatment that we started him on? And it turns out that he had tried to do those lid scrubs one time, said that they burned, and that was it. Parents didn't want to try it anymore after that. They didn't want to upset him. So he didn't actually do any lid scrubs. And he actually has progressively over time had more of this crusting in the morning, feeling a little bit more uncomfortable. You ask about some additional associated symptoms, if there's anything else that's bothering him. And he does note a little bit of blurred vision in that right eye. And he's really a lot more sensitive now when he goes out in the sunlight than he was previously. He doesn't have any other systemic symptoms going on, though. He doesn't have any signs of viral illness or allergies at this point, and he's otherwise been well. So on his exam, he is noted to have this little infiltrate. See if I can get this mouse to work. There we go. Here, as well as some corneal neovascularization extending in here at about 4:30. And then you also note that he's got this kind of older circular scar here, as well as a couple really small infiltrates down here at the bottom. Some fluorescein stain is put in, and he does have really extensive punctate epithelial erosions. And so now he's actually diagnosed with blepharokeratoconjunctivitis, which is commonly seen in association with blepharitis. And there can be multiple manifestations. Some people just have pretty severe blepharitis with this and conjunctivitis, but then a number of patients will actually get corneal findings associated with this. And this is something that really has a predilection for children. There is still a lot of study and debate about exactly what it is that causes this, but there does seem to be a connection between potentially bacterial colonization on the eyelids. It's not really considered an infection per se, but more of a overactive immune response to bacteria around the lids and lashes, and possibly to bacterial toxins. And then there also is a belief that Demodex may play, the parasite Demodex, which we commonly see in older adults, but that may actually play a role in this in children. And these children frequently will have pretty significant anterior blepharitis, but also frequently will have pretty significant posterior blepharitis. So they'll also have a lot of meibomian gland dysfunction. A lot of them will get recurrent chalasia with them as well. And so when we have kids who have blepharitis, especially with recurrent chalasia, even though we don't usually get too worried about chalasia in general, in our younger population, we do have to be a little bit concerned about making sure that they don't actually have blepharokeratoconjunctivitis, because this can actually lead to a pretty severe presentation with pretty significant corneal scarring from it, and sometimes even with corneal thinning to the point of rupture, which is rare, but can certainly happen. And so these patients are generally treated with aggressive lid hygiene, usually no tears baby shampoo. We oftentimes will add in a hypochlorous spray. Sometimes they'll be put on topical antibiotics or even systemic antibiotics for it. So older kids will frequently be put on doxycycline. Younger kids, we can't do that for, but they actually can respond really well to azithromycin, both systemically and actually topically. For this, we certainly need to tamp down the inflammation with steroids in a lot of these patients. And then because this tends to be chronic for a period of time, we usually will try to get them on type of steroid sparing agent as well, so that we're not exposing them to that risk of cataract development, which is a big deal in everybody, but even a bigger deal in kids, because if we get a cataract in kids, then we also risk amblyopia. There's also a risk just from the corneal changes from scarring, and also scarring induced change in refractive error, that these kids can get amblyopia on top of their other kind of more structural issues that might be blocking their vision. All right, so we get him on treatment. He's actually really doing pretty well for a while. But man, this poor kid, he comes back in December, and he's got these red eyes again, and they look pretty much the same every time he comes in. But the story is always a little bit different. And so we ask him a little bit more about what's going on. He is doing great with using all of the treatment that he's been given for his blepharokeratoconjunctivitis. And he's still on some allergy drops as well, because his allergies kicked up in the fall again. And he really doesn't have any symptoms of itchiness at this point. And he doesn't have that burning sensation of his eyes anymore. But he just complains about being really sensitive to the light, even more sensitive to the light than he was in the past. And now he has a little bit of mild eye pain. And so you go ahead and just review the rest of his history again, since he's come back. He doesn't have any new medical issues. He doesn't have really any other systemic symptoms going on. He's not tired or unwell. And you go through review systems with him. And the only thing that comes up positive is that he did have some knee pain about a week and a half ago or so, but mom's been giving him Advil like twice a day, and he's actually really doing pretty well now that he's on his Advil. And so on our exam, we see iritis. And so this kiddo actually has juvenile idiopathic associated uveitis. So he's seen to have arthritis, or I'm sorry, iritis on his exam. And now we have suspicion that that knee pain he had may actually be arthritis. So he actually gets sent to pediatric rheumatology for evaluation. And of course, we need to work up and rule out for any type of infectious cause, of course, such as tuberculosis, or much less likely at this age group, syphilis, as well as a myriad of other inflammatory causes. And so he gets a really thorough workup for that. And he comes back as ANA positive, and everything else really looks pretty normal for him. And so he's diagnosed with juvenile idiopathic arthritis, which I think is worth noting. There's a couple things that actually put kids who have JIA at higher risk of having the associated uveitis. So actually, the fewer joints that they have involved, the higher the likelihood that they'll have associated uveitis. So 4 or fewer joints is what's called oligoarthritis, and they're at higher risk. Kids who actually have onset when they're less than 7 years are at higher risk. And if their onset was less than 4 years ago, they're at higher risk. And there are a number of different ocular manifestations that can be seen with JIA-associated uveitis. In addition to anterior chamber cell, they can certainly get cell, though less frequently, inside of the posterior chamber as well. They can get cataracts associated with it, even in the absence of having frequent topical steroids, although most of these patients are going to be on frequent topical steroids. They can get band keratopathy of the cornea, edema of the macula, and then, very noteworthy, there is a 25% chance they are going to get glaucoma from this. So that all of these patients, every time that they come in, they really need, no matter what their age is, they need to have an IOP check every time. And so he actually is started on prednisolone, and he's tapered on his prednisolone. He does pretty well on it initially, and as he's tapered down, he just can't be tapered off of it and go back up on his prednisolone again and try to taper it down again, and he just can't be tapered off a second time. And so ultimately, he has started on methotrexate, and he's actually doing well on methotrexate. And so finally, we have a new patient. We're going to leave him alone for a little while. So now we have a 23-month-old who comes in with a red eye and acute onset of discharge just over the past 2 days. And so we asked some additional history. Have they ever had anything like this in the past? Have they ever had any discharge or tearing like this when they were really young? And parents say no, they haven't had any of those issues. They don't have any other ocular history. They've been rubbing at the eye, but not really complaining of pain, although they're minimally, their verbal skills are still relatively limited in this child. And you ask the parents additional questions about illness. There's no systemic symptoms of viral illness. So this patient has not had fever, runny nose, cough, been really tired or fussy. They don't have any other issues previously with nasolacrimal duct obstruction. And on additional questioning, you do find out, though, that there have been some other children at daycare who have been diagnosed with bacterial conjunctivitis. So this is really common in young kids. It's estimated that probably about 50% or so of conjunctivitis in kids is bacterial. And so this is something that certainly comes to mind when we have red eyes in kids, especially when it's associated with thicker discharge. There was a study done by Meltzer et al. That actually looked at whether or not certain factors were associated with culture positive discharge in kids who came in with conjunctivitis and discharge. And so what they found was that for these 4 factors, age 6 or more, they present in April to November, they have no or watery discharge, and if their eye is not glued shut in the morning, if they have 3 of those factors, about 76% of them are going to be culture negative. If they have 4 of those factors, 92% of those patients are going to be culture negative. So this is, I think, at least worth considering. If they have 4 of those factors that are negative and nothing looks really concerning, it's probably not bacterial. We really probably don't need to be starting these patients on antibiotics for it. The most common causes of bacterial conjunctivitis are probably about what you would expect. So strep species, Staph aureus, Moraxella, Haemophilus influenza, although that's much less common now because of vaccination. But we certainly can start children on antibiotics when we do suspect that it is bacterial in nature. These are generally self-limited infections anyway. Within 2 weeks, the vast majority of them will go away without any treatment. However, we can limit that to really only a couple of days if we give them some type of antibiotic for it. So usually a relatively broad spectrum like polytrim or fluoroquinolone will treat this pretty effectively, and we can get rid of their symptoms a lot faster and also help limit the spread in a group who is less likely to practice excellent hand hygiene. So now we've got another kiddo who's coming in with pretty significant conjunctivitis. This time we've got a 4-day-old who comes in with a red right eye and really pretty copious discharge. And you can see a large degree of chemosis or swelling of that conjunctiva in there. And so you ask your history. The baby was just born, of course, 4 days ago by spontaneous vaginal delivery. He was born at 38 weeks, 5 days, 7 pounds, 4 ounces. So nothing really concerning there. Mom said no concerns for her during the pregnancy or delivery, but she does say she didn't actually have any regular prenatal care for this baby. And she doesn't have any known health history herself that she's aware of. She said she didn't have any known history of sexually transmitted diseases. So we do get a bacterial culture though, because that's pretty significant discharge. So we want to see what might be going on there, especially in a newborn baby. And he's actually found to have gonococcal conjunctivitis. And so there's a kind of a whole series here of different things that we want to think about when we're thinking about newborn babies and what they may have causing their conjunctivitis or red eye. Usually it's going to be time related, although they don't necessarily exactly respect these times. But Neisseria gonorrhea usually will appear in about 3 to 4 days, whereas chlamydia takes a little longer, more like 5 to 10 days. And then herpes simplex, usually about a week or 2 until that actually appears. Gonorrhea is known to have what's called a hyperacute presentation. So it'll come on really pretty fast and they'll just have really extensive amounts of discharge from it. And one of the things that's really concerning with gonococcal conjunctivitis is that it can actually lead to corneal melt and you can actually get rupture of the anterior chamber from it. So this needs to be treated expeditiously. It's also really important to treat it expeditiously because not just can these kids have ocular complications from it, but especially in a newborn baby who has really limited immune response, they can get really sick systemically very quickly from this. So they can become septic. They can even develop meningitis from it. And so these patients actually need to be hospitalized and treated for their gonorrhea. And also generally they will treat them for chlamydia simultaneously, even before any results are back showing that that's positive. And the other important thing to note is that we also need to treat their parents for it because the baby obviously acquired this as they were passing through the birth canal. So the treatment for this is systemic ceftriaxone. Some people will actually do topical antibiotics as well if there's any corneal involvement in it. You'll also see that for the chlamydia and herpes, it's going to be systemic treatment as well. For chlamydia, it's going to be systemic erythromycin, and for herpes, it's going to be systemic acyclovir. Gonorrhea has, again, the most dramatic presentation with this hyperacute presentation, really purulent discharge. Chlamydia will also lead to copious discharge, but as opposed to being that really thick white discharge, it's going to be a little bit more mucopurulent. And then herpes is really more of a watery type discharge, and you may actually see that vesicular rash as well. Note that none of these are immediately present. So if the redness occurs right away after birth, that may actually just be irritation or redness caused by what they put in the eye for prophylaxis. Silver nitrate used to be really common. Now it's larger erythromycin, which is less likely to cause that problem, but not impossible. All right. Next, we've got a 2-year-old who is coming into clinic 5 days after she had a cataract surgery done on her right eye. And she's being brought in by her parents because she's just been kind of pointing to her eye and saying hurt for the last day or so. And so her parents said that they've been, trying to give her all the medications that they were supposed to. They were getting her moxifloxacin and prednisolone and cyclopentolate, and she's been getting her oral prednisolone actually as well postoperatively. You ask some further questions. You want to know if there's been any trauma to the eye. They say no trauma. She has been rubbing at her eye really frequently since the surgery, though. And then you just confirm, how many times a day they've been putting in the drops, and if they really feel like they've had any trouble getting them in there. And they said, well, yeah, we've been putting them in the number of times a day that you recommended, but she really fights us. And honestly, we don't really know if we actually are getting any of those drops in there or not. And so we take a look at the front of her eye, and you can see on your exam without the slit lamp that the front of that eye actually looks pretty cloudy. You can't even really get a very good view of her pupil. So being an astute tech, the next thing you wonder about in a kid with glaucoma or with cataract is, could they actually have elevated eye pressure? Because there's a really high risk of glaucoma after pediatric cataract surgery. So you get out your eye care and you put on Baby Shark, because that's the best video to make kids sit still. So you finally calm this kid down and get a pressure, and it's 9. So that seems great. So we're happy it doesn't seem like the pressure is really elevated, although you also know that on eye care, the pressure may be falsely lowered by having a thickened cornea. The corneal edema of the eye care is way less accurate. So you're not quite sure what's going on, but you're a little concerned that the pressure seems to be normal, but it's really hard to get a view into the front of that eye. And so then patients examined at the slit lamp, and we can see here that there is a pretty significant hypopyon in that eye. And unfortunately, there's not even a view to the back, but you get a B scan, and it turns out that there's actually pretty significant vitritis in the eye as well. So this patient's actually diagnosed with, unfortunately, a postoperative endophthalmitis. And so ultimately they are taken and put under anesthesia, and a tap and inject is done on this patient. Unfortunately, their infection gets treated and it goes pretty well for them. But they'll obviously need significant amblyopia treatment from their cataract, both and from the time that they've spent probably waiting for this vitritis to go away inside the back of their eye. Oh, what is... There it goes. All right, now it's progressing. All right. Next, we have a 13-year-old who's been referred for temporal redness in the left eye. And so patient comes in, and first thing we want to know is, how long has it been going on for? And so the parents note that, it's really always been there. It's just gotten more red more recently, in the last year or so, but they always noticed that there was some redness there on the left eye. No pain, no light sensitivity, no discharge, no associated blurred vision with it. Patient doesn't have any significant systemic symptoms, symptoms of allergies. And when you ask about past medical history, the only thing that the parents noticed that she had come to a laser procedure for like a red spot on her face when she was a kid, but otherwise no real issues. And so you actually ask if you can see a picture of what she looked like as a kid. And it looks like she actually had a pretty significant port wine stain on that side. But with modern laser treatments, a lot of these kids, you barely tell that they even had port wine stains, especially when they get them done in their first year of life. And so you can't even really tell on our current patient that she had this port wine stain. It's very light now. But you can see here that in the past, this was a lid involving port wine stain. And this patient actually has Sturge-Weber syndrome. And so what we're seeing here is actually a conjunctival manifestation, basically, of that port wine stain. And one of the big risks with Sturge-Weber syndrome is the risk of glaucoma. About half of these kids are going to get glaucoma, and so they need to be monitored very closely. And so on further inspection, this patient, you get an eye care, because you know that's really important to get on this patient who has Sturge-Weber. The right eye comes out as 17, left eye comes out as 29. And so we've got pretty big concern about what we're going to find in the back of the eye. And of course, then we find pretty significant optic disc cupping. And this patient is diagnosed with glaucoma from their Sturge-Weber. Sturge-Weber tends to cause glaucoma a little bit bimodally. They'll usually have it either when they're really quite young or kind of more as they get into their double digits. There's really two different main mechanisms that cause it. They can have anterior segment dysgenesis, and so those are the ones that usually it'll start when they're really young, or it can actually be from episcleral venous pressure. And that tends to have effect a little bit more as they get older. All right, and then our last patient is going to be a 3-year-old brought in with a red right eye, and the parents just know that it's looked a little bit more bulgy for the past 2 weeks. One of the important things that you think you want to find out is, did they talk to their pediatrician about this or not? Since it's been going on for a couple of weeks, did they already get treated with some type of antibiotic or anything for it? And they say no, seemed eye related. So they just called in a couple of weeks ago and said that the eye was red and got this appointment for a couple of weeks out at the eye clinic. And so you ask some additional questions. There has been some watering with it, just a little bit of discharge, but they also know that the patient's kind of having trouble closing the eye because it's so swollen in front. And so then we want to think about what would be the common things that would cause an eye that looks kind of bulgy in a patient of this age. And so think, orbital cellulitis would probably be at the top of our differential for this. So you ask if there's been any type of trauma to the eyelids. There hasn't been any trauma. Have there been any styes of the eyelids? And there haven't been any styes. And then of course, has there been any type of sinus issue, runny nose discharge, history of sinus infections? None of that's been occurring in the past. The patient is otherwise well. They haven't had a fever. They haven't really seemed sick. They just have this kind of bulgy looking red right eye. And so the doctor comes in, does an exam, and finds that they really can't move this eye around very well. And they actually do have a 3+ RAPD in this eye. And so they're ultimately sent to get an urgent scan and found to have this rather sizable mass here behind the eye. And this, rather than being what we would probably, think for most patients with a bulgy eye with that type of chemosis would be orbital cellulitis, this is actually a rhabdomyosarcoma. And this is actually an umbrioidal form. You can see the pathology there on the right side of the slide. And so this kid actually ultimately needs to have chemo and radiotherapy. And they actually did really well after their chemo and radiotherapy. All right, so that sums up our red eye mysteries for the day. Just a couple takeaway points to review here. A similar appearing red eye can actually have a really pretty broad differential, as we saw with our first patient who had so many different things going on with him, but looked basically the same as he came in. And so really a good history is frequently going to lead you down the right path to diagnosis. And you guys are, our front line for history taking, and thank you very much for doing that. It's really important to kind of try to dig into that history as much as possible. It can really help to determine what's going to need to come next on the exam, and kind of help narrow down the history taking as well. when we go in is if you've gotten all that great information, it really helps out a lot. And I just want to take some time to answer any questions you guys have from this talk. And then I've also been tasked with answering any questions from Dr. Walsh's talk that she gave on trauma this morning as well. So let me see if I can pull my Zoom back up here so I can see you guys.
Stop sharing.
Oh. Are there questions they just go in? Oh,
Yeah.
I see there's a Q&A section down here. Represents a young age and long term. Okay, so vernal conjunctivitis usually is not like a lifelong issue. It usually burns out when they're kids. They can't ask questions verbally.
They can raise their hand if they'd like.
Oh, okay. Any other questions? All right. Well, thank you guys so much for listening and for joining me. Hopefully you were eating lunch while you were listening to this lecture, and I hope you enjoy the rest of the conference.
So now we're going to move on to Dr. Lorenzo Cervantes. He's board certified ophthalmologist and fellowship trained specialist in cornea, external disease, cataract, and refractive surgery. And he works out of Connecticut Eye Specialist in Shelton, Connecticut. He graduated from Downstate Medical Center with his medical degree cum laude. He was a member of Alpha Omega Alpha Medical Honor Society, which is quite an honor to be in. He completed his residency at North Shore Long Island Jewish Health System in New York, where he also served as chief resident. And he did his fellowship in cornea, external disease, and refractive surgery at the Eye and Ear Institute at the University of Pittsburgh Medical Center. So his talk is a pre-recorded talk, but I believe that we have Dr. Cervantes for questions at the end. So go ahead and roll the video. Thank you.
I serve as a medical director for Eversight and on their board of directors. And I would also like to thank Eversight, specifically Katie Lopes, Mike Scarlett, and the marketing department for providing a lot of the material that's in this presentation. I'd also ask all of you out there that if you found something interesting in this talk, to stop by the Eversight desk, Eversight booth, and talk to meet Trish, and tell her something that you learned today. All right. So today we're going to talk about the different types of cornea transplantation and eye banking from a historical perspective. And here's my cell phone number and my email address. If at any time you have any questions, feel free to text or email, and maybe I'll even respond during the presentation. And I'll get back to you when I can. All right. Here is our outline. Most of cornea transplantation and the developments that have occurred happened over the last 100 years. So we'll try to fill in the blanks as we go along. If you hear the word keratoplasty, it comes from the Greek kerato, which relates to the cornea, like keratoconus or keratitis. Plasty refers to comes from the Greek, which means to restore the function or a body part through a surgical procedure. So keratoplasty would literally mean cornea repair. Rhinoplasty would be like a repair of the nose, for example. The first time anyone ever thought about cornea transplantation was about 200 years AD. But nobody really did anything about it until the 1800s, when the first cornea transplantation ever performed was on a gazelle, so an animal-to-animal cornea transplant in 1837. In 1838, there was an attempt to use a pig cornea on a human, which was not successful. And for years, the there was a debate on how should cornea transplantation occur. Should there be animal to human transplantation? Should it be human to human? Should it be partial thickness or full thickness? And that debate continued until 1905, when the first successful human transplant occurred. In 1905, Edward Zerm performed the first successful human-to-human cornea transplant. It was his only documented case, but this effectively ended the debate that humans were going to be donating their corneas to other humans for the sake of giving the gift of vision. Cornea transplantation continued to progress as a procedure, and the picture in the middle down here, this is a picture of Dr. Castroviejo, who arguably is the godfather of all cornea transplantation as we know it, or cornea as a subspecialty as we know it. He developed instrumentation and techniques in the 1930s, 40s, and 50s, essentially moving full thickness cornea transplantation forward. And that's the way it has been over from the 30s, 40s into the latter part of the 20th century, when things started to change. But let's pause here, because cornea transplantation really there was only one way to do it, which was a full thickness cornea transplantation for many years, and it just was a matter of refining it. When someone comes into the office with a cornea problem and is being evaluated for someone with a cornea transplant, or for a cornea transplant, we want to know if a cornea transplant is going to be worth all the trouble. So in questioning patients who are coming in for a cornea transplant or cornea evaluation, we want to know how their vision is affecting them. In modern times, we'll ask them things like, are they, how is your vision affecting you? And let patients tell us what they're feeling. That's the subjective component of it. The basis of any surgical procedure for any patient is to know what we're going to be able to give back to patients. Now, objectively, we want to find out several things and measure several things in order to determine whether or not a cornea transplant is going to be helpful in these patients. So we want to know what their uncorrected vision is, what their best spectacle corrected vision is, what their best correctable vision is, say with a contact lens or a scleral lens or an RGP, a rigid gas permeable lens. And people who have irregular corneas will see much better with a hard contact lens or an RGP or a scleral lens than, say, with glasses, because the irregularity of the cornea is masked by these contact lenses. Other things that we can evaluate in the office to see how cloudy their visual axis is for example, a retinoscopy. That'll give us a good clue whether their visual axis is clear or clean. Likewise, through a dilated exam. A pachymetry. Pachymetry is a measurement of the corneal thickness. A cornea that's very swollen, very cloudy, because it's, let's say someone who has a lot of corneal edema will have a very thick pachymetry. And on average, a normal corneal pachymetry is about 550 microns, or about 0.5 millimeter. If we have other testing available in the office, corneal topography defines the shape of the cornea, and if we're really nitpicky, we can, or have the ability to, we can measure the other aberrations that the cornea is inducing through higher order aberrometry. So when we talk about cornea transplantation or full thickness cornea transplantation, that's called penetrating keratoplasty, because the incision for the cornea transplant penetrates the full thickness of the cornea. People who get full thickness cornea transplants are corneas where the entire thickness of the cornea is involved, and the impairment, the level of the impairment of these patients is not correctable with glasses or contact lenses or other less invasive forms of corneal procedures. So we really reserve full thickness cornea transplantation as a last resort. And here's how we do a full thickness cornea transplant. This is the donor cornea scleral rim that we get from the eye bank that gets delivered to the operating room on the day of surgery. This little device is like a cookie cutter punch. We determine what size we need. We cut it out, the part of the cornea that we need. And we have a similar device, cookie cutter device, that's affixed to the patient. I'm sorry if this is disturbing for some people, but this is the best way to try to get the correct size and have everything fit just perfectly, like a manhole cover fits a manhole. This blade goes down to a certain depth, and in the next slide we'll see that
Mark, could you check the video for us? It seems to have stopped.
had just used. This eye, this cornea has a tremendous scar from prior trauma. This cornea is going to get cut out following the shape of the cookie cutter trephine that we had just used. Once the patient's cornea has been removed, the donor cornea that we had prepared previously is then sewn in. All these little purple or blue markings are marks that help us determine where to place the sutures. Most cornea transplants that I do have 16 sutures. We do our best to try to tie them evenly so as to minimize postoperative astigmatism. So as to minimize postoperative astigmatism. What we're paying attention to, this is not a cornea transplant, this is actually a cataract surgery where this lens is being implanted, but look at the red reflex, the orange light in the middle. So after, you might notice that it's orange and now it's getting dark, and it's getting darker and then it's now completely obliterated. What has happened is that this eye has lost pressure because it's open, and now all the intraocular contents like the vitreous are starting to come forward. What has happened is that the choroid within the eye has filled with blood and bled, and we call that an expulsive choroidal hemorrhage. And this is pretty devastating if this were to ever happen to us. Because we trephinate a full thickness manhole through the cornea, essentially during that time, if there's any bleeding that were to occur, which fortunately only happens rarely, but that can cause loss of vision and loss of the eye. And that's essentially what we want to try to avoid by working quickly and expeditiously. Now, when cornea transplant patients come into the office afterwards, we're always looking to make sure that it's healing properly. In the top right, this is a nice looking cornea transplant. The cornea is nice and clear. We always check pressure because patients are on steroids afterwards, and steroids for long term can cause elevation of the pressure and glaucoma. We want to check the health of the cornea, and one of the ways to check the health of the cornea is to check a pachymetry, really at every visit. Corneas that fail tend to become swollen, tend to become cloudy, and a pachymetry is a good tool to help us know whether or not the corneas are doing well. On the bottom right, patients with full thickness cornea transplants eventually have all their sutures removed. My patients start having the sutures removed at about 6 months, and every month or so after that we remove 2 or 3 or 4 sutures until they're all out. And then we start vision rehabilitation with glasses, contact lenses, astigmatism correction, further surgery. And during this time, we're always looking out for problems, right? We always look out for things like glaucoma, poor healing, infections. Patients are on steroids, topical steroids. And because of topical steroids, their immune system around the eye is essentially reduced. So we can develop weird infections. This is a patient who had a full thickness cornea transplant, and in the middle of her cornea is this white round ring. And whenever you see something white or something round, a white round infiltrate on the cornea, we always have to worry about infection. So whenever a patient who has had a cornea transplant, or any surgery really for that matter, calls with problems, in order to help determine how severe a problem this patient's problem is, it's a good guideline to understand some certain subjective things that the patient can communicate to us. All my patients are aware of what I call RSVP symptoms. R stands for redness, S for sensitivity to light, V for vision changes, and P for pain. Any severe amounts of any of these things, or any combination of any of these things, I ask all my patients to give me a call so that we can figure out what's going on. All right. Now, as cornea transplantation became more and more successful, one of the problems was that we had nowhere to get the corneas from. There was a time before me, and before probably for a lot of the cornea doctors in practice now, where the cornea surgeon would have to be on call to go to the recently deceased to harvest corneas, bring the corneas to the operating room, and have the patient on call, just like one would do for kidneys or liver transplants. In 1944, though, the first eye bank was established, and what they were able to do was to help provide corneas for transplantation. We're going to talk about eye banking in a second, but what eye banking does is they work collaboratively with the surgeons to help select good quality corneas from potential donors, and also get cornea tissue ready for surgery. All right, so in 2021, there were about 80,000 cornea transplants performed. This is down from 2019 before the pandemic, but it is more than was done in 2020. And 80,000 cornea transplants, even in 2021, is about double of all the kidney, liver, and heart transplants done in the United States combined. So this is probably the most commonly performed organ transplant in the world. And in order to have a cornea transplant done, there are a lot of moving parts involved. This slide is great. I love it. It starts off with somebody in need, and that someone in need is helped by a charitable gift, someone who's made the active decision that they're going to be an organ donor. And once that person passes, their wish, their gift is allowed to happen through all the people who work at the eye bank. That donor tissue is recovered, it's evaluated for proper, adequate health. It's then prepared for transplant, brought to the operating room, and then eventually transplanted. And then eventually, that transplant is is with that patient, and sight and independence has been restored, but there's still care there. All my patients understand that they have received a gift, and it's their job to be responsible for it. So patients often ask me, how do I know the cornea I'm going to get is good enough for me? Well, it goes through a really rigorous screening process, so that even though people who are characterizing themselves as donors, they have to have a really thorough medical background check done after the patient has, after the recently deceased has passed. We don't want to pass on any communicable diseases. Anybody who is at high risk of that, we pass on their corneas for surgical use. The tissue has to be of good quality. Yeah, so even what the eye bankers do is that they go to the recently deceased, they do an evaluation, they draw blood to check for communicable diseases. And if, while all of that is waiting and pending, the eyes are harvested. So essentially the first part of the surgical procedure is performed by the eye banking technician soon after the recently deceased has passed. The eyes are harvested and saved in this preservative. And this is what gets sent to the eye bank so that the corneas can be evaluated. And once they're evaluated, they're sent for surgical use. All right, so that's about eye banking. And again, stop by the Eversight booth if you have any questions. It's really fascinating and really interesting. I didn't know a lot of this stuff until I got involved with the eye bank, and hopefully a lot of cornea surgeons who you work with and work for appreciate this as well. All right, so eye banking really transformed things because we found out that we could actually preserve corneas, and corneas can last a while. Right now we can have corneas wait for surgery for almost 2 weeks. So we can schedule cornea transplantation on elective and predictable basis. Because we've been able to preserve corneas and hold on to corneas, we've been able to study them. And with the dawn of eye banking and the surge of really generous people who have donated themselves and their eyes, we were able to figure out how the cornea works. So in the latter part of the 20th century, we figured out how to do surgery much more efficiently, much more successfully. We understood the immunology of the eyes and learned that topical steroids reduces the chances of rejection. We understood how the cornea has different layers. And just like ogres and onions, corneas have layers too. So this cross-section under this microscopic evaluation is a cross-section of a cornea. At the very top label, 1 is the epithelium. Level 3 is the stroma, which is the vast majority of the thickness of the cornea. And level 5 is the endothelium. The endothelium is a single layer of cells, and arguably, one of the most important layers of the cornea, whose job is to act as a waterproof barrier so that the fluid, the aqueous inside the eye, doesn't track into the cornea and cause it to become swollen. And a swollen cornea is known to have what's called corneal edema. All right, now that we understood that the cornea has different layers, we started thinking, well, if full thickness cornea transplants have this gamut of problems and complications during and after surgery, can we figure out a way to replace only the layers that are problematic? And that's where people postulated in the 50s to do partial thickness cornea transplants. So in effect, just transplanting the layers of the cornea that are diseased. So full thickness cornea transplantation was essentially the main cornea transplant performed for like 60 or 70 years. And today still accounts for about 35% of all transplants in the United States and is the vast majority of transplants that's performed around the world. However, at the turn of the 21st century, there was a revolution in the revival of partial thickness cornea transplants. As our instrumentation and research got better, we figured out ways to try to transplant only the layers that we needed. So we can divide that into 2 portions. One is anterior keratoplasty, or stroma and in front of that, or endothelial keratoplasty. So for patients who have dysfunctional endothelium and corneal edema, that's what endothelial keratoplasty is for. In terms of anterior keratoplasty, this is something that is not done all that much, even in the United States, because we don't need it as much. But it became more and more popular in the 2000s as we figured out how to actually get the front part of the cornea off of the patient while leaving the posterior layers intact. And this is how we do it. It kind of looks like a penetrating keratoplasty, but we spend a lot of time trying to really carefully leave the back layer of the cornea intact. And this cap of cornea that we've removed, we're going to further remove using this air bubble, which is pushing the back of the cornea, the endothelium of the patient, backwards while we cut off the rest of the stroma. And if you notice centrally here, there's bubbles there. Those bubbles tell you that the eye is not open, that those bubbles are in the anterior chamber. So the posterior layer is still intact. We're removing Descemet's membrane here from the donor cornea. And just like before, just like with the penetrating keratoplasty, but only in the front, we're going to sew this back on. Penetrating keratoplasty, but these patients have healthy endothelium to maintain clarity of their corneas. Now, the reason for doing this is that we get to avoid opening the eye and preventing things like an expulsive choroidal hemorrhage. The problem with this is that it's a really technically challenging procedure, and Descemet's membrane is very fragile. So there might be a time when we're trying to do what's called DALK, or deep anterior lamellar keratoplasty, and we end up breaking Descemet's membrane in the patient, and we have to convert to a penetrating keratoplasty anyway. Really frustrating when that happens, and so that's a big turnoff for a lot of surgeons. But in the end, it could be a longer term It could be a solution for a patient, a young patient, who doesn't necessarily want to have a cornea transplant later on in life, should that full thickness cornea transplant fail. Now, in terms of postoperative complications with anterior lamellar keratoplasty, it's pretty much the same as penetrating keratoplasty, save for one unique one. This is called, the picture that you see here is an OCT of something called double anterior chamber syndrome, where you have your DALC graft here, and you have the patient's Descemet's membrane down here. Now, normally they should be attached to each other, but in this case there is fluid in between the two. So the Descemet's membrane never really attached to the graft. This patient will need something to force that Descemet's membrane up against the graft, like an air bubble at the time, like an air bubble in the office, or a regraft. Now, endothelial keratoplasty is where cornea as a subspecialty really has changed and taken off over the last 15-20 years. Before endothelial keratoplasty, full thickness cornea transplants were really the only thing done for endothelial disease. And because most of what we treat today, like Fuchs dystrophy or corneal edema, as the main indication for having a cornea transplant, this has transformed cornea transplantation more than really anything over the last 100 years. This is a picture of Gerrit Mellis. He's based in the Netherlands, and he described posterior lamellar keratoplasty, the precursor to modern DSEC and DMEC, in 1999. DSEC was first reported in 1999, and in 2006 he furthered that to introduce DMEC. Both of these we'll go over. DSEC, which is up here, we take like 20% of the donor cornea, and we stick that onto the back of the patient's cornea. So you'll see here there's a thickness here that corresponds to stroma and endothelium. All right, the endothelium being the important part there. The stroma is really just the carrier of the endothelium. The F down here is where we just take a single layer of cells of the endothelium with no stroma and stick that to the back of the patient's cornea. As we'll see, DMEC leads to clearer vision, faster recovery, and although both surgeries are really a great improvement over what we've had previously. So DSEC stands for Descemet stripping endothelial keratoplasty. DMEC stands for Descemet membrane endothelial keratoplasty. Interestingly, I don't think the names of these surgeries really tell you what they do. It's easy to remember that S in DSEC carries stroma. So that's just one way of remembering it. And it's easy, I show you a lot of these videos because it's easy to understand what the surgery does based on how we prepare the graft. So here's how we prepare DSEC. We take the donor cornea. We use this blade that cuts a cap, a partial thickness cap off the top. And what that does is it creates two distinct layers, a front part and a back part. So as this blade passes through, it'll cut a cap off, and this cap, as you see here, is the front of the cornea, and then on the back here is stroma facing us and endothelium on the back side, and it's this bottom part that we are interested in transplanting. So in surgery, let's see, In surgery, we are going to take that cornea. Now we're looking at the endothelium here. It's backside up towards us. We use that same cookie cutter, and we're going to make a little button of stroma and endothelial cells. Once we are in surgery, we take that back portion, which is what I'm folding here with the forceps, being careful not to touch the endothelium because they don't divide, they don't repair themselves. We have what we have, all right? So we want to be very careful with these fragile cells. We take the back portion of this cornea and we slide it into the eye. All right, so there's no big wound here. This is what's so great about this surgery as opposed to penetrating keratoplasty. And we unfold that sheet and we use an air bubble to float these cells up and make them stick to the posterior cornea. Notice here there's only one suture, which is really cool too. The vision is more predictable and there's less rejection, down from 15% to about 5%. So in terms of DSEC complications, one of the things that we have to worry about is having that graft actually stick. So in the video up here on the top right, it's not obvious, but there's an air bubble there, and there is a line that corresponds to the edge of the transplant right about here, where the transplant is displaced way up. All right, so we had to bring this patient back to the operating room, move that transplant back down, and in the bottom video, it's much more centered. Endothelium. So here's DMEC. We're getting the graft ready. Under the microscope, the technician is really carefully just peeling back Descemet's membrane, finding the edge, and we're only talking about a single layer of cells here. All right, I hope you can see that what's stained blue there is the edge of the cells. And peel it off of the donor cornea. And if it's transparent, but you can kind of see the blue edge there, that's the actual sheet of cells that we're going to be transplanting. And once we have that lifted, we stain it all blue so that we can actually see it under the microscope. Get rid of the border or the edge of it, leaving us only with a central button of tissue. And that central button, we sort of draw it up into a glass syringe, and all right. And what we have here is us peeling that central button of tissue off of the donor, and we will load that into a glass injector and inject that sheet of cells into the eye. Now, to get it to stick, we have to unfold it. It wants to scroll up, but we unfold it inside the eye. That S that you see there tells us that it's in the correct orientation, that the endothelial side is down, and we use another air bubble to make it stick to the back of the cornea. Now, as you can tell, the tissue is extremely fragile, and that leads to the potential complications of this type of surgery. On the left here, this is me preparing one of my earlier DMEC grafts when we used to have to prepare it in the operating room before eye banking really helped us with this. And if you missed it, what I did there was that as I was peeling it, as I was peeling this button of tissue, as I'm lifting it up right about here, I'm lifting it up, and I realized afterwards that I ripped the sheet of cells in half. All right. So one of the biggest things that we have to worry about during this type of surgery is actually destroying the graft tissue. I did end up using half of the sheet of cells in the patient, in the same way that I normally would, and this patient actually still ended up doing really well. But this is where the benefit of iBanking has helped. iBankers and technicians will prepare tissue much more frequently than me, and they do a much better job of it than I ever will. And because of that, I know that when I'm going into the operating room, that I'll have good tissue waiting for me, rather than have to worry about not destroying the tissue and then having to tell the patient that they can't have their surgery that day. All right, so just as with DSEC, one of the things that we have to worry about with DMEC is actually getting these cells to stick. On the day after surgery, there's going to be a big air bubble there. We know that those cells will be sticking. A week after surgery, that bubble will be gone, and that's when we check to see if those cells are sticking on their own. If they are not sticking on their own, like they are here on the left side, there's the graft, there's the cornea, and there is some fluid in between. If that amount of fluid is too great, then we have to replace the air bubble, and we do that at the slit lamp. If you were watching that video on the right side, what we're going to do is we see a transplant that is not sticking. I use a 30 gauge needle at the slit lamp under sterile technique, and we replace that air bubble in the office. We make sure that the pressure is fine afterwards. We ask them to stay in the office for about a half hour afterwards, and then they go home. This air bubble is going to last another few days or so. And after that, usually the cells really take off and do well. So with DMEC, there are some advantages of DMEC over DSEC, which is that the vision potentially is going to be a lot clearer. They have a better chance of getting to 20/20. There's a faster visual recovery from like 6 months down to like 3 months. We can work through a smaller incision, and it's relatively inexpensive. As fragile as it is, you don't need fancy machines like that machine that prepared the DSEC tissue to prepare this. However, DSEC, there is still a role for it. Not everybody can have DMEC, especially if they have anterior chamber intraocular lenses, glaucoma tubes and shunts, if they're aphakic. So in those cases, DSEC is going to be better than DMEC. This chart shows us, so that's basically where we are today. Those are the main cornea transplants that we're doing today. And this chart shows us what things have been like over the last 15 years. This green line shows us full thickness cornea transplants and how the number of them have been declining over the years. The black line shows us the number of DSECs that have been done. And here about in 2010, 2011, we start to see a white line, and that's where this white line and this blue line, that's where DMEC started to become more popular. Over time, we're seeing the blue line DMEC become more and more popular, and the black line kind of declining, so DSEC is becoming less popular. Interestingly, here I put myself in this zone between 2010 and 2011. That's where I did my training, and that's where this inflection point occurred, where endothelial keratoplasty started to outnumber the number of full thickness cornea transplants that were done in the United States. So where are we going from here? So we've gone from full thickness cornea transplants to eye banking to partial thickness cornea transplants, but yet that's not the end. It's an exciting time. We are starting to see cornea therapies that don't involve cornea transplantation at all. Patients who have progressive keratoconus, for example, have a procedure called collagen cross-linking that might prevent the need for cornea transplants in the future. For some patients with Fuchs dystrophy, they might not need a transplant, and we might just need to remove the central part of their endothelium that's diseased. There's also the possibility of stem cell transplantation in the future. What if we don't need to replace endothelium but grow endothelium instead? And there's also been work done for artificial corneas. Just a couple of quick videos. This video is something called Decimase stripping only. This patient has Fuchs dystrophy in the middle of her, which is causing some disruption of the middle of her endothelium. And what we're going to do during cataract surgery is take care of the cataract, but at the same time, we're going to peel the back layer of her endothelium off. These forceps are specially made to face upwards, so they're grabbing endothelium and peeling a central 4 millimeter area of her endothelium off. It does cause some corneal edema for several months, but we expect that the endothelium from the peripheral part of her cornea come and replace those cells, eventually clearing up her cornea. Hopefully, she will never need a cornea transplant. Speaking of artificial corneas, this is called the Boston Type 1 keratoprosthesis. It involves placing a central PMMA optic in the middle of a donor cornea button, and it's sewn on like a penetrating keratoplasty. The reason why these corneas are so difficult to take care of and why we don't see them all that often is that almost universally these patients develop glaucoma afterwards and suffer vision loss from that. Also, because this is a foreign body, a piece of plastic in the cornea, it's also prone to developing infections. So you might see one of these once in a while. They require a lot of care, topical antibiotics all the time, and watch out for glaucoma too. You can imagine it's difficult to check a pressure in these eyes. All right, I've run over my time. I'm sorry about that, Debbie. I hope you all found this interesting. There was a lot of information to cover. But you have a lot of resources here. Here's my email and my phone number again. Feel free to reach out with any questions.
Wow, that was quite the survey of PK, but very useful seeing the timeline and seeing how the different procedures evolved over time. All right, so let's move on to the next talk. The next talk is given by Patrick Cody. He's Yale Fellowship trained in retina vitreous surgery. I worked with him when he was a fellow. He's just the nicest guy in the world. Formerly of New England Retina Associates, but unfortunately he's now practicing in New Jersey, so we don't get to see him as much anymore, but just a good guy, excellent surgeon. And he's going to talk to us in this pre-recorded video about retinal surgery.
Thanks, Dr. Lin. Thanks for inviting me. Pleasure to be here. I've been enjoying the talk so far during this meeting. That nasal stimulator, I guess during the era of COVID, you can't share those among people. So that's just a cautionary thing from the previous talk. But I can't fit in everything about vitreoretinal surgery. I do post cases. I've been a little slack in the last month, being a new father of a second kid this month. But I do post cases on Instagram if that's pertinent to retina topics that we see in our clinic. So, you're all eye professionals. Some I'm going to be showing videos, so hopefully that comes across clearly for you. So if there's, kids or other people around, some may be considered a little bit more graphic. Instead of kind of going through my questions word for Word that I posted, I'll be trying to highlight in yellow some of the, the answers and of the topics that I put out there. So we can't cover the full breadth of vitreoretinal surgery, but I just wanted to give you, my main goal is to kind of give you a glimpse of what we see when we're in the OR, behind the microscope. The folks listening to this presentation are hard at work taking care of patients, but not necessarily seeing exactly, what happened to the patient when they show up for their post-op day one, post-op week one appointment. So just want to give you a little flavor of what it looks like when we're performing some of these. So we'll talk about rhegmatogenous retinal detachment repair, some macular disease surgery, some surgery related to problems or complications from cataract surgery. And then we'll talk about, if we have time, some surgical intervention related to macular degeneration. So this is one of our questions here. So there's different types. When we talk about retinal detachment, we use it as a shorthand to talk about, primarily, we're talking about rhegmatogenous retinal detachment, which is the type of retinal detachment you get from a tear in the retina, and subretinal fluid is able to get underneath that tear. And the retina detaches that way from a mechanical means. Exudative retinal detachment is more in the lines of when we're talking about posterior uveitis or central serous retinopathy or other diseases where you can have leaking of fluid underneath the retina, not caused by a break in the retina. And then tractional detachment, most commonly seen in our diabetic patients, from scar tissue pulling off the retina. And there can be a mixture in the types of retinal detachment, but in general, when we use retinal detachment in shorthand, we're talking about rhegmatogenous retinal detachment. So this case is just to illustrate that not all cases of retinal detachment ends up in the operating room. This was a 55-year-old female patient that presented in my office 4 years prior with asymptomatic inferior retinal detachment in actually both eyes, and she had a laser barricade, you can see in the right eye, for basically 360 degrees, and in the left eye as well, infratemporally. And this was just taken a couple months ago. So this would be a laser barricade for treatment of retinal detachment, but we're going to focus on cases that are more surgical. So this was another patient of mine, 85-year-old lady who came in with 1 week of vision loss in the right eye. She had hand motion vision, and you can see in this Optos photo of the right eye, you can see the retinal detachment, unfortunately, including the macula. You can see kind of the water line over here, and the OCT shows you fluid underneath the retina, and you could see the break here. This was the only break we found on exam. So we have a rhegmatogenous retinal detachment with a break at about 9:30 or 10 o'clock. So we discussed the options with her. And so just to kind of review our options here. So we have pneumatic retinopexy, which is an in-office procedure, pars plana vitrectomy, and scleral buckle. So those are the three surgical options we're going to talk about. So after discussing all the options, she elected for pneumatic retinopexy, which is a procedure we do in the office where we do a freezing treatment to the break and inject a gas bubble, have the patient position, usually face down for the first day or two, and then position with the gas bubble overlying the break so that the freezing treatment, or you can also do laser barricade the next day so that seals down. And this was her OCT picture 2 weeks later, from hand motion to 20/50 vision. And I've seen her more recently than that. Vision is trending towards 20/40. But you can see initially, she had a macula off retinal detachment. So her visual prognosis, we expect good recovery in her vision, but these patients can get close to what they were before retinal detachment, but they never quite get back to what their vision was before the retina detached in the first place, and unfortunately involved the macula. So here on this Optos picture is a little bit of a montage picture. You can see the gas bubble at 2 weeks that we injected, almost gone. So as I mentioned, this is kind of one of our in-office retinal surgeries, pneumatic retinopexy. This is one from the original paper in 1986, which described this procedure. You can see there's different ways to do this and you can stage it, but the way this described here is cryotherapy to the retina breaks, followed by injecting a gas bubble, and then positioning the patient so that the gas bubble pushes the retina back, and so that the cryotherapy can seal the break once the gas bubble dissolves. So just a general rule of thumb, so candidate for pneumatic retinopexy is, in general, again, this is kind of generalizations, and there's other nuances that we're not going to get into, but retinal detachment with few breaks and generally close together, and superior, meaning in the kind of top 2/3 of the clock hours of the retina. So in general, if it fits that criteria, this is a procedure that can be considered if the patient can position for it. There's different ways, like I said, to treat the breaks. You can treat the breaks with cryotherapy, or you can treat the break on a subsequent day with laser barricade once the gas bubble has pushed the retina back into place. In general, if you compare laser with cryotherapy for treating a retina break or tear, in general, laser has had some advantageous properties in that you get normal adhesion much quicker, where within a day, and then you get a 2 to 3 times normal seal. Twice normal seal at about 2 to 3 weeks, whereas cryotherapy, actually initially, even up to the first week, because of the edema and the swelling from the cryotherapy, the seal can actually be weaker before it starts to firm up. And there's other, theoretical advantages to laser, in that it being less inflammatory, but cryotherapy is a good option. The different type of gases, there's really 2 gases available in the United States. In Europe, there's 3, but for those that work with retina doctors, SF6 and C3F8 is a very common parlance. So C3F8 is a much longer acting gas. It can last in the eye up to 3 months, whereas SF6 can last up to about 5 weeks. So the main precaution that, we always have to think about, the thing that's going to blind the patient, is that this gas bubble can expand with 2 major things that they wore a safety bracelet for. One is if they get nitrous oxide anesthesia, and the other is air travel. So the change in air pressure from sea level to about whatever the cabin pressure is pressurized to, usually about 8,000 feet or higher, that can expand the gas bubble, which doesn't have room to expand because the eye is a closed space, so the intraocular pressure can raise to a dangerous level. So this is something we got to always be vigilant that our patients understand that when we treat. So in general, with pneumatic retinopexy, there's about maybe a 20% chance of needing additional surgery and other associated complications, but it's a good option for the right patient, in that you don't need the operating room time, and in general, less use of resource for our healthcare system. and potential savings. It also has been handy during this time of COVID when perhaps operating room time, not that we don't have operating room time, but getting patient COVID tested and the lag associated with that. This is a procedure you can get done right in the office. So it is generally less invasive than surgery, but it does also have a lower first-time success rate compared to the other options, which we'll talk about here. This was an 80-year-old male who had vision loss in the left eye for 2 days, preceded by new flashes and floaters. This is my drawing of the left eye. He had a macula off-retinal detachment with multiple breaks, including breaks, in the lower 1/3 of the retina. He had a history of multiple tears in the other eyes that were treated. So let me show you this video. If there's any problem with this displaying, please let me know. So this is, I'm just going to pause here off and on. So this is our 3-port vitrectomy system. This is a pseudophakic eye. You can see the intraocular lens here and the glimmer of that. We have 1 port that provides infusion, and then 2 ports, generally one for instrumentation, the vitrectomy tip, and the other one for lighting. So this is our vitrectomy tip. It's like a guillotine that cuts back and forth, and the cut rates have gone up a lot. Cut rates are anywhere from about 5,000 to 10,000 cuts per minute. And the reason that's important is because the vitreous is attached to the retina. And what you're doing is cutting a small piece, vacuuming it, vacuuming it, so that you can gently remove the retina without tearing more. Gently remove the vitreous without tearing more retina. Here in this video, you can see a break that we're highlighting with diathermy, which is a type of cautery inside the eye. This is another horseshoe tear. And this is scleral depression here, where we're indenting the eye to clean up the vitreous. And then this is what we call fluid air exchange, where we're putting air into the vitreous cavity and removing the subretinal fluid through one of the existing breaks. And so now the retina is flat by the air that we've placed. We laser all the breaks that we marked with diathermy, make sure the vitreous is dry, and we exchange that air with one of those gases, either SF6 or CH3F8 gas. And this is what it looks like at the end of the case with our antibiotics and steroid injection at the end. So this patient with 3.5 months after surgery, again, macula off retinal detachment. So we don't expect vision, unfortunately, going back to 2020, but regained vision to 20/60 vision. And you can see a big improvement in the OCT and starting to reconstitute the outer segments of the OCT, which for our mind tells us that the photoreceptors are starting to get organized and function better. So that was a case of we've seen so far of a pneumatic retinopexy. First case, second case was primary vitrectomy. And our nomenclature here, you'll see this PPV means pars plana vitrectomy. Fluid air exchange was the part of the surgery I showed you where we took the fluid out of the vitreous cavity and put air to flatten the retina while draining the subretinal fluid, and then SF6 gas, which is what we exchanged the air for at the very end of the case. This patient positioned face down for a week, and the gas bubble, since it was SF6 gas, was gone in about 3 weeks. Another case, this was a 56-year-old male who presented with hand motion vision, count fingers vision for 3 to 5 days in the right eye. He was noted to have a giant retinal tear, and a giant retinal tear is a retina tear that covers more than 3 clock hours, so more than a quarter of the circumference of the retina. So let me show you what that looks like here. So again, this is our 3-port vitrectomy system here. This is me putting in the ports. And here, it's a little bit of a hazy view, but you can kind of vaguely make out the optic nerve. But what's interesting is that the retina is flopped over the macula and the optic nerve. It's such a giant tear that the retina is flipped over, covering the macula and optic nerve. So here we are taking a peek underneath. This is the back side of the retina, and here we see our macula and optic nerve here. So in these cases, we need a little extra help to unfurl the retina open. This fluid that we're injecting into the eye is called PFO, which is perfluoron, which is a heavy liquid that we inject to flatten and steamroll the retina in real time during the surgery. Because otherwise, just putting air, the retina will stay kind of flipped over onto the macula. So here we have, we're doing scleral depression, indenting the eye, removing the vitreous carefully, removing even anterior parts of retina that are left over, which can be nidus for PVR. That was showing removing some anterior retina, and then under the PFO, putting laser. This is an extensive area that we have to laser for almost. This was more than 180-degree tear, so more than half the retina was torn. That's why it was flopped over and covering the macula, and you could see the backside of the retina. We remove that PFO liquid. It can't stay in the eye, and we put air to exchange, and then we exchange that air for a long-acting gas. And this is what it looks like at the end of the case after we've sutured our wounds. So 7 months later, you see that you've lost the foveal contour. This unfortunately is not an OCT exactly through the fovea, but if you take a OCT through the fovea, you've lost some contour. There is a little bit of ERM and scar tissue, but in generally, this patient did very well, 20/50 vision, and also with posterior capsular opacity, so had even improvement in vision after that to about 20/30, 20/40 vision. I want to show you another case. This will be kind of like our last in the section for retinal detachment, a 40-year-old female who had vision loss for at least 2 to 3 months prior. The reason she presented so late after losing vision is a couple of things. One is she had poor baseline vision from amblyopia in that right eye, and she was mostly relying on her left eye for most of her life. And second thing, because of COVID, she was scared to kind of get seen. So this was a case where we did a vitrectomy, but we also put a scleral buckle. I don't have a case of a primary scleral buckle, which means just doing a scleral buckle without vitrectomy. But in general, scleral buckle is a silicone band that supports the vitreous base, and you want to position them so that the brakes are mounted on the buckle so that it changes the fluidics in the eye so fluid can't get underneath the retina anymore. This is kind of a cartoon of what that looks like. So again, this is the 3-port vitrectomy system. The only thing that's different is here you can see our loops around the rectus muscle. You see the retinal detachment here. We're doing our vitrectomy. You can see the vitreous kind of fluttering as we're cutting it. This was a nice case because you can see what the buckle looks like. We started the case by putting the scleral buckle on first. So this is what it looks like during the surgery. We're tightening it to give us some indentation at the time of surgery. Here you can see the indentation. And that indentation, instead of me doing my own scleral depression or assistant doing that, provides us with our own scleral depression so we can clean the vitreous nicely 360 degrees. This patient actually had a dialysis type tear, which is a tear in the most peripheral location. Again, this is PFO liquid flattening the retina. And we ended up, this is us lasering the dialysis and doing a fluid air exchange, putting air in the vitreous cavity. And then we actually ended up putting oil in this eye. And this is what it looks like with the oil coming in. So the oil, instead of a gas, has to be removed at a further date. Here you can see the oil filling the vitreous cavity, and the sclerotomy sites were sutured, the scleral buckle trimmed, the peritomy that was made in the beginning closed, and this is what it looks like at the end of the case. So potential drawbacks of scleral buckle is, there could be short and long-term complications associated with it, including diplopia or extrusion either in the near term or late term. And they could cause issues with intraocular pressure by impeding scleral outflow again. I'm going to skip this just in the interest of time and talk about a couple macular disease cases. So this was a 72-year-old man who presented with distortion of his right eye vision for 2 months. He had 20/60 vision, but was a lawyer, prolific reader, and wanted to have something done about it. After discussing the risks and benefits, he decided to have vitrectomy with macular pucker. So macular pucker, the thing that you need to know is that the most common complaint in patients is metamorphopsia or distortion of vision. So that's one of the answers to the questions there. So again, this is a 3-port vitrectomy system. We are putting our, this is a phakic patient, so they haven't had cataract surgery yet. So you put the ports different location based on whether they've had cataract surgery before. We start off the same way, doing a vitrectomy, removing the vitreous, cleaning up some of the vitreous in the periphery. Then this is a stain we use to stain the ILM, that's called ICG stain, and this is washing it out. It helps us see the interface between the macular pucker and the ILM so that we can peel it. Sorry that it's a little bit blurry here. Hopefully not too bad on your screen. And then we manually try to find an edge and peel. This is kind of like a real time here. Not real time, but. So thankfully we've caught an edge of the macular pucker, and this one was fortunate in that it came off in a nice sheet. But this is what it looks like at the time of surgery, peeling off that membrane from the surface of the retina. So then usually we finish off the case by inspecting the peripheral retina, making sure there's no tears, and then closing up our wounds, make sure everything is watertight. So this patient did well. This was 4.5 months with macular pucker surgery. The improvement is not immediate, it's gradual. And most of the improvement is up to 3 months in the distortion, but can be improvement 6 months to even a year after surgery. I will skip this case and talk about full thickness macular holes. So this was a lady who had a distortion in vision in the right eye from a full thickness macular hole. You can see in her left eye, she started to have vitreomacular traction and then stage 1 macular hole. And she decided to go for vitrectomy for repair with membrane peel in the right eye. And her vision improved at 1 week to 20/40 and then 20/30. Her left eye subsequently, that vitreomacular traction in stage 1 hole improved spontaneously without surgery. So I had a typo on one of my questions, question 4, regarding, it's supposed to say regarding full thickness macular hole, not full thickness retinal detachment. So what's pertinent there is that, as I showed you in that case, half of the stage 1 holes can actually close spontaneously. But if you have a stage 2 hole or higher, nearly 100% of those progress with further deterioration in vision. Okay, last thing we'll talk about is dislocated lenses. So this is after cataract surgery, could be many years after cataract surgery, the intraocular lens dislocating into the vitreous cavity. And there's different options for that. You can exchange that lens for different type of lenses. But the thing to be aware of is that the most common cause of dislocation is pseudoexfoliation syndrome being the most common risk factor with more than 50% of cases, but other causes are significant, like aging, trauma, or diabetes, or interestingly, retinitis pigmentosa. So this is the technique I usually perform to fix this. So this was a late 90s female who had a dislocated lens in the left eye. Let me just show you, this will be our last video here. So here you can see the dislocated intraocular lens sitting on the back of the eye, sitting on the retina. I start off with a 3-port vitrectomy, and we're grabbing the lens complex. You could see the capsule still there and soldering ring. We're grabbing it with our MST instruments with viscoelastic, placing it into the anterior chamber, cutting it in half so we can still remove this old lens through a small incision, as well as the old cortical debris. We use plenty of viscoelastic during this procedure. This is our new 3-piece lens going into the sulcus. And since we don't have any capsule support, we have to find we have to fixate that. And as I kind of glossed over, there's different ways to do that, but this is a scleral fixation technique where we, using a fine tip needle, we thread the haptics into the needle to externalize the haptic and fixate the lens to the sclera. So this is threading the haptic inside the eye on one side, and then the trailing haptic on the other. And then we're going to externalize that. And then the trick to this is once we've externalized these haptics, we cauterize the tip of the bulb so that they can't slide back into the eye. We tuck the haptic underneath the conjunctiva and sclera. Here we can see that intraocular lens. You can see one of the haptic, but once this pupil comes down, that's going to be nicely in the visual axis. Hydrate our wounds and make sure our scleral wounds are watertight. So it's a large topic, but I hope I gave you a flavor of what's involved in vitreoretinal surgery. I just want to thank Deb for putting this meeting together, Dr. Lim for inviting me, and then my team at New England Retina at the VA for this is a team sport. So thanks for everyone's effort in taking care of these patients.
Isn't that stuff just the greatest? Love that. Okay, so I want to apologize for us running over. We're about 10 or 15 minutes over, and because we have a lot of control over the program, we thought, well, maybe we'll try to cut it a little bit short. But my concern is that I want you guys to have the information that you need to answer the questions to get your CE credits. So we're going to let this run as the agenda says. Our next topic is going to be the many faces of glaucoma. And we're actually running 3 short videos. The first one from Dr. Martone. Most of you know Dr. Martone. He's our past president of the Connecticut Society of Eye Physicians. He actually served 2 terms. We're very pleased with how he led us during his time. He got his MD from Albert Einstein College of Medicine, where he also did his ophthalmology residency. He has a master's in public health in epidemiology from Johns Hopkins, and he did his fellowship training in glaucoma at Duke University. So without further ado, if we could go to the video.
So hello, everyone. Been a long day for you. I'll try to get through this and not keep you too long. So I just named this the other side of glaucoma just because so often when we think of glaucoma, we just think of pressure. And even with working with the residents and so forth, even when we know that the main cause of the glaucoma is something other than the pressure, we tend to still focus on what the pressure is. So I wanted to do something here today to highlight the other parts. I have no financial disclosures. So just to start out, a review of the optic nerve head. Can you see my cursor?
Yes.
Okay, good. All right, so the optic nerve head, there's the superficial nerve fiber, there's the prelaminar area, there's the lamina cribrosa, all right, and the retrolaminar area. So what you notice here, it's really one of the most multifactorial eye diseases because it includes so many different things. So you have nerve tissue, you have connective tissue, you have vascular tissue, all in this little area. You even have cerebral spinal fluid coming up from behind and can nourish this, but also compress it or create a negative pressure. So if we look at all these things together, glaucoma really is a very, very multifactorial condition. Here's another view of it in another way, okay? And you see the main blood supply comes from the short posterior ciliaries. There's a little circle of Zinn that goes all the way around at the nerve head here. There is also these peel arteries that penetrate into the nerve and give nourishment back here. So it's a really rich nerve supply, but it's also at risk. So if we just consider intraocular pressure first, everyone knows about that. The higher the pressure, the greater the risk. The longer the duration of the pressure, the greater the risk. The more it fluctuates, there's evidence there's greater risk. And as a single risk factor, so I'm just going to go on a slide. I'll forget my cursor. So what part of the nerve is most vulnerable to getting damage? You can see on the right side here, there are different areas of the nerve. The top right, the big fibers that come in from the periphery don't have a lot of scleral support. So the pressure in the eye is going to damage that area more. Just below that is the papillomacular bundle, which serves the macula. Those are not as susceptible to pressure, but more susceptible to vascular insults. So here's what it looks like if you have a vascular issue. I mean, if you have a pressure issue, the superior and inferior part of the nerve. So where do those fibers come from? They come from the periphery. They're hooked up to several hundred photoreceptors, come in as big fibers, less scleral support, more commonly get damaged by pressure, and the visual field you get down below is more of a nasal field. Now, what are the other? So the other side of glaucoma, all the other things that can impact it, and they're usually ischemic in nature. Low systemic blood pressure, especially diastolic, because we've become more aggressive at lowering blood pressure as we've gone along over the years. Arterial stenosis, older people have stenotic vessels. Faulty autoregulation. So with migraine, Raynaud's disease, sleep apnea, you get poor autoregulation, so you get more blood flow when you don't need it and not enough when you do need it. So that's a problem with the optic nerve. Ineffective cardiac function like arrhythmias, heart failure. So an EKG will help us to understand if there is an arrhythmia which is causing a problem with us. Poor oxygen saturation is a problem. So now if you have narrowed vessels or arrhythmias, and then you add poor oxygen saturation to that mix with sleep apnea or anemia, that adds to the risk. Sleep position can make a difference because when you're lying flat, the venous drainage from your eye is poor, so the pressure's higher. So now if your blood pressure drops at night and your eye pressure's higher, then you have a poor perfusion pressure, and that adds to the problem. Dr. Higginbotham this morning talked about central corneal thickness, which gives you a falsely low pressure reading in the eye. But I think the bigger issue with that is it tells you if you have a thin cornea, you probably have a thin eye wall, which means you probably have a thin lamina cribrosa, which may be more vulnerable to pressure changes. Tissue type is another thing, but we have never really gotten into that too much. But there are certain people who have different types of tissue that are more susceptible to causing distension and damage. Cerebrospinal fluid pressure, if you have too low of a cerebrospinal fluid pressure, it doesn't properly support the optic nerve head. Glaucoma then can happen easier. Conversely, if you have high cerebrospinal fluid pressure, you get you get papilledema, which is, in essence is reverse glaucoma. It causes pressure on the nerve head and causes nasal defects, which are in fact like reverse glaucoma. Autoimmune conditions can also cause glaucomatous changes, either because we're cross-reacting with a bacteria in our body, or there is a immune cascade that is started from the damage of glaucoma. That's beyond the scope of this talk, but it is something else that can happen. So the area that gets damaged is the papillomacular bundle, which serves the center of your vision. Now, these fibers are much smaller and they're tightly packed, and they serve a small number of photoreceptors because this is high definition vision. Small axons, tightly packed, less room for capillary support. So if there's less room for capillary support, they're going to be more vulnerable if there's a vascular insult. The damage results then in paracentral scotomas. And again, here you see the larger openings at the upper part of the lamina. Temporally there on the left, on the right side, you see small axons going through there. In the center of the nerve, there's really nothing going through there. So here's asymmetric glaucoma. On the left eye, you see a paracentral defect. And whenever you see that, you have to think, okay, this isn't just pressure, this is a vascular insult. The other clue to that on the bottom picture is an arrow. There's a notch in the nerve. When you have high pressure, you get concentric enlargement of the optic nerve head. If you have a vascular insult, you get a notch, and it's usually accompanied by a hemorrhage. So here's somebody, if you look on the right side here, who has both. They have probably a pressure defect infranasally, and they have a paracentral defect. So just because you have had pressure problems in the past doesn't mean you can't have overtreated hypertension now. Conversely, just because you have had a vascular insult doesn't mean you can't have high pressure. These tend to blend together. On the upper part of that visual field, it looks like they're separate. And as you look down below, you see supranasal change, and you see a more dense infranasal change. So these things tend to blend together over time. So what are the vascular risk factors? Low blood pressure, vascular stenosis, low oxygen in the blood. If we look at low systemic blood pressure, it really came about because of overtreated systemic hypertension. The studies on blood pressure showed that the lower the systolic blood pressure dropped, better people did in terms of secondary cardiac and cerebral events. The problem is when you do that, you lower the diastolic, and that's a problem. So when a patient comes in and says, my blood pressure is great, that's a concern. If they say it's good, that's fine. But when they say it's great, that worries me because it tells me it's probably a bit too low. These people get orthostatic hypotension. They get nocturnal hypotension, and that's when things are bad because that's when you're lying down and the imbalance between your eye pressure going up and your blood pressure dropping is a bad combination. You can do 24-hour blood pressure monitoring, or you can just have people check their blood pressure at night. Say, do you get up at night to go to the bathroom? And they say, most say yes. So before you even sit up, check your blood pressure. Have the cuff or have a wrist cuff in your bed, check it, write it down, because that'll give us the best idea of what's happening at night. So again, you can see because of this rich blood supply, if you cut that off, you're gonna make this optic nerve suffer. The arterial stenosis part of it, a lot of people have a history of coronary artery disease or cerebral vascular disease. this compounds the effect of the low blood pressure. So if you have low blood pressure, that's bad. If you have low blood pressure trying to push blood through a narrowed vessel, that's a bad combination. So you always have to think about this, especially in patients who have monocular glaucoma. Decreased blood oxygen is something we see a lot of at the VA, a lot of sleep apnea. So if you see people who have unexplained defects in their visual field, and they tend to be mid-arcuate, get a sleep study. Anemia is also enough to do it. Poor oxygen in the blood. So just end by saying, when you have people with glaucoma, remember the other risk factors: low systemic blood pressure, especially diastolic, arterial stenosis, get carotid studies, even though that only measures what's going on in your neck. But you may have to pursue it more with arteriograms. Faulty autoregulation is a risk. Think about sleep apnea, because the first thing that happens in sleep apnea, the endothelial cells get damaged. Ineffective cardiac function, get an EKG. Poor oxygen saturation, again, sleep apnea. Sleep position, sleep with their head above their heart. Tissue thickness, get a central corneal thickness. It tends to run in families also. And then cerebrospinal fluid is not a common thing, but there are conditions where that can happen. And glaucoma can also be associated with autoimmune conditions. So are there any questions about any of that? If not, I would say this, that we really need to shift our thinking in terms of glaucoma. It used to be that it was really thought of as a disease of pressure. And as we go along, we realize there's so many other factors that come into play. It's taking time for doctors to change their thinking. So as technicians, I think you can be helpful. If someone has glaucoma and has normal pressures, and if you see the fields and they have these telltale paracentral defects, you know there's some vascular component. So you can play a role in starting to get a history about cardiovascular risk factors, arrhythmias, vascular stenosis, overtreated hypertension. So I think you really can play a role in helping to elucidate the causes. So when I hear normal tension glaucoma, the first thing I think about is, why did this happen? Number two, have we identified what the cause is? Have we done anything about it? And has it made a difference in terms of halting the progress? If we just stay focused on the pressure, we'll miss a lot of the contribution that systemic factors play. And just because someone has had high pressure in their eyes doesn't mean that they can't have vascular risk factors. If you have had high pressure in your eye, it doesn't mean you can't have overtreated hypertension. It doesn't mean you can't have vascular stenosis and so forth. So if you, as technicians, can keep that in mind and play your part in bringing up some of these risk factors, you'll be helping the patients and your doctors. So oh, here we go. This one first. So one is, can long-term use of prednisone cause glaucoma? The answer is yes. So any steroid use can cause pressure rise. And it could be oral prednisone, it can be skin creams, it can be eye drops, it can be injections for back pain and so forth. So anytime steroid is introduced into the body, it can cause pressure to rise. And why does that happen? A byproduct of metabolism of steroids is the formation of glycosaminoglycans, which are large molecules which clog the trabecular meshwork. And so anytime there's steroid use, that can happen. It usually takes at least a couple of weeks for that to develop. And it usually takes a couple of weeks for it to go away, although in some cases, the pressure rise can be permanent. So the answer is yes, prednisone can. Can you go over the question about the something new agent to lower? I'm not sure if I'm reading that correctly.
Can you go over the question about the NW agent to lower EVP?
I'm not sure what the question.
Extrascleral venous pressure?
I'm not sure what that question actually refers to.
Do you see a higher
do you see-
incidence of hypotension in eyes with hypotony?
A higher tension of hypotension in eyes with no, I think hypotony can be related to a lot of things. I mean, the hypotony in the eye is either overfiltration from surgery. It can also be due, in some cases, due to ischemia, but not necessarily due to hypotension. Cornea verticillata may be seen with what? Well, amiodarone is the most common one. I've seen it with Haldol and some topical medications. You see verticillata with anything else? Those are amiodarone is the classic one though.
Okay.
Okay, I think that is everything. If there are any other questions, happy to answer them. Okay,
All right. Thank you.
thank you very much.
Our next video is done by Christy Mascarenas, who is a fellowship trained glaucoma specialist at Middlesex Eye Physicians in Middletown and Westbrook, Connecticut. She did her glaucoma fellowship at Yale University, her residency at NYU, Manhattan Eye and Ear Hospital, and did her medical degree also at NYU. So why don't we go ahead and go to the video?
Having me, Dr. Lim. Here we go. Okay, so I'm Christy Mascarenas from Middlesex Eye, and I'm here to tell you all the things you may or may not want to know about glaucoma workups for techs. So I have no financial disclosures. So why is the tech workup so important in glaucoma? One of the things you'll hear primary doctors say about their exams, and I'm talking primary medical doctors, is that you can get 90% of the information you need to make a diagnosis actually while you're talking to the patient and getting a history. So glaucoma's got a lot in common with primary care. It isn't exactly like primary care, but it actually isn't so different. So depending on what a patient says during the history, it might lead us toward or away from particular diagnoses like glaucoma versus not glaucoma. Or we might actually get a good idea of whether their glaucoma is stable or needs treatment or needs surgery. And since techs have the first contact with the patients beyond the front desk a lot of times, you get the first and best chance to establish a relationship with them and establish a basis for trust. So you also get the first chance to start digging for that gold mine of wonderful information that helps us take care of them. So going through all the parts of the tech workup, first is the chief complaint. So short and sweet, why is the patient here? Do they actually have glaucoma? Do they know they have glaucoma? If so, how long have they had it? So two basic elements of the chief complaint, what and for how long. If they're not sure, did somebody refer them for a second opinion, like a local optometrist or a primary care provider? If they were referred, what made the referring doc suspect glaucoma? Did they have high IOP? Did they have narrow angles? Did they have funny looking nerves? And how about any of the symptoms that the patient may have noticed? Do they have any pain that might make you think of intermittent angle closure? Are they complaining about blurry vision once in a while, like Dr. Combo mentioned about pigment dispersion? When somebody exercises, they might get blurry vision. Do they say they have blind spots somewhere in their vision? So sometimes different types of glaucomas tend to happen more often in different types of refractive errors. So we want to know, do they wear glasses? Do they wear contacts? If their glaucoma is unilateral, I always want to ask about a history of eye trauma, which often leads to a unilateral glaucoma. Do they have a family history of glaucoma? And then the other thing we want to know is if they do, did anyone in their family lose vision from glaucoma? Because that can run in families as well, severe types of glaucoma. So beyond history of present illness, we want to know about their medication history. When it comes to medications, of course, we care about their eye drops, including all the ones that they can remember using in the past. Now, remembering can be really hard, especially if they've had glaucoma for decades. If they can't remember the names, and a lot of times they can't, sometimes they can remember the colors of the bottle caps. So it's always nice to be able to ask about those and know in general what color is what. We definitely care about the systemic medications they're taking. A lot of those can affect the eyes. Now, I always want to know if somebody's taking chronic steroids, since those can raise IOP, but also anything that might push someone towards angle closure. So those could be almost any antidepressants. A lot of medications for overactive bladder can do that. And also over-the-counter decongestants or antihistamines for somebody who has chronic allergies. Also, since some people don't necessarily think about medications that they don't put in their mouths, I'll always ask about over-the-counter steroids in other forms too, nose sprays for allergies, steroid creams for rashes, even injections into their joints for arthritis. I have some people who respond like clockwork every 3 months when they get a steroid injection for arthritis. Thinking about all their past drop use, we always want to ask about allergies to drops too, so that we don't repeat past mistakes. So you can be allergic to any drop, but there's one that's notorious for delayed allergies. Specifically, we call it follicular conjunctivitis, and that can happen years after you start taking it. That drop is brimonidine, purple drop, purple top. So the other difficult thing about drops is adherence, and that gets more difficult the more complicated we make their drop regimen. So I'll ask how many times a week people miss their drops, and especially whether they used them the day of the appointment. I still have some people who skip their drops on the day of an appointment because they think I want to see what their eyes are like without the drops. And that way, if I know that their pressure is not doing so well the day of the visit, I don't panic necessarily if I know that they skipped their drops. So here's a nice rainbow of bottle cap colors. Thank goodness we have them. And here's a chart with the most common eye drop classes color-coded. So starting over here, these red top drops or mydriatics and cycloplegics, those aren't that common to have at home, but if you have somebody with uveitis, you might have them on cyclopentolate or cyclogel. If you have somebody with a chronic blind painful eye, they may be on atropine, which also has a red top. Your orange tops are going to be carbonic anhydrase inhibitors, azopt, brinzolamide, dorzolamide. Yellow tops are going to be 0.5% beta blockers, timolol, and all its equivalents. And then over here you have kind of light green alpha agonist combos like Simbrinza. Your gray will be NSAIDs. Your Kelly green over here will be miotics like pilocarpine. Then there's light blue, 0.25% beta blockers. This isn't such a great color, but over here you've got your aqua green, which would be prostaglandin analogs. And then white tops could be just about anything. Unfortunately, some companies do choose to put white tops. Dark blue will be a beta blocker combos, so things like dorzolamide timolol or brand name Combigan. Purple will be your alpha agonists. Pink top usually means a steroid. And over here, tan top will mean an antibiotic or sometimes an antibiotic steroid combo. So sometimes if you ask patients about bottle cap colors, you'll get a better idea of at least what class they're on, if not the specific medication. So then on to past medical and surgical history. There are lots of medical problems that can affect the eyes and affect glaucoma especially. So I'll always ask about sleep apnea. That OSA is obstructive sleep apnea, and that's a risk factor for glaucoma. Sadly, it seems that treating it doesn't make the glaucoma any better, unfortunately. Also, low blood pressure and migraine are a couple of systemic illnesses that are risk factors for low pressure glaucoma. COPD and asthma aren't actually risk factors for glaucoma, but if a patient has them, I want to know about it because I'll be reluctant to use beta blocker drops. Those can actually make the COPD or asthma go out of control if it's on the borderline or it's severe. Surgical history. We want to know if they've had cataract surgery and also LASIK or PRK. So refractive surgery like LASIK and PRK can thin the cornea, and that means we'll be underestimating the pressure. So if you think about a Goldmann tonometer, it's got a flat surface. The thinner the cornea is, the easier it is to flatten with your tonometer, which basically means it'll push back less at you while you're checking the pressure. And that means regardless of what the actual pressure is, you'll think it's a bit lower than it is. So of course, we want to know if they've had glaucoma surgery or laser in the past so that we can tell whether that's something that we can repeat or not. And sometimes they may not know, but we can also ask about other eye issues that might affect IOP measurement. So if someone has Fuchs endothelial dystrophy and their corneas are swollen, that might cause us to overestimate IOP for the opposite reason of the thin corneas. And keratoconus could actually make parts of patients' corneas thinner and also make pressure measurements inaccurate. And social history can actually be pretty interesting as it relates to glaucoma. So in the last couple of decades, the number of people using complementary and alternative medicine to self-treat their glaucoma has really increased. That's something that we want to be aware of if that's something that they're doing. Everything on this list here is something that some patient of mine has said that they've used for glaucoma in the last 10 years. Hang on 1 second. So some of the names you might hear are ginkgo, bilberry, mirtogenol, forskolin, resveratrol, and there are many more. So the trouble is that the evidence for these things is kind of mixed at best, and a lot of them do have negative side effects. So it's something that we do want to be aware of. So asking about marijuana can also give you very interesting information. I always like to know if someone has had any specifically on the day of their appointment, because that can actually lower their IOP for at least a few hours. The problem, and one of the reasons why we don't give it for glaucoma in the first place, is that it can also lower your blood pressure, which isn't always good for your optic nerves if they're not getting the blood flow that they're supposed to. If I know someone uses marijuana occasionally for other things, I might ask them to try not to on the day of their appointment, unless they're using it for, say, anxiety or PTSD, so that I can make sure their IOP is low enough during the times when they're not taking any. Often patients will also ask about other lifestyle choices and substances that might affect glaucoma, and I know some of our techs have had questions about these too. So caffeine can raise your IOP, but you'd have to drink a lot of it right before your appointment for me to see the effect of it when I'm measuring your pressure. Alcohol can actually lower your IOP in the short term, but it seems that heavy chronic alcohol use is actually associated with glaucoma progression. And then cigarette smoking is also associated with higher IOP. So then we move on to the tech portions of the exam. So the first part of any exam is you want to read their glasses. You want to know what kind of glasses prescription they have if they're wearing any. Some glaucomas, like we mentioned, are associated with particular kinds of refractive errors. So for a high hyperope, you want to be aware of the possibility of narrow angles, and that would happen because hyperopes have a shorter, more crowded eye. For young adult myopes, like Dr. Combo was mentioning, they may be more likely to have pigment dispersion. And just answering her question about pigment dispersion, in young pigment dispersion patients, the laser iridotomy is something that we can do to separate their iris from their lens and prevent some of that chafing and pigment dispersion. It doesn't always lower their IOP, but once we've done that, we treat it just like any other kind of glaucoma. They can have eye drops to lower their pressure. We can cautiously do SLT, and we can always do glaucoma surgery if all those things fail. And then in high astigmatism, you might start thinking, do they have keratoconus? And there you might want to check IOP differently so that you're not getting confounded by the keratoconus. So sometimes what we think about is actually measuring IOP twice. If you take your Goldmann prism and first measure the IOP with the prism horizontal and then turn it and measure it 90 degrees vertical and then average the measurements, that can give you a little bit more accurate IOP measurement. So you want to check their pupils, of course. And if you think there's an APD, and it doesn't take much to make an APD in glaucoma, just a little bit asymmetric visual field defects, you want to get confirmation of that before you do anything to change the pupils in a way that your doctor won't be able to see that APD if it's there. If we're still not sure that somebody actually has glaucoma, sometimes checking color vision can also help differentiate between a glaucoma diagnosis where you'd be less likely to see color vision affected and a neurodiagnosis where you might actually see the colors are down. A confrontational visual field can sometimes help us confirm a visual field defect when an automated visual field is unreliable. And I had that recently on a young patient. I think everyone should have pachymetry on their initial exam. So we talked about this a little bit already. Average corneal thickness is around 540 microns. As we already talked about, if your corneas are a lot thicker than that, we start calling them corneas of steel because they're harder to flatten with the tonometer. Regardless of what their actual IOP is, that will make you tend to overestimate their pressures. A lot thinner than 540, and we may underestimate the IOP. We don't actually go correcting usually for those thicker or thinner corneas, but it's nice to have that in your mind when you're wondering, A, whether I treat somebody, or B, whether they're actually controlled. For me, when I first meet a glaucoma patient, I don't like to meet them when they're already dilated. I like to do a gonio first. Sometimes if their eyes are already dilated, I miss important findings on gonioscopy if their angles are crowded. But the other thing about dilation that we really, really don't want to do is if we dilate somebody with narrow, potentially occludable angles and put them into angle closure. So here is this repeat customer that nobody wants to see. This is someone who was here for a dilated exam a few hours ago, and now their dilation is wearing off. They're in a lot of pain. They can't see too well. They might be throwing up because of the pain and the high eye pressure. And here are all the classic findings of acute angle closure in that right eye. So there's lots of hyperemia. The cornea is all swollen and cloudy. You can't see the details of the pupil and the iris that well, but you can see that the pupil is mid-dilated compared to the other eye. That's usually because it got stuck on the thickest part of the lens as the dilation was reversing, and that's what we call pupillary block. On exam, you'll find that their IOP is very high. The highest I've ever seen in angle closure was in the 80s, and they have a closed angle if you are able to get a look through all that corneal edema. This is not what we want to do to anyone, especially a new patient that we've just met. So this is a really good thing to go and get your doctor for. If you think somebody has narrow angles, it never hurts to ask somebody to double check. That's not something that I'll ever get upset about if it means that we avoid angle closure later on. And then the last part of the exam that you might be involved in as a tech, I kind of skipped over the whole doctor part of the exam, is the ancillary testing. So for narrow angle suspects, we might want something like anterior segment imaging. For everyone, I like to get disc photos at least once for a baseline, and sometimes we'll repeat them later on as well if we have a good fundus camera. If I'm trying to diagnose glaucoma, I'd like an RNFL OCT at the first visit, since that's the test that most likely will show early glaucoma damage. You could actually lose 50% of your retinal nerve fibers before you start to have visual field problems, so that will be your most sensitive way of really diagnosing glaucoma early. Then on the second visit, I'll get them a visual field to stage their glaucoma or confirm that their visual field is normal in early glaucoma or for a glaucoma suspect. And here are some of the common visual field defects in glaucoma. So any of these can appear above or below the horizontal midline. So over on the left, there's a nasal step. In the middle, there's an arcuate scotoma, which you can kind of think of as a nasal step that kept on growing. On the other side, on the right, there's a central scotoma, and that's a little bit confounding. You can also see that in things like macular degeneration. Central or paracentral scotomas can also appear in nutritional deficiencies, but it also happens to be pretty common in low pressure glaucoma. So none of these would surprise me to see in a glaucoma patient. These visual field defects are a little bit different. So if you see these, glaucoma should not be the first thing that comes to mind. So over on the left is a homonymous hemianopia. Homonymous basically means that if you take these visual fields and lay them on top of each other, right over left, they'll match. If I see a visual field that looks like that, the first thing I'll ask a patient is when they had their stroke. If they don't know of any neurological problem that they had, I'll get them a scan of their head to see what might be causing this that's in their brain. So classically, when you see something like that, this is not caused by something in the eye. It's a brain thing. The one on the right is a bitemporal hemianopia, so here and here on the visual field. For this one, I would think of a problem with the optic chiasm, which is the place in the brain where some of the fibers from the left and right optic nerves start to cross from one side to the other. Your pituitary gland lives right near the optic chiasm, so a bitemporal hemianopia most often means that there's a pituitary tumor that's pushing on the optic chiasm, or that there's a bleed in your pituitary gland. So last thing, we'll go over these self-assessment questions. So if people want to put the answers in chat, you can do that. Which type of visual field defect is not commonly seen in glaucoma? So we just did these: a superior arcuate, a central scotoma, bitemporal hemianopia, or a nasal step. Yep, so bitemporal hemianopia, great. And which commonly used substance will raise your intraocular pressure? Caffeine, tobacco, alcohol, marijuana, or A and B? Yep, A and B. Okay, here's a patient that is the last thing you want at 5 p.m. on a Friday. They had a dilated exam earlier in the day. This is acute angle closure glaucoma until proven otherwise. Which is not a symptom of acute angle closure glaucoma? Blurry vision and halos around lights, flashes and floaters, red eye, or nausea and vomiting? Yep, so flashes and floaters. If you see flashes and floaters acutely, you want to think retinal detachment. All right, so here's a patient who's red, irritated, tearing, hasn't changed glaucoma drops in a few years, but here are some glaucoma drops. Which of these is most likely to cause that delayed follicular conjunctivitis even years after starting? Latanoprost, timolol, bromonidine, or dorzolamide? And that one is bromonidine. Last question. Get rid of this. So what is one clinical implication of measuring central corneal thickness or pachymetry? Does thicker than average corneas mean that we're overestimating IOP? Does thicker than average corneas mean that the patient might have had refractive surgery? Does thinner than average corneas mean that the patient has Fuchs? Or does thicker than average corneas mean that the patient has keratoconus? Yep, so thicker than average corneas of steel means that we're overestimating IOP. All right, so thank you for coming to this virtual talk, and thanks to Dr. Lim and Deb again for inviting me. I think we're all hoping for fewer socially distanced eye exams soon, and hoping we can go back to CSEP in person soon too.
I was just saying how much I appreciate Dr. Mascarenas bringing forward the importance of that medical history and social history that you guys are take for us. Even things like sleep apnea, cannabis use, other medication use. It's so important to assessing the glaucoma patient. Our next speaker is also brought to you by video. It's Dr. Sarif Poor. He's board certified fellowship trained glaucoma specialist at the Yale Eye Center. He completed his medical school at Tufts University School of Medicine, did his residency training at NYU and glaucoma fellowship at Yale University. So he's presenting the last of this triad of glaucoma topics.
Thank you very much for the very kind introduction. It'll be hard to follow all the excellent presentations so far, but I'm lucky enough to talk about very exciting topics in OCT and glaucoma. So I have no financial disclosures. And some of the things, as mentioned, that I'll be talking about is just I'll spend a few minutes talking about OCT options, different machines, different protocols, very briefly there. Then I'll go on to talk about, in particular, OCT RNFL, OCT GCL, and OCT angles, and how we use them in different settings and how visual fields may work their way in comparison based off the findings that we find with those. And then lastly, I'll spend most of my time going through some common artifacts that we may see on our OCT RNFL scans, how to identify them and how to best kind of rectify them to avoid causing problems in terms of diagnoses. So starting with the fundamentals of OCT. So OCT, kind of as mentioned in the previous talk, is effectively just an optical ultrasound. Effectively, instead of sound, we're using light, and the light's going into the eye, or we're hitting whatever tissue that we want it to hit. The light interactions are occurring. It's coming back to our machine where a complex algorithm is applied and then used to generate some very pretty pictures for us. Because we're using light, the most important thing for us is needing a clear or good media. Things like cataract surgery, things like cataracts, vitreous hemorrhage, dry eyes, poor ocular surface can affect the quality of our scans, which can affect the findings of our scans as well. So things like artificial tears or doing surgery and things like that may benefit in the long run. Again, so very simply kind of put, the machine has a light source. It shoots out a bunch of light. It hits a beam splitter where some of that light goes to a reference mirror in the machine itself, which the machine uses for comparison. And some of that light goes to the actual tissue, where it then enters and bounces. Some of the light hits different layers of the tissue. Some bounces back, some keeps going, some bounces back, some scatters, and so forth. Eventually, the light works its way back to the detection unit. And in the detection unit, there's usually some machine that's applying some sort of algorithm and comparing the input from the reference mirror to generate the pictures and the thicknesses that we end up reading and showing to our patients. Very briefly, there's a couple of types of OCT machines, and many of you are probably familiar with some of them, but just a few brief words. One of the most common ones that we utilize here is the Cirrus OCT. So this is the machine illustrated below, and this is kind of the scan outputs that it puts out. The patient puts their head here and the imaging head is right here. This moves a little bit, but it's relatively immobile compared to some of the other machines that we have. As a consequence, it's usually a lot easier to use, right? You don't really have to do anything. It kind of just moves, or we can move it minimally in its own way. But, because of that, it's also a little bit more reliant on the patient. The patient has to be relatively compliant to get good scans with it. The number of scans it does is pretty quick, 27,000 per second, and it has pretty good resolution. The other thing to kind of mention about the Cirrus in particular is that some people feel that it has a little bit better of an algorithm in terms of tracing vessels and in terms of RNFL progression. So it might be a little bit more popular amongst glaucoma people. But the overarching theme between the different machines is just there's a lot of personal preference in terms of what people like to use. The Heidelberg Spectralis illustrated below, the output's kind of put over here. The nice thing about this is that the head that takes the photos is quite mobile. So it requires a little bit more experience to use, but we can swing this around, up, down, right, left to help get images, even when the patient may not be as cooperative as we'd like them to be. This can help us get around things like exotropias, or if we want to image something in the periphery of the retina or outside of the posterior pole, we can have the patient fixate and move the machine around to get the picture. This machine also tends to have a slightly higher resolution than the other two, which makes for prettier pictures in general, and sometimes is a little bit more popular amongst our retinal colleagues. And then lastly, there's the OptiView. Again, a great machine as well, depicted below. It takes a similar number of scans, has a very good resolution, acquires real-time images, which sometimes is helpful on more inattentive or difficult patients, and has an excellent scan protocol. So ultimately, there's a lot of different types of machines out there, and personal preference ends up kind of being the most determining factor. It's also very helpful to kind of compare the same scans from the same machines to each other, as opposed to scanning somebody with a, say, Heidelberg, and then comparing it to, say, a Cirrus scan. It won't be as useful in that respect. Very briefly, the machines offer two main scan protocols, and then I'll throw in a third one that we kind of make up on our own. The default scan protocols are just 3D scans. The machine is taking a bunch of scans and putting them together, kind of like a CT scan, and piecing together a picture for us, which we can then scroll through to get a nice idea of what we're seeing. An example of this is the macular 512 by 128, or the optic disc cube 200 by 200. The numbers, so in the 512 by 128, it's effectively taking 512 location scans along the x-axis, about 6 millimeters apart, and then then 128 location scans along the y-axis 6 millimeters apart, repeating the scan a couple of times and then piecing it together. So it takes some time to do it, but it comes up with very pretty kind of holistic images for us to scroll through. 2D is the other one, and it's much, much quicker. Effectively, we're focusing all our efforts onto one particular area. So either a particular line or a particular circle, and it's doing hundreds and thousands of scans through that same spot to get a very high signal strength to give us a very, very nice picture. This is helpful in patients who are extremely inattentive, or in patients where for whatever reason, the media is highly limited. There might be a vitreous hemorrhage and we're just trying to get some idea. By repeating it multiple times, we have some potential to see something in the posterior pole. And then the combination is the 2.5 dimension scan. And this is effectively just a way of us utilizing several two-dimensional scans and putting them together to get a little bit of three-dimensionality out of it. The classic example is the 5-line raster scan. So here we have effectively 5 lines, and each is effectively just a two-dimensional scan. It's scanning a bunch of times at each of these lines, but when we scroll through it, we get some idea of how things look overall in the retina. Now, in terms of interpreting a scan, there's a lot of factors that go in. It's not just the straightforward, oh, okay, the machine is generating green numbers for us, the patient doesn't have glaucoma, or the machine is generating red numbers for us, the patient probably has glaucoma. The machine has its own normative database that it compares to give us these numbers, but a lot of things are assumed by the machine that may not be the case in our particular patient or population, right? Each patient's a little bit different and each scan is a little bit different. So first and foremost, signal strength is very, very important. So this is a Cirrus scan. You want a pretty good signal strength. You want ideally greater than 8 out of 10, but sometimes it can be a little bit difficult, but you want at least some 6 out of 10 scan quality there. And in terms of Heidelberg, most people want at least a 15 to 20 in terms of the signal strength. We know, and there's been many studies that have shown that as the signal strength goes down, the retinal nerve fiber layer thicknesses go down. And sometimes this can be misinterpreted as progression of glaucoma or the existence of glaucoma. And we may create treatment algorithm differences as a consequence of that. But we have to be aware of comparing the signal strength. Different things can cause the RNFL to be thicker in certain populations for our measurements and be thinner in certain populations for our measurements. So if someone is hyperopic or has a smaller eye, or if somebody has a larger disc, these patients tend to have thicker RNFLs than the average patient that might be compared to in the normative database. Conversely, if someone has a lot of myopia or a long axial length, we know these patients tend to have thinner RNFL. And in fact, the patients with high myopia may lose RNFL faster with time. We know that as we get older, nerves in general kind of fade, and the RNFL is not particularly special. So as we get older, the RNFL declines at a normal rate. And certain diseases can sometimes be associated with thinning of the RNFL. So Alzheimer's, Parkinson's, and things like that have been shown to be associated with thinner RNFLs. So all of this, when we're seeing the patient, we do want to gather this information so that when we're doing our imaging, we have an appropriate idea of how we're comparing to the normal database. Again, going back, so the RNFL from the perspective, all our machines are kind of geared towards glaucoma as opposed to neuro-ophthalmology. And from the perspective of glaucoma, the most important parts tend to be the superior, nasal, and inferior parts. This is where we oftentimes see progression. So when we're doing, fortunately for us, the machine splits the scan as we're going from a circle to a straight line, it splits it at the temporal aspect. This is to the detriment of neuro-ophthalmology because temporal aspect is a little bit more important there. But as a glaucoma specialist, I'm delighted with this. So effectively, what we're seeing when we're doing our scan, we're starting right here at the temporal aspect. And this one corresponds to what we're seeing on our aspect once it's rolled out. It's going up to the superior part, right, which will correspond to somewhere around here. Then to the nasal part, the nasal disc rim will be the thicknesses that we're seeing here, the inferior part here, and then way over here where the 2 is, the second half of the temporal. And this is useful to know because when we're looking for different artifacts, we want to know which part that the artifact may be affecting. A quick word about the guided progression analysis. So all the machines have the ability to look at a couple of different scans and to see if there's any progression as dictated by the machine itself. This requires 3 scans, 2 that are baselines. Typically, the first 2 scans are on the patient, so we can assign it to be anything we want. Depending on if a patient has a lot of progression at some point, they may have a new baseline, so we can change that number. Similar to the visual field GPA, this machine kind of looks and compares the numbers of the current scan to the initial baseline. And if it notes a notable amount of decline, it flags it as, orange, yellow, possible decline. And if it notes it twice in a row, it flags it as red, very concerning for decline. The nice thing about the guided progression analysis is it does take age into effect. So I mentioned that with older age, we expect a natural decline of retinal nerve fiber layer thickness. This takes it into effect. So if it's flagging something as red, it's not because the patient is just getting older and losing nerves at the normal rate. It's because it's losing nerves at an abnormally higher rate than expected. So that was the retinal nerve fiber layer scans. So we know that the retinal nerve fiber layer is the axons of the ganglion cells, and the ganglion cells are being affected by glaucoma. The retinal nerve fiber layer scans are done at the level of the optic nerve, but sometimes patients have pathology at the optic nerve or just things that can, physiologic changes that may cause their scans to be less accurate. Things like parapapillar atrophy, myelinated nerve fiber layers, tractional membranes that might be present or whatever. Those may cause us to get less accurate results with our retinal nerve fiber layers. So fortunately, we have a ganglion cell analysis. And we're lucky in that over 50% of the ganglion cells are located in the macula. So if we scan the macula, we can get an idea of the amount of ganglion cells that are present and how it's doing compared to the normal population, whether damage is happening or not. Again, as mentioned, this is useful in patients that have parapapillar atrophy, parapapillar disease, but normal macula scans. The other nice thing about the ganglion cell analysis is that because we're looking at the macula, we're looking at the central vision. And central vision is generally much more significant to patients than peripheral vision, right? If something damages someone's peripheral vision, people may not notice, but if something damages someone's central vision, people are very sad about that. So we know that studies have shown that the ganglion cell analysis actually correlates a little bit better with 10-2 visual field findings and can catch things that are sometimes missed on RNFL, especially in the central field loss. Similarly, if someone has macular disease like a giant macular scar or geographic atrophy, the ganglion cell analysis won't be as useful. And in those patients, we need to do retinal nerve fiber layer analysis. So, I won't bore anybody with any particular studies, but, literature reviews have been done and show that the RNFL and GCL are pretty close. Maybe the RNFL is a little bit better, so we use it a little bit more frequently, but it's very, very close, and both are useful in different situations. So you'll see us oftentimes order both and kind of monitor both. The other thing that's kind of interesting, so every test that we do, including the OCT, has a maximum amount of damage that it can identify. And this is called the floor effect. So at a certain point, so much damage will have happened to the nerves that even though nerves are present, the machine won't be able to tell how much nerve is present. It'll just kind of overlap and detect it as effectively 0 nerve left, even if it's not there. That level is the floor effect. That's the maximum measurable damage detected by the machine. So for RNFL, the floor effect is somewhere in the 40 to 50 micron range in terms of average. And it's a different floor for each segmental area. GCL has a slightly lower floor, so it might be a little bit more useful in patients with a little bit more advanced glaucoma. So GCL being in the 30 to 40 micron range. However, eventually, especially in very advanced glaucomas, the floor is reached in both of these. In those situations, it might be more useful to track patients with visual fields because visual fields, one, are functional, and as long as visual fields have their own limitations as well, they're very difficult, they're very boring, they take a long time. But if the patient is able to do it, we can get some idea of if progression is happening in more advanced glaucomas. And visual fields are also functional tests as opposed to structural tests. So OCT is just looking at the thickness of the nerves. It's not telling us how this is affecting the patient, whereas visual fields are telling us, like patients are missing XY amount of vision. And they can help us in situations where the OCT may come up as falsely full or something of that nature, looking for other etiologies as well instead of just glaucoma. So the nice thing again about OCT is that we've seen in many studies that OCT progression predicts visual field progression. So damage, if it happens on the OCT, eventually will lead to damage on the visual fields. Effectively, we have tools that can find damage before actual vision loss occurs, which is nice. So in short, OCT is objective data, which is nice, and it's a structural test. So we're looking at the structural changes. It is not a functional test again. So whatever we see on OCT doesn't necessarily correlate with actual loss of vision at that particular time. It may in the future, but it's not telling us how this is affecting the patients as opposed to visual field, which does. There are, it's nice in that we can pick up disease early, maybe even before patients are symptomatic, but it can be affected by a lot of different things, including artifacts, including different medications and diseases and things like that. And the floor effect does limit it eventually. So visual field plays a role in more advanced glaucomas. A few brief words just about OCT angles. So we're fortunate, we've learned that if we readjust the wavelengths, we can use the OCT machine to scan the anterior segment of the eye instead of the posterior segment of the eye. And this is really helpful for a couple of different things, including looking at corneas and things like that. But from the glaucoma perspective, it's great at looking at angles. If we scan the patient in the dark when they're most susceptible to being having the narrowest angles, we can get an idea as to whether they have closed angles or not. And studies have shown that if we see closed angles on OCT angles, it's probably, it's pretty specific. It doesn't necessarily rule out narrow angles. So we still have to do things like gonioscopy and or ultrasound biomicroscopy if we're suspicious. But if we see it, it does really help ruling it in. It's non-contact, it's relatively quick. And the really nice thing about it is that it really helps in terms of talking to patients because we have pictures to show them. And we can show them their angles and we can show them normal angles and we can show them how at risk they are. And this can kind of help them make educated decisions about their treatment plan. It does have a limited ability to visualize super far back. So oftentimes with OCT angles, we may not necessarily see the ciliary bodies as clearly, and we may not get a good view for ciliary body tumors or choroidal tumors or things like that. And ultrasound biomicroscopy may be better if there's suspicion in that respect. Plus the machine is different, the algorithm is different, it may cost extra and it may not be accessible to everybody, but something nice that we have. When we're doing the scan, effectively, if I'm looking for narrow angles, I'm looking at this particular part, right? I'm looking to see where the hyperechoic portion intersects with the darker portion, the ciliary body and the scleral spur outline. And then I'm looking to see if the drainage system is open at that particular intersection. Some people find that if you create a line through the cornea and a line through the iris, it creates an angle. And we know that sometimes if the angle is smaller, they're at higher risk. So if someone has an angle that's say less than around 20 degrees, it might induce us to worry about these patients a little bit more and to at least follow them and monitor them with OCTs and or gonioscopies. So now the most exciting part of the talk. So I'll go through some different artifacts. I left the answers blank and I'll kind of show them as I go through, but I'll encourage people to think about what the artifact might be in each of these and what to do in case it once identified. So here, the machine, as I mentioned, effectively is scanning through the optic nerve, right, and creating a path and deciding where the retinal nerve fiber layer is and then tracking it and then measuring the thickness in between to create these numbers for us. Here we can see the machine does okay in the posterior aspect. It's not perfect. It's a little off right here. It's a little off right here and so forth, but it's okay in the posterior axis. But if we look at the anterior aspect, right, we can see that it mistracks. There's a little fibrous band that's pulling, and here we have an anterior acquisition artifact. It's mistracking and measuring that band instead of the actual retinal nerve layer. As a consequence, when we look down here at the nasal portion, we see a huge amount of thickening, which is clear artifact. Similarly, so in this machine, we can see the signal strength is a little bit weaker, right? It's a little bit more grainy. The anterior aspect here, the anterior acquisition is pretty good. It's actually almost spot on. However, when we look at the posterior aspect, I may have missed something there, but over here, it completely misses the posterior border of the retinal nerve fiber layer and instead jumps to the anterior border. So this is a posterior acquisition defect. And of course, it's measuring this as 0. So it's going to measure the nasal aspect that's completely thin. And effectively, it's flagging that area for us. when in fact it may not necessarily be thin, it's just being misread. The nice thing about the Heidelberg is that it does give us the option of kind of readjusting the machine's acquisition points. So you'll see sometimes when I see something like this, if the patient's already gone and we can't rescan them, if you go to the, I'll go to this button right here, and it'll give us dots highlighting the areas that are being tracked. And we can adjust those dots to the appropriate border to get a more accurate representation and to effectively fix the error. So something to bear in mind in that respect. I'll say here, the OCT, as I mentioned, takes the numbers that it's seeing and compares them to the normative database. And I've said that this is a problem because the normative database may not reflect the population we're seeing, either by race or by gender or by the visual, the axial length and so forth. One other thing that the machine assumes is that we're doing perfect scans each time. So it's assuming that everything is 100% perfectly centered. We know that as the nerves, the distance of the retinal nerve, the distance of the nerve to the optic nerve matters in terms of how thick that area is. So here we can see that this optic nerve is shifted off to the side. It should be perfectly centered. Unfortunately, what happens is because now what's happening is the machine can't tell that it's necessarily decentered. It's kind of assuming that it's relatively well centered. It's going to compare the portions of the nerves that are here to what it assumes should be here, right? The machine is assuming that the optic nerve is right here and that this nerve right here would be the equivalent of what we're seeing here. And as a consequence, it's no longer comparing apples to apples, it's miscomparing to its normative database, and that can give us some misreadings in that respect. So getting a good centered image is very important as well. Sometimes, so here we have a little bit of an outline artifact. We can see it's kind of tracking pretty well right here, right? But right here, something happened. Either the machine misscanned or something got in the way very briefly, or there's a shadowing artifact from something or whatever. Something happened and we're missing a little portion here. And this completely messes up the machine in terms of analysis right here, right? It's tracking and then it completely collapses in terms of tracking here. We see that the difference between the right and the left eye is noticeable, right? The inferior aspect is thin and it's flagging the superior as a little bit, not necessarily thin, but as flagged, right? And that could be a consequence of what we're seeing here, because this would correlate with the supranasal area. So an outline area, effectively, it's misidentified the retinal nerve fibrillator borders. What about here? So again, the machine, I'll talk just briefly and you can kind of think about what potential artifact might be here. But effectively, the machine shows us two pictures, right? One picture here is effectively what the machine is reading in terms of the retinal nerve thicknesses. So red here means that the nerve is thicker. And this is typically what we're expecting, right? Thicknesses, as it's kind of coming out in an arcuate pattern, a little bit thinner in the other aspects. The deviation map is nice in that we can see the blood vessels and things like that. And effectively, it's comparing it to the normative database. So red in this particular area is going to be areas where it's seeing it thin compared to the normal database. If we look right here, we can see in this particular situation, the patient moved. Right, the blood vessels are no longer lined up. Here we see the blood vessels are perfect and pristine. Here, the blood vessels are not lined up. So the patient must have moved and then the scan continued at that point. Similar to the decentration artifact, this is a problem because we know that the thickness of the RNFL is again impacted by how far away it is from the optic nerve head. So if the patient's moving, the machine's not going to be comparing appropriately and we'll end up with artifact and misreported information. What do we have here? We can see on the right side, things look pretty good. On the left side, we notice a lot of thinning. It even looks kind of like a bad scan in general, and we can see that the scan quality is lower. And as a result of the lower scan quality, the algorithm is completely messed up. It's unable to detect the retinal nerve fibrillator. This patient probably blinked, right? Which makes sense, because if the patient blinked, then the machine is scanning the eyelid, which has no retinal nerve fibrillator. So of course, it's going to come up as abnormally thin. So we just need to rescan this patient when they don't blink. So this is a little bit more of an interesting one, right? If we look, we can see a difference between the two eyes, and we know that glaucoma is oftentimes bilateral, can be unilateral, but oftentimes bilateral, but is almost always asymmetric. So asymmetry between the two eyes in terms of thicknesses is often a flag for us in terms of detecting glaucoma. Here we can see down here that infranasally is the area of particular concern. It's where it's being flagged. When I look at the maps, I can see right here right? I see this one area in the infranasal quadrant that's coming up as black, right? It's not reading anything there. And here on the deviation map, I can see that the machine is in fact confirming that it is detecting that as an area of thinning. And that's probably the area of thinning that's causing this to turn a little bit more yellow. When I compare it to here, you can see that there's a little bit blacker here, which correlates with that same particular spot. So this patient has a floater, and the floater is blocking the scan at a particular area, which is causing us to think that maybe this patient has glaucoma, when in fact it might just be an area that's being misscanned in particular. Ways around this, you can have the patient look up, down, try to get the floater out of the way to rescan, and then have two kind of scans in terms of ability to compare, or just bearing it in mind and monitoring it in that respect. Other things, I'll go a little bit quicker in that respect, but other things to bear in mind here, we have peripapillar atrophy, which can cause thinning, and which might prompt us to do a GCL analysis instead. Here, we have a scan of the macula, unfortunately. So if we scan the macula, and so we scan the macula with an RNFL analysis, when in fact we may have wanted to do a GCL analysis. So of course it's going to misread it and create artifact thinning in that respect. And then I think this is my second to last slide. So here we have the machine completely unable to recognize any borders here because of the myelinated nerve fiber layers. So this is a myelinated nerve fiber layer artifact. And again, both in this patient and the patient with PPA, we may be better off tracking with GCL analysis. So the big take home message here is that artifact, so this study looked at 2,300 scans consecutively, and they found when they looked really closely, 46% of the scans that they did with very experienced photographers and technicians had artifacts. So it's really important for us to bear this in mind because almost 1 in 2 scans may have artifacts. So in conclusion, OCT is reproducible, it's objective, and it helps a lot in terms of monitoring glaucoma and progression. But visual field 24-2s and visual field 10-2s also can help detect progression and can be really helpful in very advanced glaucomas. GCL is helpful, especially in patients with peripapillar abnormalities, but is less helpful in patients with macular pathologies. Artifacts are really common. 46% of the time we may have an artifact. And RNFL can vary in different patients. So not all patients are the same and not all diseases are the same. It may be thicker if the nerve is bigger, or and it may be thinner in patients with Alzheimer's disease. Thank you very much.
Okay, I want to take one quick diversion here. Going to give you guys an opportunity to be a superstar. So hopefully you can see on the screen in front of you a CDC brief that was just announced to the physicians last night. We found out about it maybe 2 days ago. Last night we presented it to the physicians at the physician meeting, and then today we presented it also. And this is from the CDC, and it reports 13 cases of carbapenem-resistant Pseudomonas aeruginosa presenting as keratitis and endophthalmitis, among other things. There are it's actually multi-system. But there are 2 cases reported in Connecticut. I actually looked up some other reports, and I think that the total is now up to 35 cases across the country. And they would like the eye healthcare providers to be aware that this is an issue. They're tracking it. They're asking, if you see this bottom highlighted paragraph, to report CRPA eye infections with collection dates from May 1st, 2022. So what does this mean for you guys in real life? This means when you see a patient that walks in with a corneal ulcer or an endophthalmitis or something like that, you can be that voice in your physician's ear saying, "Oh, don't forget CRPA." So the problem is it's resistant to our kind of last resort antibiotics that have proven themselves to be very effective. So this is going to be a real problem. The one that, we use ceftazidime in endophthalmitis cases, and it's resistant to that too. So have not been able to find out whether or not it's resistant to vancomycin, because that is the other drug that we introduced during bacterial endophthalmitis cases. So it's something for you to be aware of. Make sure your physicians are aware of. You've been told. What I'd like to do is introduce our next speaker, and it's always a pleasure to introduce him. He's just a nice guy. He's a smart guy. I think his title kind of says it all. You know, he's Associate Professor of Ophthalmology and Visual Science. He's Vice Chair of Clinical Affairs at Yale. He's affiliated faculty at the Yale Institute for Global Health. He's director of the glaucoma section and glaucoma fellowship. And I just know whenever I have a glaucoma issue or anterior segment issue, I can count on Dr. Teng to kind of back me up. He did his medical school at SUNY Downstate and his ophthalmology residency at NYU and his fellowship in glaucoma at New York Eye and Ear Infirmary. So I'm going to turn it over to Dr. Teng. Thank you for coming today.
Thanks so much, Dr. Lim. It's really such a great honor to be here again. I'm sitting here live from the AquaTurf where we're doing the live meeting, and it's just been such a pleasure to be back in person. I can't wait for our next meeting in June of 2023 when all of us will be back. It's going to be such a great meeting. I'm going to talk today about micro-invasive glaucoma surgery, and I've titled the talk all about MIGS, and it's loaded with videos on all the various types of MIGS that we've seen in the office and that many of the technicians have worked up. I don't have any financial interest to disclose, and I've been posting videos since I was a fellow in 2009, and I only recently started my TikTok page, which I've named IOTA. And unfortunately, I didn't have the foresight to brand myself like many of the others have on YouTube. But, you know, after watching so many wonderful videos on YouTube and TikTok and learning so much, I've realized the value of doing so and creating the value and education that is all accessible to everyone. Not all patients are well served only on medications. Glaucoma traditionally was always known as you have high pressure, you have glaucoma, and it's evolved to disease of the optic nerve, with pressure being the most common cause for that. But you can have normal pressure glaucoma where the pressure is not high at all, and you just have optic nerve damage. Why are not all patients served well? Well, there's adherence issues, there's allergy issues that we all see with medicamentosa when they come in with red eye, with some of the more common medications, most commonly bromometine. There's the cost of medications, ALT, argon laser, trabeculoplasty, selective laser, trabeculoplasty, and micropulse laser trabeculoplasty exist, but there's still a big divide between lasers and more invasive glaucoma surgeries such as trabeculectomy and glaucoma implants. So microinvasive, formerly known as minimally invasive glaucoma surgery, was to fill that laser to surgery gap. And there's a large push now for less invasive techniques for IOP control. And why is that? Well, we all know that trabeculectomy and glaucoma tube implants might predispose the patients to larger risk for infection, hypotony, scarring, decreased vision. What is MIGS? Well, there's 5 features there that was eloquently written by Hadi Saheb and Ike Ahmed. 5 features are microincision, minimal trauma, modest to good IOP lowering. It's got to have a high safety profile and a rapid recovery. The anatomic targets of MIGS are the Schlemm's canal, and Schlemm's canal is the canal that is outside of the trabecular meshwork where the trabecular meshwork drains into, and there's the suprachoroidal space, and the suprachoroidal space increases uveoscleral outflow, and then there's a subconjunctival space where the trabeculectomy typically resided with a filtering blood. This is a wonderful picture from Jackson and Sears looking at the collector channels, and collector channels of the eye are predominantly located in the inferior nasal area of the eye. This is of the left eye, and we can see where all the flow is directed to, is towards the nasal aspect. So most MIG surgeries are targeting the nasal aspect of the eye. The site of the most resistant area of IOP and aqueous outflow is the trabecular meshwork, and most commonly the juxtacanalicular trabecular meshwork. So a lot of MIGs are targeting the trabecular meshwork or bypassing that. There's various types of targets, as we've mentioned. There's the trabecular meshwork targeting, and those are trabectome, Cahook, GAT, Omni, iStent, and Hydrus. There's Schlemm's canal targeting, which is Omni, ABIC, and the Hydrus has multifold potential areas of IOP lowering. Suprachoroidal shunts, the CyPass was promising, but got pulled from the market. The iStent Supra will be coming out. And there's the microinvasive bleb surgery, also known as MIBS, and those comprise the Zen gel stent and the PreserFlow. The PreserFlow was not formally approved, but it's available in other countries. And then there's also ciliary body laser. That's not as popular these days, but that's endocyclophotocoagulation, where you laser the ciliary body to help lower the pressure. The first MIGS might have been goniotomy, and this was first described by Dr. Carlo Di Vincentis in Italy in 1892, where you cut open the trabecular meshwork. The interesting thing about what Dr. Di Vincentis did is he did it without direct visualization of the angle. He did it without any technology in terms of having a lens. He just basically put a knife in the eye and cut the nasal angle. And that was probably the first MIGS in history. The modern correlates of what he did are trabectome, Cahook blade, and the bent angle needle. And you see here in the picture, I have the luxury of having a lens and direct visualization of the angle, and I'm cutting the trabecular meshwork. Me being at Yale, I was fortunate to go into the archives of our library and pull out the original article from Dr. Di Vincentis in 1893 about goniotomy. The OGs of MIGS, how has MIGS evolved since then? Ike Ahmed, who's based in Toronto, first coined the term MIGS, and initially he called it minimally invasive glaucoma surgery, and then that has evolved to micro-invasive glaucoma surgery because he didn't want the minimally to minimize the impact of the glaucoma surgery. He could be considered the father or originator of MIGS. George Barvelt, who recently passed away, invented the Barvelt glaucoma implant that many of us use. He invented the trabectome, which may have been the first modern day MIGS, and he could be considered the grandfather of MIGS. And Carlo Di Vincentis, I think we all could agree from 1893 would be a good candidate to be called the godfather of MIGS. Trabectome was the first MIGS, as I mentioned, in 2004 that came out, and that was invented by George Barvelt and Roy Chuck, who's the chair at Montefiore Medical Center in the Bronx. And they came up with an innovative tool with a foot plate and a cautery unit to remove and ablate the trabecular meshwork with a goniotomy technique. This is a video in a sample eye, and you can see that the trabecular meshwork is being ablated and removed. And if we looked at the histopath photos, the trabecular meshwork is removed, so you get direct access to the Schlemm's canal. This is a video of me doing it, and trabectome has been shown to be really effective. We just did a review paper looking at trabectome and another goniotomy called the Cahook dual blade, which I'll talk about next, and they had similar outcomes. So the trabecular meshwork gets removed in the nasal aspect, and that gives direct access for the aqueous to flow from inside the anterior chamber, bypassing the diseased trabecular meshwork. As I said, the most common site of resistance is a juxtacanalicular trabecular meshwork. So when you remove that, you give the direct access to the Schlemm's canal, thereby decreasing the pressure, thereby decreasing the need for IOP lowering drops. Trabectome is most commonly done in conjunction with cataract surgery. Typically, in my hands, I first do the trabectome, and then after this is done, I take out the cataract in the patient, and this has been shown to be effective in lowering IOP. The Cahook dual blade was invented by Dr. Cahook, who's based at the University of Colorado, and that's a similar type of goniotomy procedure, but there's no cautery unit and there's no pack that needs to be open. This is just a standalone blade that you just open up, and the novel design of this is that there's two blades on the top and the bottom, so you can nicely remove the trabecular meshwork. And Dr. Cahook, when he talks about inventing this, he talks about wanting the trabecular meshwork for samples when he was doing his studies. And this is a nice device to remove the trabecular meshwork, much like the trabectome. And this is the video of that. Oftentimes you'll see a little bit of blood reflux from the blade, but you're literally just scratching the trabecular meshwork surface. You embed the foot of that knife hook into there, and then you remove the trabecular meshwork and you go one way, and then you go the other direction. Moving on to other targets of Schlem canal, there's the gonioscopy assisted transluminal trabeculotomy, which came around 2014, and it was devised, let's say, by Dr. Ron Feldman in Dallas. And he had such a long history with Schlem's canal targeting in children because he did a lot of peds glaucoma. And he came up with this surgery where they thread a 5-0 proline into the Schlem's canal using a microforceps. And based on his knowledge of what he was doing in pediatrics, he said, why can't we thread this proline suture 360 degrees in the canal using an internal approach? Hence, he came up with this name, gonioscopy assisted transluminal trabeculotomy. GAT also has other meanings, by the way, and I said this in one of the talks that I gave specifically about this, was that it also means Goldman applanation tonometry, which is a nice thing. But I said to Dr. Feldman, this is really great because his practice in Dallas is called Glaucoma Associates of Texas too. And then he kind of chuckled, right? So he knew that this was a multi-pronged name that he came up with, and it was really brilliant on his part. So you thread the proline suture there using a microforceps, and the beautiful thing is that it can thread 360 degrees, and then when it comes and emerges on the other side, then you pull it, and then you have a 360-degree trabeculotomy. So this is the video of that. We use the lens there to stabilize, and the microforceps there is advancing the proline suture. Now, the challenging part of this surgery is that you're doing it blind. You're basically just pushing and pushing and pushing until you see it emerge on the other side like that. Until you see it emerge from the other side, you really have no visualization of where that proline is. And then once you visualize it, then you pull it like that on both sides, and then you have a 360-degree trabeculotomy opening. But I say that because sometimes the tip can take a dive into the suprachoroidal space, either nasally or inferiorly, or sometimes it stops and you keep pushing and pushing and it doesn't advance anymore. If that happens, hopefully it's at the 180-degree aspect, and then you can just pull it there. And then if you want to do the other 180 degrees, then you have to advance the other direction. But this is one of my favorite procedures in all of glaucoma, because when you see that tip emerging from the other side, it never ceases to amaze, because it's such an amazing concept to be able to thread this blindly 360 degrees. Fortunately, there's an easier mechanism, which I'm going to talk about. So there's this other device using an eye lumen catheter, where there's a light pipe, and the tip of the light pipe is like flashing. It's like Rudolph the Red-Nosed Reindeer. So when it's going into the Schlem's canal and you're advancing it through the Schlem's canal, you can see the light flashing. So that helps you gauge where that tip of the catheter is. And then you're advancing it around, and it has other capability as well. So it's attached to a viscoelastic syringe as well. And then every time you advance, every 3 to 4 clock hours, you can turn a knob, and that injects viscoelastic. So some doctors like doing what's called ab internal canaloplasty, which you do with this device. So you don't have to pull a trabeculotomy. You can just keep pumping the cannula. And then when you do that, it releases viscoelastic, and that helps to dilate the Schlem's canal. A good way to think about it is if you think about a tunnel that collapsed, right? Just say we all have pipes in our house. Sometimes what they can do nowadays is thread a catheter in there to expand the pipes if the pipes collapsed or if there's root infiltration or something like that, right? So if you think that the Schlemm's canal is collapsed, which does happen a lot in glaucoma, you can thread this catheter in there and then viscodilate the canal using viscoelastic, and that helps to expand any collapsed channels in that pipe of the Schlemm's canal. So this device has multi-pronged actions where you can dilate the pipe or you can pull it as 360. So typically what I'm doing is I'm doing both. I'm dilating as I go along, advancing it, and then I'm also pulling it at the end. So what it does, as the slide says, is that it's viscodilating the collapsed pipe of the Schlemm's canal. And this is the video of it. So there's the light flashing, which makes it so easy to visualize. As you're advancing it, you have complete visualization of where you are. And this is also an amazing procedure as well, because you're looking at it in real time. Contrast that to the Prolene suture, where you're passing it and you have literally no idea where that's going. That's why when you see that Prolene suture emerging on the other end, it never ceases to amaze. And it's like one of the greatest joys I have when I'm doing surgery. And this one is highly satisfactory as well, because you can see it the entire time as you're advancing it through. Then once you advance it through, then you pull both ends, and that's the trabeculotomy. That's the trabeculotomy. It's the opening of the trabecular meshwork, which is called trabeculotomy. We'll just show this one more time. And another nice thing about this machine is you can either make it flash or you can either make it a steady red light. So I typically like the flashing red light. So that's the way I do it. And then sometimes it stops at 180 degrees, which would be about right now at this point. If it does and you can't advance any further, you can try to jam it through. If it doesn't go, then you can just pull it, and this would be 180 degrees. And then you could advance around the other way to complete 360 degrees. Further along in the innovation of the Schlemm's canal trabeculotomy space is a device called the Omni. Now, the original form was another device called the Trab 360. And what this does is it also gives the ability to inject viscoelastic to dilate the pipe. It can also advance this Prolene suture, and it does that by advancing this Prolene suture. Now, the Prolene suture goes around, and then you basically advance 180 degrees like this bottom picture, and then you pull that, and then you get 180 degrees of trabeculotomy. Then you go around the other way and do 180 degrees. So this is called the Omni device, and it just makes that procedure a little bit more straightforward, because it does take a little bit of training and muscle memory to be able to thread that other Prolene around or that other catheter around 360 degrees. So this is doing 180 and 180, and this is a nice device that many places employ. And this is the video of that. So you're advancing that 180 degrees, and when you retract it back, it pumps the viscoelastic in, then you advance it back, and now you have 180 degrees of trabeculotomy, and then you just stick it around on the other side, and then you do the other 180 degrees, and that makes 360. This device and the catheter device do cost a little more than the most cheap device, which would be the Prolene suture. All you have to do is open a 5/0 Prolene. You cauterize the tip to give it a little bulb as an anchor, and then you can do the 360-degree trabeculotomy with just a Prolene suture, which would be the most cost-effective trabeculotomy technique. There's also stents that came out, and these are trabecular meshwork bypass. The first one that came out was called the iStent. This is the third iteration of it, the iStent Inject. And this is a heparin-coated titanium implant, and it's the smallest implant in the eye. And basically what it does is it creates a little bit of a bypass of the trabecular meshwork to be able to increase trabecular meshwork outflow. Nowadays, the iStent inject is coming in with 2 stents in one device. So it's basically a punch. And then you punch that in there, and then the iStent's sitting there. That's the first one. And then you advance it into another part of the nasal quadrant, and then you punch it again, and now you have 2 stents there. So that was one of the first trabecular meshwork bypass stents, and it's really a nice device to help lower pressure. And this is indicated for mild to moderate glaucoma. There's another one, trabecular meshwork bypass and scaffold stent. Now, if you look at the design of this, you can see that it acts as a scaffold to open up the collapsed pipe of the Schlemm's canal, but it also at the end has a little bit of an area that stents, acts as a stent as well, where fluid can go from the anterior chamber into the Schlemm's canal as well. And this is made out of a nickel alloy called nitinol. So it's also a device that you enter into the eye, and then you can see that you're advancing it with the wheel with your index finger, and it's nicely advancing into the Schlemm's canal, and that acts as a scaffold. And then the distal end, which is the end that is going to be removed from the tip right now, acts as the stent area. And this is recent study has shown that this one out of all of them might be one that may help improve glaucoma if you put it on in early enough in the disease process. The Zen gel stent is a porcine stent that could be considered a modified trabeculectomy. The way it was designed initially was to place it ab interno, meaning from the inside of the eye to the outside of the eye, to help bypass the trabecular meshwork and create a filtering bleb. Now, trabeculectomy does the same thing, except the trabeculectomy is made from the outside of the eye, cutting into the eye to create a bypass flap for fluid to drain from inside of the eye to the outside, which then causes what we call a bleb. You guys have all seen a lot of blebs. So the Zen gel stent is doing a similar type thing where it's taking fluid from inside of the eye to the outside. There's been various iterations of putting in the Zen from ab interno, and then Dr. Ahmed talked about an air Zen where you put air under the conjunctiva because you want the distal end of the Zen to be subconjunctival and subtenons. I like to do it from the outside technique where you still take down the conjunctiva like you're doing a trabeculectomy, but instead of cutting a flap with the trabeculectomy, you put in this Zen implant to bypass that area. And this is the video of that. So I've cut down the conjunctiva at 12 o'clock in this eye, and then you're using the applicator device to inject the Zen stent into the eye. And then afterwards, you'll just sew the conjunctiva back over that Zen area. So this is basically like a small tube that you put into the eye, and that takes fluid from inside of the eye to the outside of the eye, and then you cover the area back with conjunctiva, and then that creates the bleb in that superior area. And that's been shown to be really effective. We've had some patients that are doing wonderfully after the Zen stent. It's exciting times in glaucoma. There's the art of glaucoma is really, really strong. There's so many iterations of surgeries that we can do, and there's going to be more. I mean, this is just scratching the surface of everything that's been we're going to be doing for glaucoma patients in the future. MIGS are changing the glaucoma surgical paradigm. It allows for an expanded treatment algorithm. But the good thing is that if your procedure is not working as well as you want it to, you always have the option to go do TRABs or glaucoma tube implants. Thank you so much, Ed and Deb. I really appreciate the invite.
Fantastic. It's a very clear explanation. You know, I hear about a lot of these devices being put in and, you know, doing retina. I don't really get to see that. So watching the videos, seeing how they work, looking at the advancement over time of the management of surgical glaucoma. That was a great talk. Thank you very much. Are there any questions from the audience? I think you wowed them. I don't see any questions. Okay, thank you very much, Chris. I appreciate you being here and taking the time out of your day to be here. Hey, remember to let us know how we're doing with your detailed feedback. I'd like to recognize the hard work and cool-headedness of Mark Longenheim for his production of this program. Thank you again to Deb Osborne for fighting for CE credits for our ophthalmic technicians and taking this program from concept all the way to completion. And I hope that you, our technicians, have found this program helpful and that there's information that you can take away and make part of your team contribution in the care of our patients. Use that QR code to go to the website or to the test so you can complete the exam and get your CE credits. We hope that you'll join us for the next planned in-person meeting on June 9th. It'll be here at the AquaTurf, at least that's our plan. It'll be live, physical, unwired, and in person. So we hope to see you there. Thank you for spending your day with us.